Good morning, ladies and gentlemen, and welcome back again to the real conferences, virtual and physical. This is the ninth Pedia Dubai, and I hope that you will all enjoy it. Our first session, we'll start our first session now. Our first lecture will be presented by Professor Ashraf Abdelbaei. He is a professor of pediatric at Ain Shams University. And he's a senior consultant pediatrician, head of pediatric department in the Armed Forces College of Medicine, Cairo. He will be talking about personalization of pediatric asthma management. Welcome, Dr. Ashraf Abdelbaei.
Thank you very much, Dr. Abir, for this kind presentation. And I would like to thank my dear brother and friend, Dr. Sharif Mossad, for inviting me for this marvelous event and successful, inshallah. I'm very happy to be with you again because actually UAE is very dear to my self. And today I'm going to talk about something about asthma, which is a future of asthma management. We are going to tackle two important points today. The first point is personalized medicine. What is personalized medicine? Before we are going to talk about personalized medicine in pediatric asthma, we should take a brief about what is personalized medicine. And the second point we are going to tackle is what are the applications of personalized medicine in pediatric asthma. The definition of personalized asthma actually refers to a medical model using characterization of individuals' phenotypes and genotypes. So you must describe the phenotypic presentation, the clinical phenotypic presentation of the patient, and then the genotype, you are going to dig in to see the genes responsible for this phenotype. So you are linking gene to phenotype. And according to that, you will see this gene product. The gene product must be the target for the therapy. So targeting the product of the gene will stop the disease process. This is simply the personalized medicine. So you are not giving one drug, the same drug for all the patients, but rather you are going to give a specific working drug for each patient. It is important also, using this definition, it can be used also for prediction. The first situation was about the patient. The patient, you are going to define the phenotype and you are going to define the genotype and then the product of the genotype. What about the normal individuals? You can make screening for the normal individual, and if you find the offending gene, at that time, you can make strategy for following up this patient to prevent the disease to occur. So personalized medicine is talking about treatment of the patients, and this treatment is very specific for each patient, and also as well detection of early detection of the patients and prevention. So you are talking about prevention, early detection of the patient, and improved prevention. Then for the patient itself, how to diagnose it, accurate diagnosis, making phenotyping, and then improving the outcome by targeted treatment or targeted therapy. If you are going to see the literature talking about personalized medicine, you are going to be a little bit confused because there is another nomenclature, which is precision medicine. The precision medicine is a term used by the American in USA rather than Europe. And since the presidency of Obama, he was very interested in the precision medicine, and he made a huge project because this is a future project. And so the term precision medicine started to be used in replacement for the personalized medicine. However, in Europe, they are still using the term of personalized medicine. More or less, they are the same. Regarding the precision medicine, as we told you, that we are depending on defining the genotypes. Then you are going to see the product of the gene. Here comes what is called omic sciences. Omic sciences are a group of sciences working to define the product of the gene and the gene itself and how the environment affecting the gene. For example, we are going to see the genome. All of us are acquainted with the genome. And epigenome, so working on the effect of the environment on the expression of genes. And transcriptome, this is the transcription of the messenger RNA into proteins. Metabolome, the metabolism, or the metabolic effect of the gene expression. Proteome, this is the protein product of the RNA transcription. And microbiome. Microbiome, all of us know that the microbiome, the main microbiome we are talking about is the gut microbiome. Studying of the gut microbiome now become one of the very important aspects of studying precision medicine or personalized medicine, because it affects the metabolism, it affects the proteome, and it can affect also the epigenome, the expression of certain genes. All of these, we are going to put them into data analysis, and this data analysis will lead us to detect the specific therapy for each patient. And here we come to the personalized or precision medicine. So it's two aspects again. We have to remind ourselves two aspects. The first one, how to deal with the patient by detecting the phenotype and the genotype and the protein expressed by the genotype, and then detecting the specific therapy to stop the effect of the gene product. Regarding the asymptomatic or the normal population, we have to do screening for them to know if the gene is present in any of the individuals, of apparently normal individuals. Then we have to make a program for follow-up to prevent the disease. The current medicine we are practicing, all of us practicing, is about giving one drug for all patients. And a very good example is the bronchial asthma. Is to give the bronchial asthma patients the same medication. What happens actually when we give the same medication for all the individuals, that some of them will have good effect, some of them will have minimal effect or no effect, and some of them may have adverse effects. Because one size does not fit all. So the rule here is different. One size does not fit all. The future medicine we are talking about is we have to see the phenotypes, we have to do investigation, genotypes, and other investigation. The omics the omic science, and through this, we are going to personalize the therapy. So all of the patient will have a good effect. Now we can consider the era or the evolution of recent medicine. The first phase was intuition phase, starting from the 50s of the last century to the last 80s, which depend on, it's experience-based. And I think some of us are still working on the same concept, experience-based medicine. So my experience is telling me to do so and so. Then the whole world shifted from experience-based medicine to evidence-based medicine, starting from late 80s up to 2010. And this depends on the base, which is derived from randomized controlled studies. Then now we are in the era of precision medicine and the omic sciences that are enable us to make a target therapy, or what is called bullet therapy. It's a bullet therapy. All of us know the diversity of asthma. Asthma, despite that we studied asthma very well. All the world put forward many guidelines to deal with asthma. However, still we have considerable morbidity and mortality. The concept of asthma we have is very simple because we consider asthma one disease. Asthma is not one disease. Asthma is actually more than one disease. And recognition of the diversity of asthma and its molecular basis leading us to management in the 21st century. Have a look at this algorithm. This algorithm telling this is what's going on. This is the traditional medicine we have. Okay, so diagnosis, assessment of severity, avoidance of the triggers, and also the comorbidities, and a stepwise approach. This is the usual guideline process we are doing. In the future, we should consider, after diagnosis, to see the phenotype, what is called the endotype. The endotype is the mechanism of the disease or the pathogenesis of the disease in each individual. And then the genotype. So 3 important aspects should be considered, and this end with the omic sciences in a tailored therapy. The asthma phenotypes usually either observable trait like morphological, biochemical, physiological, behavioral trait, or clinical grouping for wheezing, like early, late, persistent wheezers, or difficult and severe asthma. Specific disease entity like atopic asthma or viral-induced asthma, this is considering the etiology or the predisposing factor. And this is an example when we are going to study the phenotype. One aspect of the phenotype is the phenotype, which is the etiology. It can be allergic asthma. It can be virus-triggered asthma. It can be also both together, allergen and virus-triggered asthma. And this is what was called multi-trigger. So it can be either pure allergic or only induced by viral infection, or it can be both mixed together, which is a multi-trigger. If we are going to study the endotype, so the pathogenesis, what's going on? The endotype of asthma. Not all of the asthmatic individuals have inflammation, as we said before in the definition of asthma. Some types of asthma have no inflammation in the airway, but the majority have inflammation, particularly during childhood. The majority having inflammation. And this inflammation can be eosinophilic inflammation, so you'll find infiltration with eosinophils, or can be neutrophilic inflammation. So you can find in the airway a lot of neutrophils. Sometimes it is mixed together. So you can find xenophilia and neutrophilia inside the airway. Each one of these consider separate endotype. And we're going to deal with these separate types as following. So we have here the allergic asthma, and then among the eosinophilic infiltration of the airway, there are two types. One type is allergic asthma, and the other type is eosinophilia, but with different mechanism. It is not involving T helper 2 cell, but rather it involved different cell, which is innate lymphocyte cell type 2. This is a newly discovered cell, one of the lymphocytes that are naive lymphocytes. They are not carrying the marker of the T or the B lymphocytes. And it was found that it has a role in eosinophilia, and it has a role also of regulation of the inflammatory reaction. So if we come to eosinophilia in the bronchial asthma, we have two types: the allergic type, the typical classic allergic type, and the one due to innate lymphocytic cell type 2. And on the other hand, the neutrophilic asthma, it is due to the reaction of T helper 1 cell with gamma interferon and production of T helper 17 cells, interleukins. And here, the non-inflammatory type, which is called polygranulocytic asthma. Here, I will not find any inflammatory cells, and there will be no inflammation. So the implication of knowing the endotypes will be reflected on the type of therapy that I'm going to produce for this patient. So for the allergic asthma, I'm going to use omalizumab, which is anti-IgE. And for the other eosinophilic asthma, which is not the classic allergic type, I can use the mepolizumab. Omalizumab, as I said, it is anti-IgE. Mepolizumab, it's working on the receptor. Sorry, it's working on interleukin 5, which is activating the eosinophils. So these are two types of therapy that can be used. It is very targeted therapy, very specific. Also, for the non-inflammatory type, if you are going to use a steroid here, it will not be effective. So you have to stop steroid. And this is the only type of bronchial asthma that you should not use steroid. And instead, you can use tiotropium with a long-acting effect, anti-muscarinic effect. It acts on the muscarinic receptors starting from M1, muscarinic receptor number 1, up to muscarinic receptor number 5. So the wide spectrum effect on the muscarinic receptors. And it is long-acting. It's taken once daily. And now, a lot of studies have been done on pediatric age group. It's working very nicely. The neutrophilic asthma, here comes the role of antibiotics, particularly the macrolides, okay? So we saw already how defining the endotype can affect the type of medications. Here we come some papers about the genetic basis. The last one is the gene examination, the genetic basis for personalized asthma. And here also we can see the different asthma drugs, whether leukotriene modifier or corticosteroid or beta-2 agonist. Studying the gene, It is gene study for these drugs and defining how it works and defining the product of these genes and how to act directly on it.
3 more minutes.
Okay. So here is a precision medicine, and here are the discoveries of the effect of the gene and gene expression and gene products on some aspects of the medication. And so here is a sequence. We now going with no patient selection treatment. The second step, we are going to enter the clinical phenotyping, then targeted treatment, then the molecular phenotyping and targeted treatment, then the precision medicine expected on the 2025. And here is a study about the mepolizumab, basic mechanism and how they are working. And the key points by the end, this is the last slide. Personalized medicine and precision medicine are often used as synonyms. They're the same, but actually have slight meaning difference. Personalized precision medicine would bring better treatment strategies, and treatment strategies, what's called bullet therapy or targeted therapy, will actually change the outcome of the bronchial asthma. The phenotyping and the endotyping process and the utilization of predictive biomarkers, which is a product of the genes, can contribute with the omic sciences we have just talked about in reaching the goal of good asthma treating. And thank you.
Thank you, Professor Ashraf, for this excellent presentation and update information. And now the next speaker will be Dr. Sharif Mus'ad. All of us, we know him. He's the chairman of this conference, and he's a consultant pediatrician, and he's the head of Department of Pediatric and Neonatology Department in Amina Hospital, Ajman. He will be talking about a new disease now, which emerged in this corona year. It's about multi-system inflammatory syndrome in children. Welcome, Dr. Sharif.
Welcome. Thank you, Dr. Abir. Good morning. Thank you for coming to Pedia Dubai, and I hope you enjoyed. And it is very difficult to speak after Dr. Ashraf Abdul Baqi. Yeah, he's and I try to. I cannot say I'm a student because Dr. Ashraf is still young, but really he's my senior, and Dr. Abir, she's my former head of the department. So thank you for all. And today I will speak about very important topics right now. It is up to date, and it is related to the coronavirus infection. You know that the coronavirus, it is started in December 2019, and fortunately, we are thinking that the children, they are safe and they are not infected by this virus, but unfortunately, this is not the truth. So it is children can infect with coronavirus. Of course, it's less than the adult, but they have later on complication. It's called multi-system inflammatory syndrome. And today we will speak about that one. So today the aim of our lecture, we will speak briefly about some facts about the coronavirus infection terminology, and we'll review the clinical presentation of the myth and hypothetical pathogenesis and proposal management. So this is a history of the coronavirus. All we are know, it is starting in 2002 by as what's called severe acute respiratory syndrome, and it was in the China. Then later on, it is coming to Saudi Arabs mainly, and they are 2012. Then it is an COVID or SARS-CoV-2 virus infections from December 2019. And everybody, they are not recognize this is COVID or this is SARS. The virus itself, it's called SARS, severe acute respiratory coronavirus 2, and the disease is called coronavirus disease or COVID-19. So severe acute respiratory syndrome, coronavirus 2 infection rapidly spread worldwide since it was first identified in China in the late 2019, with suspected epicenter being recognized in Europe and US. Previous report of SARS-CoV-2 infection indicate that the young children were disproportionately spared from infection, as we said. The incidence it is less than maybe 3%. In the later half of April 2020, a novel syndrome in the children and adolescents termed as multisystem inflammatory syndrome in children with likely relation to SARS-CoV-2 infection was the first described. The initial report surfaced in UK and Italy, followed by New York and other parts of the US, and even everywhere in the world right now, in Egypt, UAE, and Saudi Arab, Oman, everywhere. Preliminary accounts of this feature of the syndrome resemble that of entities such as Kawasaki disease, toxic shock syndrome, and secondary hemophagocytic histiocytosis, macrophage activating syndrome. So it looks like an post-infectious or immune dysregulation. So we have reviewed the preliminary data regarding the clinical presentation and publication of MIS and Kawasaki. So this is a coronavirus, as you see here by the electron microscope, and we will see the structure now. We can zoom it. This is the coronavirus. We are called corona because it looks like round with the spikes. We will see what is important of this spike. We will take one and we will see. So this is a single strand RNA and provided with crown-like spikes of the outer surface. Its diameter is 65 to 125 nanometer, has 4 main structural proteins, including the spike S. This is a spike protein, and a small envelope and membrane and protein, glycoprotein and nucleocapside. The most important is an S protein. This is a one, and four homotrimer protruding in the viral surface and facilitating binding of the envelope virus to the host cell by attraction with angiotensin converting enzyme 2 expressed in the lower respiratory tract infection. So this is the one, it is expressed in the lower respiratory tract infection, and as we can see here. And you imagine how the weight of the virus all over the world. Now we are reaching more than 60 million all over the world. And if we are weighting the virus, and it will coming only 10 grams. And so it is 10 grams all over the world right now. So this is a very important slide. We can see here what is the stage of the virus. The virus, it is coming inside the cell. It is an alveolar cell type 2 by binding to ACE receptors. Then it's coming inside the cell. Then it is releasing the RNA. It will replicate. Then by exocytosis coming outside. Then at that time, the immune system started to release what's called the cytokine, and we will go to what's called the cytokine storm. So this is a steps, 3 phase. Entrance of the virus through the nasopharynx, then to the lung. This is the first stage. Second stage, replication, and third stage is an cytokine storm. Fortunately, the children, they have less infections because they have less gene expression of the ACE2 inhibitor in the lung. The ACE2 inhibitor, by the way, it is not only in the lung and alveolar cell type 2, it is also present in the heart and present in the GIT and kidneys. That's why they are making that what's called multisystem inflammatory syndrome. So this is what happened. This is an early stage. It is coming inside, and then it is releasing the virus coming inside the cell, then the stimulating of the T cell and B cell, and it started to secrete interleukin 1 and 6, and it will damage also in the wall of the alveolar cell type 2. You know, all alveolar cell type 2, it is responsible for secretion of surfactant. So if the surfactant is not secreted, it will make what's called respiratory distress. This is a history, and we can skip it. This is a transmission of the virus, and this is a mode of transmission. As we know, it is a droplet infection mainly, and it is one person to one person, and it is less than 2 meters. And the mode of transmission by coughing, sneezing, and checking the hands, rubbing the eyes, and the close contact. This is how you can protect yourself by wearing the mask. And if you are both the patient and the exposed person, it is covered by the mask. So the rate of infection is very less, 1.5% only. So till yesterday, this is an statistics all over the world. It is 68 million all over the world, and this about 1.5 million, and recovered is 47 million. Fortunately, the incidence of recovery it is high now. So let's go quickly about what is called MIS, or multi-system inflammatory syndrome. The multi-system inflammatory syndrome, it is appear as you can see here in the slides. It is in the April. They said Corona alert, a rare syndrome seen in the UK in the children. Some children they are severely sick, and the pictures looks like Kawasaki or toxic shock syndrome. So it is first identified in the mid April or late April, 27th of April 2020. So starting in the May 5, the Royal College of Pediatric and Child Health put the guidelines about that, and they said there should be a low threshold for referral for pediatric intensive care using normal pathway. So because this is starting the new syndrome, and we have to discover early and start treatment. So in the Gulf News, I published this articles about that time, and there is no coronavirus infections right at that time, but unfortunately some cases start to appear in Al Qasim Hospital. I think about 5 or 6 cases, or in other place. So the prevalence of MES in the US, for example, we'll take it because it is it appears in the area with the incidence of infection by corona is high. So in the US, they are from 1 year up to 20 years of age, as we can see here. And this is how much is the percentage of the infection among these children. So it is about 186 cases discovered in April and May, and it is distributed all over the US also. And if we can see here, the peak of the MES, it is after the 4 weeks from the infection by corona in adults. So it is late response to the coronavirus, not due to. Let us remind ourselves about what is the Kawasaki disease. It is an acute medium vessel vasculitis with predilection for the coronary arteries that occur more commonly in the younger children, and it's more common cause of the acquired heart disease in the children in the developed country. The Kawasaki disease defined feature including rash and cervical lymphadenopathy, and ocular and oral mucosal change, although the involvement of other organs such as the liver, lung, gastrointestinal tract, and central nervous system and joint is widely recognized. But it's mainly the rash and also change in the periphery, and glossitis, and also there is an edema or redness in the upper and lower limbs. Okay, and the lymph node, cervical lymph node enlargement. Similar to MES, that the Kawasaki disease laboratory marker of the inflammation such as CRP is increased, but it is increased more in multi-system inflammatory disease. Hematological abnormalities are slightly different, as a patient with the Kawasaki disease tend to have leukocytosis with neutrophilic predominance and thrombocytosis. But in MES, it is in the reverse. It will be, there is lymphopenia and the thrombocytopenia. So this is also different in hematological finding. The cardiac finding in MES is also divergent from Kawasaki disease, as MES patients are more likely to exhibit cardiac dysfunction and hypotension as opposed to coronary artery. It can making what's called myocarditis and the pericardial effusion and even affecting the coronary. But in the Kawasaki disease, it is mainly in the coronary artery. So this is the Kawasaki disease, as we said, there is a sign and symptom. And this is the main problem of the Kawasaki, that is a coronary artery dilatation, and it is affecting about maybe 2 to 3% of the total Kawasaki disease. So is the Kawasaki disease linked to COVID-19? No, it is different. This Kawasaki disease is different, but the clinical picture is the same. As you remember, the Kawasaki disease, it is mainly up from 6 months to 5 years of age. But in MES, it is from even birth till 19 years of age. So it is even older. This is a clinical picture in France and US. You can see here the mucosal change. It is like Kawasaki in 76% in cases, conjunctivitis in 81%, rash 76%, and extremity change 48%, and cervical lymph nodes. So it is most like Kawasaki, but of course it is different. So what is the relationship of MES to the COVID and pathogenesis? As we said, the emergence of the cluster of the case locations between the heavily impacted by COVID, such as Italy, UK, and New York. So it is commonly or discovered early in the area that is heavily infected by the COVID. This is suggestive, the link between SARS and MES. The case series from Bergamo, Italy, and the region with high incidence of COVID-19 disease described a 30-fold increase in the monthly incidence of Kawasaki disease between 18th of February and 20th of April in the comparison to the previous 5 years. So the incidence of Kawasaki disease is 30-fold in less than 2 months. And this is, of course, must be related to something, and I think it is sure related to the COVID infection. And this is a relationship with the MES and COVID and pathogenesis, and this is an important slide also. You please concentrate on this slide. This is the stage. We have, as we said, 3 stages. Stage 1, it is an infection and the virus is go to the nasopharynx. Then after that, it is there is no pulmonary infection at that stage. Then the virus go down to the alveoli and it is entered as what's called sober infection, taken by the macrophage, helper T cells. Then it is secreted the tumor necrosis factor and interleukins 12 and 6. This is a cytokine release, isolation. Then it is coming outside the virus. It is making what's called the 3rd stage. It is a cytokine storm, and it affects most of the tissue. The children escaping the pulmonary phase. The pulmonary, they are only infection from the nasopharynx. Then they are skipping the pulmonary phase. As we said, it is due to the less receptor of the ACE inhibitor in the children in the lung. So early infection phase 1 with the SARS is likely to be asymptomatic. In the children, the pulmonary phase 2 is severe in adult, but it is mild or absent in many children. The early infection appears to be triggered macrophage activation followed by the stimulation of the T helper cell. This is internally to cytokine release, as we said, and the stimulation of the macrophage, neutrophil, and monocyte, along with beta cell and the plasma cell activation with the production of the antibody leading to hyperimmune response or stage 3. So this immune dysregulation, it is associated with the inflammatory syndrome in affected children, and the infection with the SARS-CoV-2 is less likely to play a role in the MES. So not direct infection, it is immune dysregulation. And this is also important side, identifying what is the role of the load of the virus, that this is a infection of the virus. If the early infection, there is interferon response and rapid viral clearance and less inflammation, is mild disease, because the viral load here, the blue line, viral load is less. But if viral load is high, so there is delay interferon. That interferon is an antiviral, or it can suppress the viral activation and the slow viral clearance and none of more inflammation and severe infection. So the virus load, it is important. And this is the same also, and this is the management. We have to see here, this is a mild form, and this is a severe form of the viral load by the red one. If it is mild, so the lymphocytes, it is recovered quickly, and also there is an rapid recovery. But if the load of the virus is more, so at that time, at the first times of infection, we have to give antiviral. And the second stage, you have to give the anti-inflammation as an interleukin 1 or 6 inhibitors and supportive care, of course.
3 more minutes.
Okay, less than 5 minutes to finish. So this is an WHO definition of multi-system inflammatory syndrome in the children. All the 6 criteria must meet. The age from 0 to 19 years, fever more than 3 days, and clinical sign of multi-system inflammatory syndrome, at least 2 of the following: rash, bilateral, non-virulent conjunctivitis, mucocutaneous inflammation, hypotension or shock, and cardiac dysfunction, pericarditis, valvitis, evidence of coagulopathy, prolonged BTT, elevated D-dimer, and acute gastrointestinal symptom. It is presented mainly by acute gastrointestinal symptom and can lead to appendicitis-like picture. Elevated marker of inflammation is CRB and procalcitonin, no other obvious microbial cause of inflammation. And evidence of SARS-CoV-2 infection and any of the following: positive SARS-CoV-2, positive serology, positive antigen test, and contact with individual. So not necessary, if you make a swab, it will be positive. Most of the cases negative, but if you do the antibodies, it will come positive. If the PCR test is negative in spite of highly suggestive picture, proceed to IgM and IgG test. And this is, again, the world WHO definition. And this is a picture of MES. As we see here, the rashes and in upper and lower limbs, and glossitis. So what is the MES symptom? It is fever, GIT inflammations, because as we said, the ACE2 inhibitors receptors, it's mainly in the GIT in the children. Myocarditis 75% by echo and 100% by lab, and pharyngitis, neurological manifestation, and rash and shock. This is a cartoon show the picture with a fever, myalgia, headache, high ESR, C-reactive protein, hypoxemia, thrombocytopenia, nausea, vomiting. So it's multi-system failure. And this is a list of investigation we have to do as a CBC, CRB, ESR, and procalcitonin. So a long list of investigation, D-dimer. And this is a clinical and laboratory features. As we said before, fever more than 38.5, and oxygen requirement and hypotension, abdominal pain. So this is a review, and this is a comparison of the laboratory feature by MES and Kawasaki disease. It is same, but as we said in the start, in the CBC, there is thrombocytopenia and lymphopenia in MES, but in the Kawasaki, it is the reverse. And this is coronary artery aneurysm in MES, and this is before treatment, and it will also can be managed. So this is a MES versus Kawasaki. This is, we can see here, this is a picture of the multi-system inflammatory can affect any part of the body, kidneys, lung, heart. But in Kawasaki disease, it will not the same. So lastly, what is the treatment protocol? The current treatment of MES is a similar protocol to used to treat Kawasaki. The goal is to reduce inflammation to avoid long-term damage to the artery in the child. High dose of IVIG, typically 1 to 2 milligram per kg, and low or moderate dose of glucocorticoid, or high dose of IV pulse in the severe case in the life-threatening complication. Anacrina, this is an interleukin-1 inhibitors, and it is used in some cases. As we said, it is a cytokine storm, so this is reduce the cytokines what is released. So as we said, the IVIG, aspirin can be given also 30 to 50 milligram per kg per day, and the dose should be reduced to antiplatelet dose 3 to 5 milligram when the fever subsides. And corticosteroids, we are using dexamethasone or 2 milligram per kg prednisolone. Uh, what is the mechanism of the IVIG? As we know that generalized anti-inflammatory effect, modulation of cytokine, neutralization of the toxin, augmentation of regulatory T cell, and suppression of the antibody synthesis. So this is again the treatment, and we will what is the protocol of the treatment in general and for that mess? We can give antibiotic azithromycin, hydroxychloroquine, ceftriaxone, steroids, anticoagulant, and tocilizumab and infliximab. We have to monitor, of course, most of the cases are managed in the ICU, about 80%, but 20% of the cases can be managed in the ward. And also, the mortality rate is very less. Mortality rate is maybe 1 to 2% only, fortunately. And the incidence of MIS all over the world, 0.014% from the infected case. So, for example, if we have 9,000 baby infection with an corona, only maybe 70 or 80 cases. So this is a therapeutic of mild and moderate and severe, and we can, all of them, they are taking methylprednisolone. This is my picture in the ICU during the pandemic. So we can conclude severe acute respiratory syndrome infection may result in multi-system inflammatory syndrome in children. The clinical presentation of MIS, including fever, severe illness, and the involvement of the 2 or more organ system in combination with laboratory evidence of inflammation and laboratory or epidemiological evidence of SARS-CoV-2 infection. Some feature of MIS in the children resemble Kawasaki disease, toxic shock syndrome, and secondary hemophagocytic lymphocytosis. And the relationship of MIS and SARS infection suggests that the pathogenesis involves post-infectious immune dysregulation. Patients with MIS should either be managed in pediatric intensive care environment since rapid clinical deterioration may occur. A specific immune modulation therapy depends on the clinical presentation, the relationship between immune response to SARS vaccine and development and MIS requirement further. So this is a clinical picture. It must be appears to be rare and may show up to a week after COVID-19 infection and cause inflammation across multi-organs, including heart, lung, kidneys, skin, and eyes, and produce varying symptoms in the children, but they may include fever, abdominal pain, vomiting, neck pain, rash. And thank you very much.
Thank you, Dr. Sharif, for this excellent and comprehensive presentation of the MIS in children. And now, because we passed the time, we have only 5 minutes for discussion. So whoever wants to ask a question, and those who are attending virtual, they can send their questions online, and then it will be answered by the speakers. Yes, now there is the third lecture in the first session is a virtual. It will be virtual. It will be presented by Dr. Serdar Usturk. He will be talking about IMD.
Thank you. My name is Serdar Usturk, and today it's not also, I would like to start by indicating that it's not easy to speak after the previous presenters because they touched upon very important disease like the COVID-19. And today I would like to switch to another important disease, which is invasive meningococcal disease. And for the next 15 minutes, I would like to try my best to say 5 minutes to focus on the main particular importance of the invasive meningococcal disease and why we need a broad protection to prevent against that. So I'm a full-time employee in GlaxoSmithKline. My name is Serdar. I have a PhD in public health, and I work in the university and academia. And I've been in GlaxoSmithKline for more than 10 years, and I'm responsible for sharing the latest scientific data with the esteemed healthcare providers like you. So it's a great honor for me to being part of today's call. And thanks a lot for giving us this opportunity to share this really important and deadly disease and the consequences. But I mean, this is the flow of my presentation. First, I would like to focus on meningococcal disease characteristics, and then focus on epidemiology and the need for vaccination. And of course, today it's a promotional event, but my main ambition is not to convince you to use our product. Maybe it's a paradoxical, but let me start. What's my objective today? My objective is to highlight the importance of this deadly disease, an important disease, and to try to convince you that you have multiple options as a vaccines to prevent this disease, and to highlight that what will be the membrane look like and what are the options. And again, at the end of the day, as a healthcare provider, it's your and our responsibility to help our people to prevent against this important disease. And let me jump on, what is the invasive meningococcal disease? Well, there are two main clinical forms. First is the meningococcal meningitis. As you can see in here, it's the most common presentation. But basically, it's a half of the presentations linked with the meningococcal meningitis. It occurs after bacteria cross into central nervous system, basically. And it's a classic definition. And the second one is the meningococcal septicemia. Well, it's around 1/3 of the cases, I can say that. And it's an infection and multiplication of Neisseria meningitis in the blood. But on the other hand, I would like to take your attention on the right-hand side of the slide, and you can see there are some other rare form of meningococcal disease, such as pneumonia, arthritis, otitis media, and even in the less common presentations. But before continuing here, I would like to stop and to remind you, this is the latest paper coming from UAE. The authors are Fatma Mohammed Mahmoud and Tana Arara. They're from Sheikh Khalifa Medical City, and they just publish it. It's an interesting finding that Neisseria meningitis pneumonia without bacteremia, with bacteremia, without meningitis. It's an atypical presentation, I totally agree, but I think they publish one of the best case reports, and I heavily recommend it. This is a really interesting paper, just published in June 2020. It shows that this disease exists everywhere, even in the rare forms. And again, I would like to highlight, this is Neisseria meningitis pneumonia case report without meningitis. So, okay, what's the important in here? What's the important deal in here? It's the carriage of Neisseria meningitis. Okay, we know that Neisseria meningitis attaches and colonizes the surface of the human nasopharynx. You can see in here. And in many people, colonization with Neisseria doesn't cause any symptoms. And this is called a carriage. And well, again, duration of asymptomatic carriage varies from days to months. We know from the multiple studies. And at the end, prevalence of carriage is around 10%, but it changes depending on the country, depending on the immunization program. But we know that also it depends on the age. And we also know that incidence is highest in the adolescents, around 22 to 25%. And lower incidence is observed in infants and also adults. Okay, Neisseria meningitis can spread from nasopharynx to the brain, and colonization is one of the important entry point in the important factor in here, and it might penetrate to the mucous membrane. And then in some cases, we know that penetration of the blood-brain barrier occurs, and also spread and multiplication in the bloodstream, giving rise to the invasive meningococcal disease. Okay, why is meningococcal disease is a serious disease? I would like to give you 4 reasons for that. Of course, you can increase these reasons, but I mean, number 1, it's very challenging to diagnose. Number 2, there's a rapid disease course, and you know that in the first 24 to 48 hours, there's a really quick and prompt progression from initial non-specific disease to a really deadly and also important outcomes. High mortality levels. Without treatment, more than 50%. With treatment, 5 to 10%, there's a risk of mortality. And the last but not least, significant morbidity still exists. And 1 out of 5, or around 20% of the survivors, they are going to have or they may have a sequelae. So, I mean, let's go in the wide challenges in diagnosis. I would like to highlight three multiple factors in here. Number one, it's related to healthcare challenge. It's very frequently misdiagnosed as a flu because of the uncommon, I mean, it's very common symptoms. And meningitis is not suspected because we know that it's rare. So you don't put in the diagnosis prioritization. And also, it's really challenged because patients don't turn up if you talk about the children's, that there will be no follow-up or no surveillance. It's also microbiologically challenged because Neisseria meningitis is a fastidious organism and it's difficult to culture. And if you're looking for a technical challenge, lack of PCR and low skill set and the experience, this could be one of the reasons in the challenges on diagnosis. And I will give you an example for that. The culture and the role of culture plus a PCR, you can see the using PCR, it definitely six-fold increase the diagnosis. But in case of antibiotic usage, especially we have to use an empirical antibiotic without waiting no more and saving the children's or the people's life, then it causes that 80% reduction in the culture. And then you are losing your chance to identify what will be the pathogen. So, and this is related with the rapid progression from non-specific symptoms to death in 24 hours. In the first 8 hours, it starts with the non-specific and flu-like symptoms, and easily it can transform from 9 to 15 hours. Some classic meningitis symptoms might occur. And again, I was graduated from the medical school many years ago, and at that time they were saying that hemorrhagic rash will be very pathognomic. You have to know it. I agree. But on the other hand, the recent studies from India and many countries, they show that it's not as frequent as we thought. It would be around 20% or 30% of the cases you might see hemorrhagic rash among children. So therefore, although it's a pathognomic, but this could be neck stiffness, photophobia, or maybe cold hands, feet. But after 15 hours, between 16 to 24 hours, it may progress from non-specific symptoms to death within 24 hours. That's the risk. Very rare, but it could be fatal. And if you look for this impact to compare with the other vaccine preventable diseases, and I would like to highlight with the help of this slide, this is the estimated case fatality rate in percentage. You can see meningococcal disease can represent the exceeding 10% fatality rate, which is the highest among the other vaccine preventable diseases, such as diphtheria, pneumococcal pneumonia, or polio, or pertussis. So what's the mortality? We talk about mortality, let's talk about morbidity. It could be limb loss or digital amputation, or hearing loss like a sensorial consequences, or systemic one, chronic organ damage and the arthritis. So these are the important, and we know that about 10 to 20% of the survivors will have a long-term consequences, disabilities such as loss of limbs, deafness, or nervous system problems. These are the really important consequences. Okay, why we need a vaccination in here? Several populations are at increased risk of meningococcal disease. Infants, healthcare personnel, military, adolescents, we know that. And travelers and also pilgrims, Hajj and Umrah, you might be exposing yourself as a risk of meningococcal disease. And we know that the most frequently affected population is children under the age of 5. Depending on the geography, you can see it could be majority, it could be minority, but there's a substantial number of children needed to protect against invasive meningococcal disease. And if you're looking for the entire picture in here, it covers multiple countries from the different part of the world, including Canada, Japan, Europe, Turkey, Saudi, Australia, South Africa. You can see a different group of Neisseria meningitis exists in the different part of the world. In short, there are 13 types of Neisseria meningitis serogroups, and the 6 of them are the only causing disease in the humans. And we know that it's A, B, C, W, Y, and in some cases X or the non-groupable ones. And we have vaccines to protect against this. But you can see that we cannot say that there's a one serogroup dominates across the world. It's not the case. And also I would like to highlight that these snapshots, it's not easy to compare. It's like an orange and apple, because if you look for the same country in the different timelines, it's like a taken picture in 5 years' time. And you are going to see yourself is changing and developing, which is exactly happening right now for the invasive meningococcal disease as well. You can see in United States, Brazil, Colombia, and Czech Republic, in the different time zones, same country with the same infrastructure, you can see the B is increasing, CW is increasing in Brazil, and also B and C increasing in Czech Republic. So you cannot say that with the help of one study and one surveillance snapshot, you would never say that this is the case. It's going to be dynamic process, it's going to be changed, and it's unpredictable. So that's why I postulate that there's a need for broad coverage with the MenACWI vaccine. And this is another paper. It's a little bit an older paper. It's published in, if I'm not mistaken, 2007. But it definitely explains. It's coming from UAE, and also it's highlighted the epidemiology in meningitis in Al-Ain, and you can see it's a rare disease. They estimated that it's 1 per 100,000 in 2005. Is this the case as of today? I don't know, but at least it shows that meningococcal meningitis seen with a different group of people, and it's an interesting people. It's an interesting paper. And currently, MenACWI vaccines are recommended in 30 countries globally. And these are the list of 30 countries in here. These are the 30 clinical recommendations. And if you're looking for the Membeo, our product in the MenACWI, again, it represents more than 10 years global experience, distributed more than 58 million all over the world. In 60 countries, we are available and approved, and around 50,000 subjects participated in our clinical trial R&D program in the different age group. And in the 60 countries we are available, it's the only meningococcal vaccine available both in Europe and US. It's in the NIP program of Argentina and Switzerland. Well, I would like to share with you that in the last couple of years, we had to share the immunogenicity results only related with the multiple vaccines, especially in the rare care disease, because when you are going to launch a product, of course, you have to wait multiple years to receive a real world evidence. And until that time, in all these products, they can get their application and the approval process with the help of immunogenicity results. But for today, thanks to experience, I would like to highlight that Membeo is a unique vaccine to represent a successfully studied high risk and high transmission groups, such as in travelers and such as individuals in the dormitorium living in the close proximity. And I would like to share with you that some results coming from Membeo. It's coming from Poland. In the army, they vaccinated a military unit and they reduced carriage an 8-fold. And also in UK, after the implementation of the adolescents, in the reduction they saw in the nasopharyngeal carriage, it's 36%. And this is another interesting paper coming from South Korea. They basically vaccinated 1.5 million subjects with the one shot of Membeo in this high transmission group, because it's coming from army, they are living together in the close proximity, and they reduced the incidence rate of invasive meningococcal disease by 88.24%. No safety concerns, no deaths, and no ACWI cases. So it's a really great observation. It's a comparison of pre-vaccination period and the post-vaccination period and the incidence rates comparison. And if you compare 0.52 drop to 0.06, then it definitely becomes an 88.24% reduction 4 years post vaccination program. So in summary, I would like to highlight that invasive meningococcal disease is definitely important contributor. It's an important disease. We should be really looking after it and careful about it for the diagnosing. It's very frequently misdiagnosed as a flu. And there are 30 clinical recommendations in favor of use MenACWI. If I'm not mistaken, in UAE is also recommended for the people at the age of 15 or 18. But also, I would like to highlight that the majority of the population affected by invasive meningococcal disease is children under the age of 5. And we are representing it here more than 10 years of clinical experience in worldwide and strong evidence on immunogenicity and robust safety profile. For the sake of time, I'm not representing, but I'm here to answer all questions you can ask. And last but not least, for me, the proactive prevention can save lives. And I would like to again summarize, these are the overall numbers. Common adverse events, of course, safety is important. In the placebo-controlled trial, it shows that most frequent in the children under the age of 5, irritability. In the adolescents and adults, headache is the frequent adverse event. And you may see the others, but it's approved for infants with high-risk iris conditions, and it works in the all age groups, travelers, and the healthcare workers as well. So generally well tolerated, I would like to highlight. And my last point would be, this is the abbreviated prescribing information in UAE. If you have any further question, you can ask our colleagues in the company. They can provide the details for that. My last point I would like to highlight for the sake of time, vaccines do not save lives. And instead of putting the living at the shelf, we should turn vaccines into vaccination, because vaccination can only save lives. Thanks a lot for your attention. Thank you.
Thank you, Dr. Serdar, for this excellent presentation and for just being stick to the time.
Thank you.
And now we'll have the panel discussion. It will be only for 5 minutes because we are very short of time. So, yes, we'll ask the speakers to come. Please. Yes, regarding precision medicine and asthma cases, when do we go to this precision medicine? In the first presentation or those for persistent severe asthma? And how costly is it?
Thank you very much, Dr. Abi, for this intelligent question, actually. As I told in the presentation, the role of the precision medicine start from screening the healthy individuals and discovering the one who is vulnerable for the disease and preventing the disease. Then if we come to the patient should be also phenotyped, genotyped, and accordingly will be targetedly treated. Could we apply this now? No, this is the future. Now we can apply this only for the severe cases, because usually we are left with about 5% of the asthma cases severe, it's 3 to 5%. Severe, not responding to the usual treatment. So at that stage, we should resort to this precision medicine. It is still expensive because it is a new technology, but what is expected by 2025, that will be much cheaper, and it will enable us to treat a bigger ratio of the patients. Thank you. Thank you. I understand that you are asking about the endotypes, and in general, let me just to summarize the situation, that most of the types are inflammatory, okay? And the only type maybe that is not associated with significant inflammation is the polygranulocytic type. The polygranulocytic type occur in children, particularly in the stable status. If the patient is controlled well, you can find a reasonable proportion of them having polygranulocytic state. But during activity or during symptomatic period or during exacerbation, you will find the majority will be eosinophilic. Expression of the sputum usually is an initial step, but you can go for bronchoscopy sometimes and bronchoalveolar lavage in order to recover the true cells from the airway. And also the blood eosinophil count. So we are depending on both. Sometimes you can find either eosinophils or neutrophils, as we said. And the endotype of neutrophilic count, of neutrophilic dominance, may be due to some sort of bacteria or bacterial infection or contamination. So if we are concentrating on the eosinophilic type, as I said, the eosinophilic type is two types, two subtypes of eosinophilic type. The first one is a real classic allergic reaction, which is depending on T helper 2. And the second one is depending on the innate lymphocytic cell, which is alternative pathway. And actually, the response of the patient to the steroid, the one mentioned in the guidelines, and the stepping up of the steroid will be effective in this situation. So the eosinophilic patient can be treated as usual with the guidelines, with the stepping up, so we can reach the control. If it's not controlled, we can use one of the biologic therapy I mentioned. So this is regarding eosinophilic. I hope that this is answering the question. Dr. Musa.
You can use a mic. You ask about one test to diagnose MES? No, it is, you know that it is, there is not only one test. It is clinical presentation. It will not pancytopenia. It will. There is no single test to diagnose MES. It is as you see, it is a long list for investigation. You have to do it to diagnose. First, you have clinical presentation. The patient is having the clinical presentation like Kawasaki-like. It is a fever for at least for 1 day. This CDC, they said fever 1 day. Then the WHO, they said more than 3 days. And also there is a history of contact to COVID patient for 1 month back of 4 weeks. And if you do the PCR, you have to do the PCR. Some patients are positive, and if negative, you have to do serology. I have one patient like this. It was classic, and we did swabs. It came negative, but antibodies came high. So that means it is having previous infection to the COVID. This is number 2. Number 3, you have to do CBC. CBC, you will see lymphopenia and thrombocytopenia. Also, D-dimer, it will be high. And also C-reactive protein and procalcitonin, it is high. So with this, at least CBC and D-dimer and ferritin also, it is high. Ferritin will be also, it will. No, most of the inflammatory marker, it will be high. Most of the inflammatory ESR, procalcitonin, BNP, Sometimes cardiac enzyme also high if the heart is affected. So I cannot say to you only single test can differentiate. So you have to do long list of investigation because this case it is not a joke. It is not managed early by IVIG and the steroids and that regimen we are said, and even in the ICU, I said 80% of the case need ICU, pediatric ICU admission. So if you are not diagnosed early and give treatment early, it will lose the child. No, to diagnose miss, must be there is no evidence of other infection. So there is no, this is one of the diagnostic criteria. You have to rule out comorbidity or there is current infection. Because as we said, it is an immune dysregulation. It is not an acute infection by itself. It is the problem in the immune system. The immune system, it will be what's called cytokine storm. Yeah, so it is not a single test we cannot diagnose. Thank you, thank you.
Welcome everyone on gut microbiota modification. My name is Hania Szajewska. I'm professor and chair of the Department of Pediatrics at the Medical University of Warsaw, Poland. My scientific card belongs to ESPGHAN, European Society for Pediatric Gastroenterology, Hepatology and Nutrition, to ISAP, International Scientific Association for Probiotics and Prebiotics, and also to evidence-based medicine. Let me start with this quote: "It's better to be rich and healthy than poor and sick." And it also applies not only to life, but also to microbiota. It's better to have a rich and diverse microbiota and be healthier than poor microbiota and be sick. And this is because if you look at the features of normal gut microbiota, I mean normal, which is health associated, you see that this richness, diversity is important. Increased species richness, increased diversity, high gut microbial gene richness, and resilience and stability over time. These are the features of normal gut microbiota, even if there's no consensus into the detail, but this is generally what is considered. So diversity matters. On the other hand, there may be the dysbiosis, and again, there is no consensus what does dysbiosis means, but usually this is a change, imbalance, so there are changes, alterations in the gut microbiota composition, but also in the function. And by now we know that almost every disease, when you talk about the pathophysiology, then dysbiosis is being contributing, hardly ever as a single factor, but definitely contributing to the pathogenesis. We also know that gut microbiota changes across the lifespan. And this slide shows you the evolution in terms of richness, which is so important, and diversity, starting from pregnancy and prenatal life. Of course, a lot is happening from birth to 2 years. Then it's more or less stable during adulthood and the elderly. Again, there is reduced diversity with all its consequences. There are many factors influencing, shaping the gut microbiota, again, throughout the life. I will not discuss all of them. I just want to focus on one of them. And these are antibiotics. Definitely one of the biggest discoveries, greatest discoveries of in medicine, saves lives. However, we do have problems, and this is overprescription of antibiotics. In the United States, approximately 25% of hospitalized children get antibiotics that they don't need. And these are very recent data from 2020. Other data, just as an example, from New Zealand, recent study, 2020, at least one course dispensed to more than 82% of children during the first 2 years of life. So we do have a problem. and with overprescription of antibiotics. There were just two examples. Another example, 33 to 39% of women are administered antibiotics during delivery. And it's not without the consequences, because if you look at the gut microbiota, then you will see this reduced abundance, mainly of fecal bifidobacteria during the first weeks and months of life, with the consequences on the number of diseases. And as a matter of fact, together with my colleagues from my department, from our colleagues from the Netherlands, we look at early life antibiotic exposure. And by that, I mean early life, I mean during pregnancy and during the first 2 years of life, and risk of diseases. We now published there are 4 papers based on these various systematic reviews. And what is documented are the association between prenatal antibiotic exposure and infant antibiotic administration and childhood allergies, but also overweight and obesity. We did not find it for other conditions, but others, and this is a very recent paper from the United States, more than 14,000 children, of whom 70% again received at least one antibiotic prescription during the first 2 years of life. And you will see that there's associations of this early antibiotic exposure with a number of outcomes, such as asthma, allergic, atopic dermatitis. So again, what more or less I showed you previously. So we do have a problem. And other factors, there's a number of other factors, but I would not discuss it in details. And antibiotics are not the only drugs that affect the gut microbiota. Many others, and when we are speaking about pediatrics, it's definitely the proton pump inhibitors, the use of which, overuse, may be problematic. And as I said, there is a number of other factors which contribute to the changes of the microbiota. But as one of our colleagues said, the patient does not care about your science. What he wants to know is, can you cure him? And this brings me to the strategies to modulate gut microbiota with various biotics, such as probiotics, prebiotics, symbiotics, and postbiotics. And let me briefly discuss them. A number of those were already covered by ISAP, International Scientific Association for Probiotics and Prebiotics, when it comes to definitions and also the appropriate use of those terms. So I will just briefly try to focus on some of the pediatric issues, starting with probiotics, which are defined as live microorganisms that, when administered in adequate amounts, confer a health benefit on the host. As I have another presentation on probiotics only, I will not cover it now, and I will move to prebiotics. Again, this is a definition which was provided by ISAP, and the probiotics are defined. A probiotic is a substrate that is selectively utilized by host microorganism, conferring a health benefit. And there is a number of health outcomes, health endpoints targeted in human trials of orally administered probiotics for obesity, for satiety, some of the studies, for allergies, for IBD, IBS, constipation, so a number of those. Of course, not all prebiotics are equal, so each one of them has to be evaluated separately. I just want to focus very briefly on infant formula supplemented with prebiotics. I will very briefly touch HMOs because it will be covered in the next presentation by Professor Ivan van den Plas. When it comes to infant formula supplemented with prebiotics, together with my colleagues, a few years ago, we published a systematic reviews that we looked at the outcomes, what are the effects of supplementation of infant formula with prebiotics. And what was really well documented, I'm not showing it here, is that all studies, and there are more than 40 studies that were included in our analysis, all of those studies show that it has an effect on stool microbiota, that increases bifidobacteria, but also had a number of positive clinical outcomes. And I just want to show you, in the context of I discuss the overuse of antibiotics, that the use of at least some of this prebiotic supplemented formula contributes to decrease use of antibiotics. Extremely important outcome, not evaluated in all of the trials, unfortunately, but important in the context of these changes in the microbiota. Human milk oligosaccharides, progress in biotechnology nowadays allows to produce at least some HMOs to be added to infant formula. So they are some mainly with 2FL and LLNT. And Professor Ivan van den Plas will cover it. So I will just show you one example, again, in the context of the discussions that we had on the use of antibiotics, that at least one of those studies showed that adding 2FL, 2-fucosyl-lactose, and LLNT, lacto-NO-tetraols to infant formula reduced parent-reported morbidity and medication use, and particularly they reduced the use of antibiotics by 31%. I think this is an important outcome to be evaluated further, again, in the context of the discussion on the effects of antibiotics on microbiota. Now let me move to another biotic, which are symbiotics, and again, what is new in 2020. This is a consensus paper published very recently by ISAP, looking at the definition, updating the definition and scope of symbiotics. And as you can see on this slide, symbiotics are defined as a mixture comprising live microorganisms and substrates selectively utilized by host microorganisms that confers a health benefit on the host. And what is important, that symbiotics may be formulating using two approaches: complementary symbiotic and synergistic symbiotic. Complementary means that there is a mixture of probiotics and prebiotics, and each works independently to achieve one or more health benefits. And synergistic symbiotic is a mixture of selectively utilized substrate and the live microbes chosen for its ability to deliver a health effects. And of course, the combination has to be shown to be documented, that the specific combination will have an effect. So two different approaches to symbiotics. Again, there's a number of studies looking at symbiotics. I just want to show you one of those, that a symbiotic may help prevent neonatal sepsis. Huge trial, more than 4,500 participants, performed in India, where the death because of the sepsis is really a problem. And they included infants, at least 2,000 grams at birth. And this is a combination which was used compared with placebo. Sorry, intervention was for 2 weeks. And the primary outcome was composite of sepsis and death. And here you see reduction in the risk of by 40%. So it shows you really that there is a potential when it comes a proper use of the use of a proper symbiotics. And of course, there are some other studies on symbiotics as well, but for me, this is one of the most important. And finally, let me move to postbiotics, and very briefly, what is pending. First, what is already known on this term. So the term postbiotics is increasingly found in the scientific literature and on commercial products. However, the term is inconsistently used and lacks a clear definition. And as a matter of fact, if you look at the literature, you will see there are several different terms, all defined differently, that have been used over the years to refer to some form of inactivated or killed microbes. Paraprobiotics, parapsychobiotics, ghost probiotics, metabiotics, tendalized probiotics, bacteriolysates, and many, many others. And there's a confusion and there is a misuse. So what is needed, I think that everyone agrees that consensus over the definition of postbiotics is needed. and the field would benefit from a single, well-defined and understood term rather than use of different terms for similar concepts. And as a matter of fact, it's important for scientists, for regulators, industry, for media, for consumers, so for everyone. And as a matter of fact, ISAP, International Scientific Association for Probiotics and Prebiotics, has finalized the work on, almost finalized the work. It's still waiting to be published, but this is a proposed ISAP definition of postbiotics. And a postbiotics is a preparation of inanimate microorganisms and or the components that confers a health benefit on the target host. And as always, every matter, every word is important. So it has to be inanimate microorganisms. These components, the health benefits are important. As always, in every definition, the health benefit has to be documented. There are many potential postbiotics and possible activity linked to this potential health benefit. Just some examples. So heat-killed bacteria, they may contribute to immunomodulation. Short-chain fatty acid may have anti-inflammatory effects, enzymes and bacteriocides with antimicrobial activity, and gamma-aminobutyric acid, which is a mood regulator. So potential postbiotics and their effects. Many others, of course, they are also available. What are the postulated mechanisms of postbiotics? There's a huge question mark. We still don't know. A lot of more studies are needed, but what has been summarized, and it was also summarized in this document that ISAP will hopefully publish very soon, the beneficial modulation of the activity and composition of the resident microbiota. There are studies on the enhancement of epithelial barrier functions, modulation of the local and systemic immune responses, modulation of systemic metabolic responses, systemic signaling via the nervous system. So some of these postulated mechanisms. Examples of postbiotic use, there are examples both in adults and in children. Here is a summary of some conditions, clinical trials with when this whole concept of postbiotics was tested or was studied. And one of very recent publication is from the Lancet Gastroenterology and Hepatology. It's in adults, but I show it to you because I think it's important to know in which direction the research is going. And it was in adults with IBS, irritable bowel syndrome, and this particular heat inactivated Bifidobacterium bifidum was used here, and it has shown to be beneficial when it comes to symptomatic relief. Here on this slide, I summarize examples of pediatric trials with postbiotics. And again, you can see there were so-called fermented formulas. It's exactly the same concept, just the focus previously was more on the process of the fermentation. And now we are more discussing from the perspective of this postbiotic, of these components which are play important role. So there is a number of studies looking at some particular effect. Fermented formulas in preterm infants, very limited data, but there are some. There are some with a management of acute gastroenteritis with various inanimated microorganisms. And again, of course, the microorganism plays a role. There are first studies on the prevention of common infectious diseases, limited data on atopic eczema, allergic rhinitis, lactose malabsorption. So definitely, we still need further research as much as we would like to see the paper that is that ends with the presentation that ends with no further research is needed, but this is not the case. We are not there yet. This is really like an emerging field, and a lot is happening. So my summary for this part of my presentation, and I hope I did not went over time, and I know that audience is usually likely to remember only 3 things from each presentation. So here are my 3 things which I think are important. First, that the diversity, that the richness of gut microbiota is an indicator of the microbiota good health. It's better to be rich and healthy and poor and sick. Numerous factors, including antibiotics, which I discuss in more detail, have demonstrated to alter the establishment of the gut microbiota in early life with all these long-term consequences. And as I mentioned, strategies for gut microbiota modification, so-called biotics, are available. Of course, each one of them has to be evaluated separately. A lot is happening, so stay tuned. And I thank you very much for your attention. Thank you.
This is Ivan van der Plas. I hope everyone is hearing me. And I would like to thank Hanya for the very beautiful talk on different biotics. And now I'm going to take on from her presentation and take one part out of it and give you some additional information on human milk oligosaccharides and what's new about it. This is the layout of the presentation, and of course, breastfeeding is the best way how to feed all infants. Breast milk is the best nutrition for every infant. And what is very typical for the composition of human milk is the presence of oligosaccharides in that human milk, which is the third most important component of mother's milk after lactose and fat, but more oligosaccharides than protein, for instance. And that's a huge difference between mother's milk and cow's milk or cow's milk-based infant formula, because you see in purple that the third most important component, the oligosaccharides in mother's milk, is virtually absent in cow's milk and in cow's milk-based infant formula. So that's a huge difference between the composition of mother's milk and cow's milk. And those human milk oligosaccharides, they have a prebiotic effect. And you just heard about the definition of prebiotics by Professor Sajewska. And prebiotics stimulate the development of a bifidogenic microbiome. And they are very unique for human milk, the presence of those human milk oligosaccharides. And as everything in mother's milk, it's quite complex, and more than 200 different structures have been discovered already, or more than 200 different oligosaccharides have been discovered in mother's milk. And the composition of mother's milk in human milk oligosaccharides differs over time. But what is very important is the effect of these oligosaccharides on the development of the gastrointestinal microbiome. So the left part of this slide shows you the microbiome development in a breastfed infant, which is predominant with bifidobacteria and very few coli and bacteroides. And then you see on the right part of the slide that the microbiome development in a formula-fed infants, in a formula which is not supplemented with any pre or probiotics, is still predominant in bifidobacteria, but a much lower content than in the breastfed baby and much more coli and bacteroides. In other words, the microbiome development in formula-fed infants is totally different than the microbiome development in breastfed infants. And that microbiome development is very important for the development of the immune system. And bifidobacteria have a beneficial effect on the development of that immune system. So the human gut is not just there for digestion of food, but it contains also gut microbiota, and that's important for the development of that immune system. Because the functions of the gut microbiome are multiple. They have protective functions against pathogenic bacteria. It's very important, as I already highlighted, for the immune development. It's very important, of course, for digestive and metabolic functions. And last but not least, it's also important for the neuronal development, because the gut is also called the little brain, and there is a modulation of the brain-gut axis during neuronal development. And motor control and anxiety behaviors are dependent on the gastrointestinal microbiome. So there is a huge interaction between what happens within the gastrointestinal tract and not only digestion, but also immune function and also neuronal and behavioral development. So what is a human milk oligosaccharide? As I already said, there are more than 200 different HMOs that have been identified, which are classified in 3 main categories: non-fucosylated HMOs, fucosylated HMOs, and sialylated HMOs. Examples are 2FL and LNNT, which are added classically to infant formula. The neutral HMOs account for more than 75% of the total amount of HMOs present in mother's milk. So it's a very complex and diverse structure. And also the amount of different HMOs present in mother's milk differs over time. It's, if you look for 2FL and LNNT, it's much higher during early lactation than during late lactation. And also the amount is totally different, because for 2FL it's in milligram and LNNT is in microgram. So neutral HMOs predominate in the first 2 to 4 weeks of lactation, decrease over time, and the amount of HMOs present differs also over duration of lactation. Not every mother secretes the same amount of human milk oligosaccharides, because you have secretors and non-secretors, and mainly non-secretors have very low to no secretion of 2FL. And so the development of the microbiome differs in exclusively breastfed infants if the mother is a secretor or if the mother is a non-secretor. So what has been shown is that there is no difference on diversity and richness, which is a good thing, but that the number of lactobacillus and bifidobacteria are decreased if the mother is a non-secretor. And if the mother is a non-secretor, you have more Enterobacteriaceae and more Lactobacillacea and more Staphylococcaceae than if the mother is a secretor. So the gastrointestinal microbiome development in a breastfed infant is not uniform, because it depends on the fact whether the mother is a secretor or a non-secretor. And about 20 to 25% of the mothers are non-secretors, which is a huge amount. And the amount of HMOs depends on a lot of factors. As there is a lot of research going on, we know that there are multiple independent variables which will influence that amount of HMOs. Lactation stage, I already highlighted that, but also maternal genetics, environment, or season have an influence on the amount of HMOs, duration of pregnancy, ethnicity, parity, geographic location. So every mother synthesizes and secretes a very specific HMO composition. And there are so multiple variables which will influence the composition of mother's milk in HMOs. Is it really new? No, we know since more than 100 years that there are oligosaccharides present in mother's milk, which stimulate the development of bifidobacteria. What is new is that since a couple of years, those HMOs can be industrially made. So is HMO added to infant formula a real HMO? In fact, no, because it does not originate from mother's milk. It is industrially made, but it's an identical molecule to the one present in human milk. So calling it an HMO may give the wrong impression that this component comes directly from mother's milk, while that is not true. It is made chemically, industrially made, but the structure of the molecule is exactly the same. So it would maybe be better to call it HMO-like or an HMO clone or human identical milk oligosaccharides to avoid the confusion. As I already said, mother's milk has over 200 HMOs. 2FL is the most important one, at least in the 70–75% of the models which are secretors. And there is that huge diversity in structure. So today in infant formula, we add 1, 2, or 3, or maybe in a couple of months, 5 HMOs. But that's far away from the 200 different. So we add now a molecule with the identical structure, which then have the identical benefit because it's an identical molecule, but we lack the diversity which is present in mother's milk because we add at the best 5 HMOs and not 200 different ones. So we should not forget that there are also prebiotic oligosaccharides of non-human milk origin. And GOS and FOS, galacto-oligosaccharides and fructo-oligosaccharides are the best known for that and have been the best studied. And GOS and FOS are prebiotic oligosaccharides which are promoting the growth of beneficial gut microbiota. We know that they stimulate the development of bifidobacteria. So if we compare the diversity, then GOS and FOS is much closer to the diversity of human milk prebiotics or human milk oligosaccharides, but they have a different structure of the human milk oligosaccharides. But if you look at the range of diversity, then GOS and FOS is quite comparable to what is present in human milk. But they have different effects because, as you see in this slide, human milk oligosaccharides inhibit the growth of a lot of possible pathogenic bacteria. And FOS does the same, more or less, except for 2 bacteria. But GOS allows the growth of a lot of those potentially pathogenic bacteria. So the efficacy of non-human milk oligosaccharides or human milk oligosaccharides is different. And some strains of bifidobacteria use HMOs as the sole source of carbon, which means that both FOS and GOS and human milk oligosaccharides stimulate the development of bifidobacteria. But the strains that develop are different because some of the bifidobacteria only use the carbohydrate from human milk oligosaccharides. Other differences are GOS and FOS contain fructose, HMOs do not. And important is that fructose and sialic acid are present only in human milk oligosaccharides. And a very small percentage, 1% of that sialic acid is absorbed and transferred to the brain and has a positive effect on brain development. What about the clinical data? Also, Professor Sajewska already alluded to some of the clinical data. First of all, it's of course nutrition, and what needs to be shown is that the growth of children fed formula with human milk oligosaccharides is completely normal. But that has been extensively studied and it's absolutely safe, and physical growth and nutritional value of those HMOs is absolutely safe. Professor Sajewska already highlighted also the importance of microbiome development and dysbiosis, and the fact that infections and antibiotics and hygiene and nutritional changes will change the composition of the gastrointestinal microbiome, which will result in an imbalance of the development of the immune response, which will predispose to allergic diseases. And the right part of this slide shows that fecal samples at 3 months, when they are different, between healthy and allergic children at the age of 5 years. So the difference in gastrointestinal microbiome predisposes the development of allergic symptoms. So a healthy, well-balanced microbiome early in life will prevent the child, will protect the child, will decrease the risk to develop allergic disease. So HMOs modulate lymphocyte cytokine production, potentially leading to a more balanced Th1, Th2 response. And again, one slide from a long time ago, over 20 years ago, showing that the difference in composition in the intestinal microbiome exists before the development of allergic disease. So again, the importance of a well-balanced, healthy microbiome early in life cannot be stressed enough. And studies have shown that infants born by C-section and having a high hereditary risk for allergies may have a lower risk to manifest IgE-associated eczema at 2 years if they have a high amount of oligosaccharides, if they are exclusively breastfed by a secretor mother. So the incidence of allergic disease in C-section born infants which are exclusively breastfed depends on the fact if the mother is secretor or non-secretor. That's also illustrated on this slide where there is a difference of diarrhea, vomiting, respiratory infection, coughing, depending on the fact in exclusively breastfed infants, if the mother is a secretor or a non-secretor. So not every exclusively breastfed infant is protected in the same way. Again illustrated in this slide on in exclusively breastfed infants, secretor, non-secretor, showing that if an exclusively breastfed infant, if the mother is a non-secretor, the risk for that child to develop Campylobacter diarrhea or any cause of diarrhea is much higher than if the child is exclusively breastfed from a secretor mother. So the amount of 2FL, the amount of HMO present in mother's milk protects the child in a different way to develop infectious disease. And here exactly the same, exclusively breastfed infants with a 3 times higher risk to develop atopic dermatitis if the mother is a non-secretor compared to if the mother is a secretor. This has also been studied in formula-fed infants, where it has been shown that formula supplemented with 2FL reduces the risk to develop atopic dermatitis compared to formula not supplemented. And that has been related to a difference in development of inflammatory cytokines, where if you see in light blue breastfed baby and in orange or in green with HMOs, that level of inflammatory cytokines is the same more or less in the breastfed infant than and in the infant fed formula with HMOs, and that levels of cytokines in the infant fed formula with galacto-oligosaccharides is totally different. And this slide was shown by Professor Sajewska, where 2FL and LNNT were added to starter formula, showing that there was, as a secondary endpoint, a reduced incidence of infections and infestations, less respiratory tract diseases up to the age of 12 months, although the intervention was only up to the age of 6 months. So a prolonged beneficial effect. And what Hania highlighted was the decreased prescription of antibiotics up to the age of 1 year. And that has also recently been confirmed in a study with HMOs in infants with cow's milk protein allergy fed an extensive hydrolysate supplemented with 2 HMOs, confirming the same evidence, the same findings, decreased lower respiratory tract infection, decreased upper respiratory tract infection, decrease of otitis media, significant decreased prescription of antibiotics and less antipyretics. And this is another way to look at it, to look at prescription of antibiotics, and it shows that infants with a high bifidobacteria-dominated gut microbiota community at 3 months less often require antibiotics in the first year of life. So it cannot be stressed enough how important the development of that healthy microbiome early in life is. That brings me to conclusion. Breastfeeding is, of course, the best way how to feed infants because it contains that huge amount of human milk oligosaccharides and that huge diversity of human milk oligosaccharides. What do HMOs do? Well, they stimulate the development of a healthy gut microbiota. They help to mature the gut barrier function. They have an antipathogenic effect. They act as a decoy receptor, so pathogens will adhere to the oligosaccharides and not to the intestinal mucosa, and they stimulate the development of a well-balanced immune response. And so it's very important to have a healthy gut microbiota because that will result in symbiosis, immune tolerance, intestinal homeostasis, and a healthy metabolism. If that gut microbiota is not well balanced, it results in dysbiosis, which predisposes the child for an increased risk to develop immune disease, intestinal disease, and metabolic disease. And there are early in life a lot of factors which influence the development of that gut microbiota. Professor Sayeska highlighted the use of antibiotics. Proton pump inhibitors do the same thing. Infant diet does have an influence. Mode of delivery, C-section versus vaginal delivery, environment, are all factors which do have an influence. So I hope I convinced you that early gut microbiota development is of major importance and will have an influence on the long-term health outcome of our infants. Thank you very much for your attention.
Ivan, thanks a lot. Thank you very much. I hope you can hear me now again. So I will continue with this topic about biotics. So Professor Ivan van den Plas covered human milk oligosaccharides. I previously covered prebiotics also, but also symbiotics and postbiotics. But now let me focus on probiotics in pediatrics, and it will be a 2020 update. You have already heard all my where my scientific heart belongs, so I will just repeat vegan, ISAP, and I really like evidence-based medicine. So we will focus on probiotics. People are asking all this question, probiotics, myths or miracle. Are probiotics really that good for your health? Probiotics, panacea, or just a big fad? Why there is such an interest in probiotics? And I will try to cover at least some of those questions. What are probiotics? There's a definition which comes from ISAP, already published a few years ago: live microorganisms that, when administered in adequate amounts, confer a health benefit. And each part of this definition is important. The microorganism has to be live. The dose matters. And of course, like in every definition, health benefit has to be demonstrated. We know that not all probiotics are equal, so it means that each probiotics has to be evaluated separately. And why it's so? And one of the reasons is that if you look at the mechanism of action, why there are some widespread mechanisms among studied probiotics, like for example, colonization resistant or acid and short chain fatty acid production. There are some species level frequent mechanisms, but what is really important is that there are some rare strain specific effects, like for example, immunological effects. What differentiates one probiotic from another is how it influences, what is the impact on the immune system. And that's why it's so important to look at each probiotic separately. What is new in 2020? This is a paper which summarized criteria to qualify microorganisms as probiotics in food and dietary supplements. And a number of ISAP members, or the people who are contributing to ISAP, put this paper together. So let me just show one slide. The candidate probiotic strain has to be well characterized. We really have to know which microorganism we are discussing and the genome sequence. The best is to know the genome sequence of this microorganism. Safe for intended use, that's absolutely obvious. At least one positive relevant human study, because even in the definition, you can hear that the health benefit has to be documented. And the product delivers study dose viable until end of shelf life. So the dose again is important. And if it's okay for all of those, then you may say this is a probiotic strain. If not, for any of those, it's not a probiotic. This comes again from ISAP, how to choose a probiotic. So I already mentioned genus, species, strains, the characteristics is important. Expiration date is important. Storage needs, not all of them has to be in refrigerator, and some of them in the room temperature. Those I already commented. And last but not least, I will repeat evidence. And this is what I would like to focus now. Some few years ago, I had a privilege to contribute to this paper. What are the indications for using probiotics in children? I will not cover all of them. I will cover some of them, and I will try to explain why. And I will start with acute gastroenteritis. And of course, everyone agrees that the key treatment is rehydration. Oral rehydration therapy is one of these for diarrheal diseases, is a success story. Until now, 500,000 of children below 5 years of age may die during the diarrhea. However, this is much less than it was in the 80s, 4 to 5 million. And this is really mainly, not only, but mainly to oral rehydration solution. But ORS remains underused, and this is despite the proven efficacy. And this is because it does not reduce vomiting, it does not reduce frequency of bowel movements, fluids loss, duration of illness. And as a consequence, there's its interest in safe, effective, and inexpensive agents as an additional treatment, including probiotics. And until 2020, most scientific societies agreed that the use of selected probiotics with documented efficacy may be considered in the management of acute diarrhea in young children, of course, only as an adjunct to rehydration therapy. But then, quite recently, 2 RCTs were published in a New England Journal of Medicine, and they showed that probiotics are no better than placebo for acute gastroenteritis. Large trial with altogether almost 1,800 participants. And one of these probiotics, one of those studies, which was probiotics LGG, Lactobacillus rhamnosus GG, which is often in the guidelines. So, well, Houston, we have a problem. Yes, indeed, there is a problem. And within the ESPGHAN, European Society for Pediatric Gastroenterology, Hepatology, and Nutrition, we decided to update, it was in a working group on probiotics of ESPGHAN, we decided to use, to update what is known on the use of probiotics for the management of acute gastroenteritis. And Professor Van Vandenplas, who was a speaker, previous speaker, he was also contributing to this paper. When we are working, but just very briefly, the recommendations were formulated only if at least 2 randomized controlled trials that used a given probiotics were available. And there were no recommendations in probiotics in general, because we strongly believe that, and I already repeated, and it's not only us, many other organizations, that each probiotic has to be evaluated separately. Like, we are not talking about antibiotics in general. We are always speaking about a specific antibiotic. So exactly the same here. If only 1 randomized controlled trial was available, regardless of whether or not it showed a benefit, we did not formulate any recommendation. And if the strain specification was not given, also we did not formulate its recommendation. And I already mentioned that I showed you that one of these criteria for probiotics is that we know exactly that we know the characterization, specification of the microorganism. We identified 16 systematic reviews and meta-analysis published since 2010, including 7 strain-specific meta-analyses. Altogether, there were 150 randomized controlled trials, and only some of these randomized controlled trials included in the systematic reviews overlap. Of course, there are every now and then there's a good explanation why it is so, but this is just for your information. And on this slide, you can see only 6 probiotics, single or combinations, that were evaluated in 2 or more randomized controlled trials. So many studies and only very few, there was repetitive studies. And you know, science is about the repetition of the results. So it really would be nice to see repetitive studies. There are the summary, and I'm just showing you the summary for one of the outcomes that we looked at. It was the duration of diarrhea, and generally there was a reduction in the duration of diarrhea. However, when you look for one of the probiotics, Lactobacillus rhamnosus, there was only reduction in the duration of diarrhea when we evaluated all of the trials. But when we look only at studies with a low risk of bias, there was no significant difference. There was, of course, a lot of discussions about how to interpret this data. I will make a long story short, and I will just show you the final recommendations. So as you can see, we have four positive recommendations, and these are for Saccharomyces boulardii, Lactobacillus rhamnosus GG, Lactobacillus reuteri DSM 17938, and the combination of Lactobacillus rhamnosus and this particular Lactobacillus reuteri. You know now that all these numbers, letters and numbers are important. And the order is based on the number of trials available. So it's not that we are saying that one is more important than the other. There are conditional recommendations with low to very low quality of evidence. We also provided two negative recommendations. One was strong and one was conditional recommendation. For all these positive recommendations, we also provided the doses in the paper, and the duration of treatment is usually based on other previous studies, and it's 5 to 7 days. So these are the general conclusions from our paper. But there's another paper which looked at the similar topic, the use of probiotics generally, but including acute gut diarrhea, and it comes from AGA, American Gastroenterology Association. And here for children in North America, the conclusion is that in children with acute infectious gastroenteritis, we suggest against the use of probiotics. Conditional recommendation with moderate quality of evidence. So we do see differences between ESPGHAN and AGA documents. Both were made based on meta-analysis of randomized controlled trials, different number of studies which were included for the analysis, target population in our ESPGHAN working group guidelines, it was children in Europe, but all evidence was considered for AGA. It was mainly, they were mainly focusing on children in North America. Certainty of evidence, in our case, low to very low, AGA moderate, and the strength of recommendation in both, for both recommendations, conditional, but for or against. For these AGA guideline, the recommendation, the two most important papers, both in North America, are these two negative studies published in New England Journal of Medicine, which show that probiotics are no better than placebo for acute gastroenteritis. Of note, more than 60% of a study population was vaccinated against rotavirus, which really differs those studies from previous studies when which were conducted mainly when the rotavirus vaccine was not so common and the children were usually not vaccinated against rotavirus. Whether it matters or it does not matter, I don't know, but I think it's something for consideration. But anyway, we do have this conditional recommendation for or against. So what is the interpretation? And here is the interpretation from the Great Handbook. It's a very similar interpretation, conditional recommendation for an intervention and against an intervention. It's the same interpretation. Different choices will be appropriate for different people. Clinicians could help each patient make decisions consistent with the patient's preferences. What is new? So I showed you what are the ESPGHAN working group on probiotics recommendations and AGA. And this is very new, Cochrane review, which looks at probiotic for treating acute infectious diarrhea. And the conclusion was on probiotics in general. So I'm not talking about any specific strain. Probably make little or no difference for the number of people who have diarrhea lasting 48 hours or longer. It's uncertain whether probiotics reduce the duration of diarrhea, and this analysis is based on large trials with low risk of bias. And here, please remember, they were not looking only in children, but generally in regardless of the age, even if the majority of trials were conducted in children. And what is interesting, so probiotics in general, there is no very favorable conclusion. However, if you look at the individual studies on the analysis on particular strains like Lactobacillus GG, Saccharomyces boulardii, Lactobacillus reuteri, you will see that is this strain-specific meta-analysis. There was also always a reduction in the duration of the diarrhea with a huge heterogeneity like all other meta-analysis. So I showed you what is the evidence. So the question is probiotics and acute diarrhea, to give it or not to give it. And this is my personal conclusion, that specific probiotics may be beneficial, although not essential, in the treatment of acute diarrhea. The use of certain probiotics with documented efficacy may be considered in the management of acute diarrhea in young children. And I think that when endorsed, the strains most often recommended include LGG, Saccharomyces boulardii, and Lactobacillus reuteri, DSM 17938. So once again, may be beneficial, although they are not essential. So I covered probiotics and acute gastroenteritis, and the reason why I decided to cover it is because there are new data, new recommendation, and also new Cochrane review. Now let me move to another indication, which is the use of probiotics for preterm infants and necrotizing enterocolitis. And here, of course, we are not discussing the reduction in the duration of diarrhea by 1 day, but we are really talking about death and life. And we know that very low preterm infants, very low birth weight infants, preterm infants, there's a high risk of, at least in some setting, of necrotizing enterocolitis. And the reason I have chosen this particular condition is that we have again, guidelines from ESPGHAN and from AGA. And as you will see in a moment, they differ. So I will start with the ESPGHAN document. These are guidelines developed by our working group on probiotics and prebiotics, but also with the ESPGHAN Committee on Nutrition. So a lot of people contributed to this document, and it took us more than 3 years to come to the final conclusion. A number of clinical questions was raised here, and we did try to address all of them, and you can find answers to all of them in the paper, which is open access, so you can go. It's published in the JPGN, Journal of Pediatric Gastroenterology and Nutrition. But one of the most important questions was, should probiotics be used in preterm infants? And if yes, which probiotics, single or combination, should be used and what dose? And so we have provided some positive recommendation, and if all safety conditions are met, the positive recommendations is for LGG and the combination of Bifidobacterium infantis BB02, BB lactis BB12, and Streptococcus thermophilus TH4. Question mark, we did not formulate a recommendation for or against. They were for those two probiotic, one single and one combination. And we also provided negative recommendation for Bifidobacterium breve BBG001 and Saccharomyces boulardii. But let me focus on something which is positive. So again, if all safety conditions are met, LGG, and we provided the dose which is recommended based on the studies, and for this combination of 3 strains. And again, we provided what should be the dose. As I already mentioned, there are again differences between ESPGHAN and American Gastroenterology Association guidelines. We provided for, nor against, and against recommendations. American Gastroenterology Association listed more strains that we listed with a positive recommendation. They did not find anything, they did not formulate any negative recommendation. So we do have a problem in a way, because while both were based on pairwise systematic reviews and network meta-analysis, because this was a methodology used in both guidelines, their conclusions differ. And this is, of course, problematic always for people. So what to do? So the good message is that in both guidelines, there's one probiotic that was recommended by both societies. And as you can see, this is LGG ATCC 53103. So my personal opinion is that if you have doubts what to choose, just to choose the probiotics which is recommended by both societies, if it is, of course, available in your settings. And very briefly, so I briefly commented on the probiotics for acute gastroenteritis, for necrotizing enterocolitis. Again, I have chosen it because there are recent recommendations and the recommendations differ. And I have also chosen infant formula supplemented with probiotics. And this is because it's very often a question which is very often asked. This is a systematic review which we published already together. I published together with my colleagues from our team already some time ago. And at that time, we found that there was a number of probiotics studied. There is some positive effect, depending, of course, on the strain, like reduced GI infections, lower frequency of colic, etc., etc. But again, I would like to call your attention that at least some of those strains can reduce the use of antibiotic prescription. And I'm going back and again to this outcome because I think it's really important in the context of the effects of antibiotics on the microbiota. So my summary for this part of presentation, based on the literature: no safety concern with regard to growth and adverse effects. Some favorable clinical effects are possible, and I showed you, and the efficacy and safety should be considered for each probiotic supplemented formula. So it's difficult to give one single recommendation which will be applicable to all kinds of formulas. So I showed you some of the evidence on some of the use of probiotics, but even if the best evidence guidelines are available, they do not automatically lead to improved health outcomes. Even more, they may differ, which makes life even more difficult. But anyway, there are so many barriers between evidence and clinical outcome, as you can see on this slide. And there is a role for physician and there is a role of patient. And with this, I would like to finish and to thank you very much for your attention.
Cairo, University, Egypt, Sheikh Khalifa Medical City, Abu Dhabi. So welcome, Dr. Islam.
Good afternoon, everybody. Thank you for the briefing class, for the presentation and the opportunity. And hopefully that in the beginning that has a physical contact with each other again, that is lockdown. So today I will be talking about something that we are taking maybe usually in our clinic. And time also provide just to start with, so what's the percentage of the living things? Just for us to know that monitoring the living will be centered. So here's something very important. Better. See something. 30% compliance, yes, 60%. While if we try to interact with each other, we need 70%. And this is actually what we are looking for today. So I'm looking to our experience topic. This is what we call a collaborative level. So this is the point that we need to talk about. So quality, I can tell you about the quality. What's the origin of the word quality? Any idea? Any idea of where this quality? Any idea? It is a key for qualities, and it is related to the economy. And the definition of the quality, that it is a full being and start and end abruptly, usually in a whole organ, and usually it is a natural one. And why? Start and just have to relieve the obstruction or to relieve the pain, maybe it is associated with a lot of people associated with as well. What's the type of the quality that all of us we know? Just name it, type of quality that we may have. So it is the interqualic, the inalqualic, and the periodic abdominal. This is affection caused by what we call the interqualic. And this is called the lemon quality. How will it add equality? Have you heard about this? If you might ask me for a money and see the so what is happening? So this is of course a kind of the shopping. Everybody that all of us we will suffer of the shopping quality. So again, we need to approve it. So in the tradition practice, usually we have what we call it a big school will depend on the effective strategy that we have, and that we do and advice for general expression that you are getting. But to be honest, this will be a lot of variation, even in diagnostic activity and similar conditions. That's why we are getting to develop what we put as systematic approach. And this systematic approach is what an ETL, not the ETL. Yes, of course, it is that evidence-based method. So this is what we are aiming for. So this is the dynamic that we are having. So we have a four each four very actively to the people that is having a third sleep right at bottom. And then is there. They are staying different. So let us see together what we are having. So this was the high of his work. If this is your case, this is what you learn about this right now. Yes. Okay. So I mean that has been some efforts, no, and this is we are talking about the fear. And I'm glad for those who said yes, because I mean there is a consequence, and the consequence that we are having a good and a bad and an ugly consequences for someone who are really just to try or not what you are concerned about. The ugly one. So this is would be something really that is not understand, and I would encourage everyone that if you do it, try to read that and not see what we're gonna show you. So the other one that there will be an entity. It's like you will see an entity, and specifically you will be having what we call that shame syndrome. So this is the ugly scenario of the sequence that we have for the infant part. The good one, that more than 17% is maybe in the UK are taking medical advice, which is something good. The other also that some will drive their experience of this environment. We have like the sentence and she drives the book and it's a life drive to the quality and she was living with the quality. But the last we have this thing that is seeking unnecessary advice for a persistent infant drive. And this is the happening in the of the family. So for those who said, no, you are not concerned, this is a consequence if you are not concerned about acquiring things and you are not dealing with them. So those, yes, now dealing with their things and trying, that every 5 months, so this is a higher level, data content, and identity activity, or a lower emotional self-regulation, or this is a level of opportunity to develop the electric skills. Not only that, but also, all of us we know that there is a key window of opportunity that we have your candidates early in life. And we need to do something early in life just to reach what we put the next application that is for you. And this is happening in the first 48 months. So to reach the next level of the emotional intelligence, of the social development, what you need, don't sit to be right now. You have to put it up. So this is very important in the development of the emotional intelligence and for the social development. So this is very important to know about it. And this is just to see. Another put even in your mind as a red flag, and this is not something normal to deal with. So, in general, what we are doing, if you have someone who's trying to find you with a sense of in their body, this is a flag that should be. Again, there is another special thing. So this ability with a copy with the trying to make our work. And this is the ability. If this is a difference or what we put it as a non-tension, that maybe there is again our construction with a lot of food, just keep it in good mind. So regarding the history of the clinical exam, he was learned eating 12 his apnea and normally in the daily food regarding the examination, the vitamin and the food examination, the food exam was unremarkable. So again, you are excluding the red flag. What do you think? Is it an inconsolation? Is it an inconsolation? Yes, no, or maybe. So still, maybe. Are we missing something? What we need to know? The teacher of the class. Look at it. So there is some teachers who teach primary, who teach just like giving for you the sentence for the college. So this example is you see that there is some of the time contract but we couldn't this explanation and it means something for them up is just a hard bit but some of it that we cannot use as well. Otherwise, give it so there's a high gives me this is very important to see. And why is that? Because we need to differentiate between safety associated with the nutritional outcome. The 70%. Sometimes that you are having someone having the option to have the head and neck to one side and the lower extremity to the other side. And this is happening temporarily. It is relatively absent during sleep. It is not. At that time, it is not a 70% position. And what you are seeing, this is what is the episode, this is what we call it the seasonal episode that you are having during this study. So that's why this is very important information about it. If I tell you that there was no red flag, and so could you say that this is a functional infant quality or not? What do you think? Yes, we're still learning. So what we are looking for that still we are in need with the teach for the diagnostic criteria. And infant quality, I mean, there's along this, so we have the diagnostic criteria. Someone have 3 hours or 3 days or 3 weeks, then they use 1 week, then in all 3 days, no problem with the 1 week, but after the period of time. Then in 2016, we came to Rule 4. And in Rule 4, the first thing that we have changed, the name. So it is not infantile quality, it is infant quality, not infantile. There is no infantile and other. It is just only identical that is created the infant. That's it. So it is the infant quality. The other thing that for the age grade, it is not in the info 4 months, below 5 months, in the duration 3 hours, 2 hours, 1 hour, because what is concerning that if the business cannot in that nation, at any point, that it is not functional, gastrointestinal disorders. This is what we need to have. The pattern usually they start after 2 weeks, the peak in the 6 weeks, and even before 5 months. Already it is done, it is still limited, just keep in mind what you need to do. So what was the history regarding this? You were having a standard counseling formula, there was no vomit or no diarrhea. You were having every 4 days, you had something like that for 4 hours, and the parents right now, they're eating the finally, and they cannot put them on carbon down. So now, the diagnostic impression, you can eat the diagnostic impression, not in any while you are in your home. You could say that. Now it is an unexplained current trying with normal risk examination, unclear physiology. This is the functional infant one. This is very important to know about. This is the Khalifa, medical city, with this is was in the IPS 2020, and we would love to see all of you get first to serve for the next. Now, regarding the theory, that so explain the infant quality. How do you explain the infant quality? So, this is quality theory. Put it as experiment between the parent and child interaction. The parents play on themselves, and this is reflected on the parents. Or maybe, repeatedly, crying baby is distressing the parents, and this is an interaction between both. It is reflected on them. The diabetic effect to make them a reaction, counter reaction. Lactose intolerance or food that's very important to know about. For this and certain smoking. So this is some of the figures. We don't know what is the left, what is the truth about them. We need analysis every time. So we remain with these things that are before across in the human system. And here, that is the problem for that this image cannot withstand what we put and now that we have it on our side. Cannot handle their daily life in the life. That's why we shout out, and this is called the climate, and this is trying to communicate with over. The other theory is the other way around. They said, because the image services, give the meaning for that, for a more stimulation, just to increase that awareness of his nervous system. So it is the opposite. War. There is not equal as a student that can resist. So usually, as a student is increasing the activity, the good people could find a student, and the student will not be stimulated till the age of 4 to 5 months. So this is very important to know. This thing, fourth trimester, and I think this is the fourth trimester. So this our scientist Harvey Carr in his book The Happiest Baby on the Block, he said that we are supposed to be delivered after 4 months. Not we have the first trimester, we need to have a fourth trimester. And he said that we are just going to go before the diabetic cells. And he said that for all species, whenever that they are delivered, they are moving. They are moving. Except for us, we have to wait for at least 3 months. Then we start for 4 or 5 months to travel. So he says that still that we are in need. This is one of the figures, and for put into no and so we think what we call it the female imbalance. So the gap is a theory that immediately at the different time for the different classes of our blood. And the microbiome is affecting our motility, and the motility is affecting the development of our microbiome. So this hyperextension or the super will give an alteration of our blood bacteria. This will give an activity which is the drawing infant food, the infant oil. So this distribution of our good bacteria is having an analysis between the good bacteria and the bad bacteria. Whenever the good bacteria is moved in this diversity, like the E. coli, the bacteria, the lactobacillus, this is what we call the symbiosis. While if you are having the bad bacteria before, this is what we are calling the dysbiosis. Our aim is to have that symbiosis. So again, we need evidence for whatever that you are saying, and here that the cytomicrobiome is a specific thing to do what having an integrated. They have a specific microbiome, and that's why this is an evidence for those who are not developing a connectivity. You will not subject to that to the microbiome signature. Again, with the gut microbiota, there is a different gut microbiota will found among the quality and the non-quality. This is the distribution. There is a specific distribution that is according to the people, and this is the most famous one of the about the quality. So, knowing all of that about the infant quality, should we be concerned about saying to be yes or no to be, or should we be concerned about or not? So the point is that the third sequence is not only affecting the quality of the food inside having the other thing that this is to keep distressing the food ability to the source of the stress and uncertainty and maybe incorrect diagnosis in this investigation or addiction and medication. This is very important and not to be done. They said that there is a difference between the being and not later on for those who will then initiate an infant this is very important. How you treat the infant how you treat in your clinic? But they will keep coming to you. They will keep coming to you. Then, okay, even if you find now that I know that this is a point. So I show that there's no uses and there's no harm. So for that, so I think we have a list of things that we should do. So keep a quality diet, creating food, the quality food, definitely there is some music, some motion, microbiome effect, scientific food, more fat, that's required. So the point is that we need to focus the evidence is behind each dish. This is the point that we need to know. So how to treat here across الوصفات اللي كانت from the grandmother, so we are talking about peppermint, we are talking about the chamomile, about Arabian ginger, what you think about that, what's the evidence? Mind the evidence is saying what? This is the lecture of herbal tea may increase try to bring them, but it could be a man, the standardization of the dosage and nutrition in the Roman. The same for the agriculture, the problem with the agriculture, that you should avoid anything that is having a sugar content. What else? So the stimulator or the great vibrator early response just like to carry him or you can use a pacifier doing an instant attack, quality folder, give out the right at all. That's So, counseling players, according to the American Academy of Pediatrics, and it seems to increase the chronic more quickly. So, the first thing, counseling the patient without counseling the parents, that will go by itself. Talking about the final report, we have a key element. Two of them said that is no more effective, was no more effective than the vaccine for the patient in infant body. So it's just giving vaccine the parent, but not the infant in the body. So every day we have the microbiota, and in the morning we have seen Erica and the private one talking about the hormones, the probiotic, the prebiotic, the postbiotic, the antibiotic, all of them will help them that got microbiota. And just to show you, so this antibiotic and probiotic are usually associated with the chronic illness. Well, remember, as things in the morning, not just the probiotic and the probiotic, because they put that they need you look the same time. Anyone saw this movie? So yeah, so they are like three brothers. One of them was the good one of them was bad, and one was in the middle. And all of them belonging to the same family. So probiotic and prebiotic is not the same. If you didn't see that movie, so we have the Chinese program. So fingers cannot be of the same sorry, so the probiotic has a very specific and it was and remember that the probiotic or prebiotic or whatever supposed to have a clinical evidence behind that. So now what's the key recommendation? Parents should be educated. This is the first thing for the infant one. The second one, handling the microbiota, whatever good nourishment, this is something good and the evidence is key. Elimination of the allergens. If it is the breastfeeding, so elimination of the allergen from the diet of the breastfeeding mother. If she is on a formula, switching formula with infant or hydrolyzed formula may help, and this is from the Canadian family physician, Mr. Albert. For infant, that means that quality criteria that we're talking about. So what's the next step? Organic molecules ruled out, avoid, provide a reassurance for the parents, and begin a self-limited natural amino of the colic. If it's breastfeeding, continue the parental assurance, consider allergen restriction for the diet, and you may consider to add probiotic separately for the breastfeeding maybe 5 hours. If they are only feeding, continue the parental assurance, and this parental assurance includes if there is any microbiota that you need to add. If not, consider transition to a hydrolyzed formula if they are from the Then the conclusion that many causes for the climate influence is there. Functional infant quality is among the causes that you need to have that there's a specific method and criteria. There's no definite cause for the infant quality. Infant quality is among or leading to a serious complication, excluding organic cause of the climate. It's very crucial. Infant quality has no definite treatment, but enhancing the proper microbiota signature may be beneficial. And my message, use sometimes, read often, and comfort always. This is Hippocrates. And at the end, health does not always come from medicine. Most of the time, it comes from peace of mind, peace of heart, peace of soul. It comes from laughter and love. For you all, peace upon you, and love you all.
Thank you very much, Dr. Islam. Informative lecture and nice like usual. Thank you. We have 5 minutes for questions before the major and opening ceremony. Any questions for Dr. Islam?
supplements for you, yourself? What you do? I mean, are you giving probiotics? I see now the increase and we see that it's not nutrition anymore. But it's like that you are doing nutrition or no, and some are nutrition, some no. So,
So again, is it an infant colic or not? This is the first thing. You need to exclude if there is any organic cause. Just like we can summarize this way: is it an infant colic or not? There is any organic cause or not? If there is any organic cause, you are done, and you have to treat the organic cause. If it is a really infant colic, so the first, the second, the third one is the parent counseling. The parents counseling, you have to reassure them that this is something which is self-limited. If they are keep coming to you for first time, it seems that it is the severity, because there is a severity. And we said, if you're gonna leave it, later on, we may have some allergic or we have some functional gastrointestinal disorder that it may develop, or you may decrease their social development, or even like the social intelligence. So it may affect them. Then at that time, you have to do something. As we just said, if they are breastfeeding, just you could counsel the mother. You could do some elimination, because maybe that there is some subtle cow's milk allergy is happening, or protein milk allergy, let us say for someone who's he's a breastfeeding, so that there is an elimination for the mother. If not, then at that time you can add some drops of the probiotics. And as we said, that it is a specific that you need to choose whatever, what is the specific probiotics that we need. This is if she is or he is on a breastfeeding. If he is on formula, then at that time they may get benefit, as we just saw also with Dr. Hania, that there is an evidence, but the clinical outcome is not the same, or it is not matching the evidence that we are seeing. So again, it is a reassurance if they are on the formula, and you can choose at that time whatever, probiotic, prebiotic, postbiotic. If it is not, then at that time you have to consider that this is, maybe it is a cow's milk allergy, and you need to shift to a hydrolyzed formula and to see what is the response. If not, sometimes that we are giving a highly concentrated glucose, at 12% glucose, also it may affect the microbiota. So this is supposed to be very clear in your mind. Whatever that you are doing, or they are coming to you, supposed to be this way, or this flow chart. Thank you. Sure. Probiotic, okay. Okay, this is a good question. I mean, usually, whatever that we are having, what we call it, from 100 to 200,000. This is the international unit for the probiotic. Usually, the therapeutic doses, I mean, it is varying from each strain of the probiotic that you are using. But there is a wide range of the therapeutic, for the therapeutic range that you are giving. Usually, it is advisable for the probiotic that you are getting. You shouldn't exceed. So they will not tell you how much you need to give, but they will tell you how much you shouldn't exceed. So you can start with a low doses for this, for the probiotic, and to titrate your response. This is very important. This is the first thing. The second, for how long? Usually, it would take 10 to 14 days to change the microbiota, if we are claiming that this is the cause for the infant colic. So at least you could see a response for at least 14 days. Then after that, you could decide you need to continue or not. Thank you. Any other question? Thank you.
Thank you very much, Dr. Islam. Highly appreciated.
Thank you.
بسم الله الرحمن الرحيم
Very good afternoon to one and all present here. It's my pleasure to introduce to you the speakers and delegates that have come from other places today to share their knowledge and enhance our confidence in the profession that we have. This is the 9th International Pediatric Conference in collaboration with Ras Al Khaimah, MHSU, and Amina Hospital. Due to the inconvenience caused by COVID-19, we encourage the participants to stay safe and maintain social distancing. Also, as a result of which, this conference is being conducted physically and visually. The theme of this conference is Trends, Solutions, and Innovations in Pediatrics and Neonatal Healthcare. We have today experts from across the field who will be imparting their knowledge with us today until tomorrow. But now, may I introduce all of you to the people who will grace us with their welcome message. Let us all welcome the Honorary President of the Conference, CEO of Al Jalila Children's and Specialty Hospital in Dubai, Dr. Abdullah Al Khayat. Sir.
الرحمن الرحيم والصلاة والسلام على أشرف المرسلين سيدنا محمد وعلى آله وصحبه وسلم أجمعين. سعادة الأخ الدكتور شريف مسعد استشاري طب الأطفال ورئيس المؤتمر، الأخوة والأخوات الحضور، أود أن أشكركم شكرا وأشكر اللجنة المنظمة لدعوتي لحضور هذا المؤتمر التعليمي الدولي لطب الأطفال بيديا دبي 9، والتي دائما تكون حصيلة الاستفادة لي ولجميع الحضور في مجال طب الأطفال كبيرة جدا. إن هذه اللقاءات تشكل أهمية كبرى وتأتي في ظل الأولويات للمؤسسات الصحية في الدولة للتطوير المهني وللكادر الطبي والفني والتمريضي ونشر المعرفة الصحية بين أفراد المجتمع، كما أنها تعتبر فرصة كبيرة للاستفادة من الخبرات والتجارب المحلية والخارجية وتبادل المعلومات والمهارات التي تعمل على توفير بيئة علمية خصبة وتساهم في إثراء المعرفة والاطلاع على كل ما هو جديد في هذا التخصص. إن العالم كما تعلمون يتغير من حولنا بسرعة مذهلة وبالذات في المجال الصحي، ولا بد لنا من الاستعداد له عبر البحوث العلمية في مجال طب الأطفال. وكما تذكرون من خلال حضور صاحب السمو الشيخ محمد بن راشد آل مكتوم نائب رئيس الدولة رئيس مجلس الوزراء حاكم دبي حفظه الله، أعمال منتدى دبي الصحي والذي نظمت هيئة الصحة بدبي، دعا سموه الجهات المتخصصة بالدولة لتكثيف الجهود وتوظيف العقول والكفاءات البشرية في بلادنا من أجل التركيز على البحوث والدراسات العلمية في قطاع الصحة ومواصلة البحث لكل ما هو جديد في مجال الطب. وأخيراً أشكركم جميعاً على حضوركم وتواجدكم معنا لإثراء مثل هذه اللقاءات، كما أشكر اللجنة المنظمة والشركاء، وأخص بالشكر الأخ الدكتور شريف مسعد الذي حمل على عاتقه مسؤولية إقامة مثل هذه المؤتمرات. ولا يسعني في نهاية هذه الكلمة إلا أن أشكركم جميعاً وأتمنى لكم التوفيق. السلام عليكم ورحمة الله وبركاته.
Thank you, Dr. Abdullah, for that warm welcome. Now, next is the Acting Chief Academic Officer and Dean, Ras Al Khaimah College of Medical Sciences, Ras Al Khaimah Medical and Health Sciences University, Dr. Bairi. Sir, please give him a warm applause.
A very good afternoon to all of you. Assalamu alaikum. Dr. Abdullah, Honorary President of the conference, Dr. Sharif, the Chairman of the conference, distinguished guests, delegates, I would like to thank the organizers for giving me the opportunity to be a part of this conference. It gives me great pleasure to address you all on this auspicious occasion of 9th Pedia Dubai International Conference. First of all, I would like to convey the message from Dr. Yasser Al-Naimi, Vice Chairman, Board of Governors of Iraq Medical and Health Sciences University, and Dr. S. Gurmod Rao, President of Iraq MHSU. Both have wished for the grand success of the conference. Let me in brief apprise you all about the Iraq Medical and Health Sciences University. It is a government of Ras Al Khaimah institution. It has been set up under the visionary leadership of His Highness Sheikh Saud bin Sakar Al Qasimi, Supreme Council Member and Ruler of Ras Al Khaimah. The university was started in the year 2006. There are 4 undergraduate programs, namely medical, dental, pharmacy, and nursing. Further, the postgraduate program, MS program, was started in nursing and pharmacy. And this is the first university in the UAE to start the MS program. The university is providing a favorable ambience for learning and in the process establish the legacy of academic quality. In fact, our students who have pursued their higher education in countries like USA, UK, Australia, Germany, etc., are excelling in their chosen field. Further, more than 600 nursing graduates, 50% of which are nationals, are serving this country after their graduation. In this way, the university is contributing to emeritization of the nationals. Thanks to His Highness Sheikh Saud bin Sakar Al Qasimi, Supreme Council Member and Ruler of Ras Al Khaimah, for sponsoring the students to nursing program. In addition to teaching and learning, the university is giving equal importance to research. A central research laboratory was established in the year 2018 with all modern equipments, and a central animal house was established in the year 2019. So far, about 600 research papers were published by the faculty in various national and international journals. Coming to today's conference, the organizing and scientific committees and the distinguished speakers have contributed immensely to make the conference more fruitful to all the delegates. As I can see, there are plenary lectures, subject updates and debate, educational workshops that will provide the opportunity to renew and inspire the knowledge, that will provide the opportunity to renew and inspire the knowledge and to debate controversies in various fields of pediatrics. I wish the conference a grand success, and I am sure each delegate will be enriched with up-to-date knowledge in pediatrics by the end of this conference. I would like to thank Dr. Sharif Masood for giving me this opportunity. Thank you all. Have a wonderful day.
Thank you, Dr. Bairi, for that wonderful speech. Then last but not the least, the chairman of the conference, senior consultant and head of pediatrics and neonatology department, our very own Dr. Sharif Mossad. Please give him a round of applause.
Assalamu alaikum. His Excellency Dr. Abdullah Khayyat, CEO of Jalila Hospital and the father god of pediatrics in UAE and maybe in all other countries. Dr. Biari, Acting Chief Academic Officer and Dean of Ras Al Khaimah College of Medical Science and Ras Al Khaimah Medical and Health Science University, and respected colleagues, distinguished participants, ladies and gentlemen, good morning to all of you. It gives me a great pleasure to join you at the opening of the 9th Pedia Dubai International Conference. Let me begin to extend my warm welcome and a special welcome to the guests who have come from abroad. Dr. Ashraf Abdul Baqi, he's my professor. He's a professor in Shams University, and he came especially to attend physically in this conference. Thank you all to coming and joining us here today, and we are pleased to able to welcome you all. This year's our conference, because of the special situation all over the world, will be hybrid, physical, and virtual. We have about 10 sessions, each session about 3 or 4 lectures, and we have about 5 workshops. So, and we are accredited about 18 CME hours from DHA. Again, it gives me a great pleasure to extend to you and a very warm welcome on behalf of my name and on behalf of the organizing and scientific committee. In this occasion, I would like to extend my sincere thanks to His Excellence Dr. Amin Al-Amiri. He Under Secretary of Ministry of Health, and he is supposed to come, but unfortunately he have an emergency meeting now. So he obliged and he sent his greeting for all of you. And inshallah, next year he will be with us. Also, I would like to welcome you, our honored guests, professors came from Greece and Poland and from UAE, and to discuss up-to-date lectures for various specialty in the pediatric. I wish you a pleasant stay among us and success in your work. Thank you very much, and hoping a great success to our conference. Wishing you all happy and fruitful time in Dubai. Thank you very much.
May I call on Dr. Abdullah to receive his plaque of appreciation. To be awarded by Dr. Sharif.
I think this appreciation should go to you guys, really, and to Dr. Sharif. I have to be here with you. Really, it is my pleasure. I feel that I'm a member of this group since early 70 when since I was graduated from Egypt, Cairo University. Shukran.
Thank you, Dr. Abdullah. Dr. Abdullah deserves not diamond appreciations. He's the best in the world. So just a small gift for Dr. Abdullah. It's a trophy. Because of this situation, they are asking us to put on the bag. So I will give Dr. Abdullah this small trophy. And thank you very much, Dr. Abdullah, for giving this chance for us. On behalf of Dr. Amin Amiri also, he will receive Dr. Abdullah on behalf of Dr. Amin. And for university, please also we welcome the Dean to take the trophy and appreciation from the conference to the RAC University for her cooperation and her support.
Good afternoon, everybody. We will be back to our scientific meeting. Today, our valuable speaker, Dr. Khalid Khalfan. Dr. Khalid Khalfan, consultant pediatric surgery, assistant director at medical affairs for Al Qasmi Hospital, Women and Children Hospital, and his talk will be about overview on neonatal surgery. So please welcome with me, Dr. Khalid.
Assalamu alaikum. Good afternoon, everybody. Actually, we'd like to thank Dr. Sharif and the committee of this fantastic meeting and conference, which really we enjoy it because it is just a physical meeting after starting the partial release from the COVID-19. We hope all of you went through this period in a good and well condition, and feel sorry for people who really lost them during this period. I will not give big production and introduction and actually for these topics. As you know, most of our pediatric surgery topics including neonatal surgery. And neonatal surgery accommodate for a lot of congenital neonatal problems which happen during this period. So today, just I would like to elaborate on the main concern for the pediatric surgeon, to share it with colleagues, neonatologists and pediatrician regarding the neonatal surgical cases and how to deal with these cases. Once we talk about those cases, first of all, we have to think and straightforward start from the esophagus. So we will start with esophageal atresia, and as you know, esophageal atresia considered as one of the common congenital problem in neonatal age group. Is it not that common as you expected, but it is not also as rare as it's mentioned in literature and textbook. We are in UAE seeing frequent cases with esophageal atresia because maybe of variety or multinationality situation. Part of it, we have 4 cases of esophageal atresia in the last 1.5 months, which was really a variety of cases which led to be treated and dealt as we will discuss it. So esophageal atresia, just everybody know the baby how he will present, either antenatally, who will diagnose with polyhydramnios and high suspicious of esophageal atresia or small stomach and other type, or after birth, baby start to feed, he will vomit, he will have frothy secretion, and you will put our neonatologist or pediatrician just will start to try to push NG tube, which it's not passing with resistance. When you will do X-ray, exactly this is what you will see. You will see that there is coiled NG tube. So diagnosis is very simple, straightforward. No need to do further radiological investigation to prove it, because this is the diagnosis. Only the type for the surgeon, very important when you know about the type. So you have to know exactly, is it type 3, which is with distal tracheoesophageal fistula or isolated type, because this is very important in the plan for surgery, either to do it as one stage or like by tracking technique or different stage. So all of this should be considered when we are considering the tracheoesophageal fistula. One of our main concern, once we diagnose esophageal fistula, to prepare the baby for surgery as soon as possible, but before that we have to do echo. The echo will trace 2 things. First of all, we'll rule out any other anomalies, which can be an association with factorial anomalies, okay, or to also know, is it normal arch of aorta or not normal. So this is very important when we when I approach for surgery. So this is how it will look. This is the right side of the chest, and baby lying down, the lung is down. So just here, if it is right arch, not left arch, it will disturb my dissection. So I have to prepare myself before I am going. This is, I have to do mandatory echo before I am going to operate on this baby. Actually, most of the cases you will find that the distance, it's not that much. So this is the proximal esophagus, and this is the distal one near the tracheoesophageal fistula. So just you have to cut this part and re-anastomosis with the other part and end by thoracoscopic approach nicely and safely, everything close and fine. But in case of long gap, you have different technique. We are not talking now about the different technique for pediatric colleague, but we need to elaborate on these issues which is related to pediatric medical. So second case, which is also another most common cases in congenital neonatal anomalies, which is diaphragmatic hernia. The congenital diaphragmatic hernia, as you know, it is 50 to 60% antenatally diagnosed between age of 16 and 24 weeks. This is what you will see, just you see the bowel near to the heart and the fetal medicine with polyhydramnios or other things. Postnatally, it is very classic. Baby will be distressed. X-ray will be done. You will see the bowel inside the chest, either right or left. So diagnosis also, it's clear. But you have to go directly for surgery. Actually, those babies, I just will run the video and we'll keep talking. Those babies, actually, the surgeon rule is the minimal rule in those cases. Our rule in these cases very minimal. We are dependent on our neonatologist, our pediatrician who's dealing with these cases to manage those cases, because those babies will die not from the defect in the diaphragmatic hernia. They will die from the pulmonary hypertension, which is the consequel and sequelae, I mean, of this disease, the lung hypoplasia or aplasia. So you have to manage those babies well, control the pulmonary hypertension, and assure that the baby in low parameter of ventilation. Always we are telling the parents in the team meeting with our neonatologist that we will come when the neonatologist will tell us this baby is for weaning from ventilation. Well, this is the best time to do this type of surgery. This will take from 5 days to 10 days. Actually, the problem that if you go in a hurry and to do it, because this is the old thought, you may increase the pulmonary hypertension and lead to pulmonary hemorrhage, and you will lose the baby. So those babies, don't touch them if they are still having pulmonary hypertension. And the best way to do it to prevent baby transfer after birth. So those babies supposed to be antenatally diagnosed, delivered in a pediatric surgery center who can deal with these cases. So you will minimize the stress on the baby that will increase the pulmonary pressure. This is very important in management of diaphragmatic hernia. Actually, this will be the end result after you are suturing the defect. And in this case, it was with sac, as you saw it in the video. So in this case, just you will repair it with non-absorbable sutures. You will, by the end of the surgery, you will see that that everything is fine. You ask your anesthetist to inflate the lung to make sure that the dome of the diaphragm moving nicely. Once you did all of this, so your surgery is finished, and that's all. So we are coming now to another rare entity, but those neonates, they are not coming straight forward after birth. They may be discharged and coming after 1 or 3 weeks with vomiting, non-bilious vomiting, which is not explained. You may do X-ray, you have suspicious stomach, doesn't look normal, but just keep watching. I got colleagues from other hospitals who just refer similar cases within 6 months. with the same presentation. Baby discharge well home, feeding well, all of a sudden start to have vomiting, and there is nothing, no distal obstruction, nothing. But in those cases, think about the gastric volvulus. So once you think about gastric volvulus, you have to proceed for the upper contrast. With upper contrast, you see this is the organoaxial actually volvulus of the stomach due to twist, and this is very characteristic of gastric volvulus. So you know now what's the diagnosis and how to treat this patient. In many gastric volvulus, it is very mild and it can resolve, but in some cases, you have to go and interfere. So with laparoscopic choice, it gives you also more option to interfere early because it's minimal invasive and baby can start feeding the second day without any issue. And it is very simple, just you have to fix the stomach. So as you see, the stomach here, I will maybe by cursor, you can see better. So the stomach is very floppy and the greater curvature is just floating because there is no fixation with the spleen by the short gastric and gastrosplenic ligament. So the stomach is floating and twisting all the time. This is why you have to fix the stomach to the abdominal wall, as you see by when you're doing gastrostomy. This is why in old ages, people is just putting gastrostomy for a while to make this fixation, and then they will remove it. So that was the treatment, but now you no need to put gastrostomy. With laparoscopic, you can fix it well without any issue. Going now to talk about another rare entity actually in neonate, which is the pyloric atresia. And pyloric atresia, very interesting that it is very rare, but still we are seeing here in the country, as I mentioned, because of variety. But it's running with other syndromic episode, most of the time with epidermolysis bullosa, which can associated with pyloric atresia. But those kids can present immediately after birth with just not tolerating to the food and vomiting. Actually, when you are doing the X-ray, you will find the classic actually single bubble sign, which will lead you to the diagnosis. Sometimes you don't need even to do upper contrast to make sure that this is pyloric, but just sometime for scientific and also approval that this is a pyloric, so you have to proceed with upper contrast study. So once you confirm diagnosis, so you have to deal with obstruction. Most of the time, the failure of canalization as embryology study, teaching, and this part lead to this pyloric atresia. And as you know that the pylorus, in this case, for example, it is very hard and it is completely blocked. So as you see it here, so just you need to excise it and bypass this obstruction. You have by laparoscopic technique, you have all the option to do it nicely and under gross magnification. And just once you fix a pre and post obstruction side, you have to work with it by just going through this obstruction, try to open it, and just if it's failed to recanalization of the same part, you can just, as I mentioned, bypass this part. So this will also add a lot of things in it. Just I will be quick because our time also limited and we have a lot of point to discuss. So this is just after we opened completely the pylorus. As you see, there is no mucosa inside. It's completely occluded by hard mass, which is the atresia part. So just now you have to connect the mucosa from proximal to distal to just make the passage normal and fine. Once you do that, so your surgery will be almost done. So this is just, I think, last step to show you how it will look at the end of the surgery. Duodenal obstruction, it will be the same as pyloric, but as you know, the classic way here, that it will be double bubble sign. So you will see antenatally, you can diagnose the duodenal atresia now with advance of 4D ultrasound fetal medicine service, and also polyhydramnios is another also indication for the obstruction. A classic X-ray after birth, you will see the double bubble sign. So we'll know, and most of the time it will be related to the bilious vomiting, or non-bilious vomiting, but there is cases that related to bilious vomiting. So 85% will be non-bilious. This is exactly, if you do also contrast, you will see that the first part intact of the duodenum, but second part completely obstructed. The approach, I think you saw it, it's almost the same as we saw it now in the pyloric atresia, and duodenal atresia also will be the same. So just you have to suture and re-anastomose the bowel part, proximal and distal to the obstruction. Once you did that, so your procedure is almost done. So you start like by diamond shape, the classic diamond shape surgery, and you are doing after you finish it. So just you check for the any anastomosis leak. Once everything is done, anastomosis look nice. So just you have to return everything in its normal position, and your surgery is done. And as I mentioned, just you can do like see the distal also saline is floating nicely now to the proximal part of the jejunum. So this is exactly how we are doing it. We are coming now more down. If you can just also see that most of our neonatal surgical cases is GI cases, and this is the most common. So the GI considered like 80% of the neonatal surgery in this age group of babies. The distal small bowel atresia, as you know, it is also reported as high as 1 in 3,000 live birth. Also 1/3 are low birth weight baby, and there is risk of some medication was mentioned also in literature. The classic presentation, baby will come with bilious vomiting, not necessarily immediately after birth. It may be 4 or 5 days or even 10 days after starting feed, especially in case baby in the NICU and feeding start a bit late or slow. Feeding intolerance, abdominal distension, passing normal meconium. And this is very crucial. Doesn't mean that baby passed meconium that you ruled out the distal obstruction. Still, distal obstruction is very important. So this is example of X-ray, which was taken like after 10 days of baby having abdominal distension, which show dilated bowel. The important thing always for our pediatrician colleagues, when they are proceeding with investigation, don't do upper contrast because you will be confused. Start with gastrographine enema. Contrast, so lower contrast to delineate the large bowel, because most of the time it's diagnostic and therapeutic in the same time. So just start with the lower part. Once you reach the lower part, you now delineate where is the defect. It is at the terminal ileum, so then you will proceed. You can add upper part if you like, okay, and it will show you the dilated part of the large bowel. As you see here also, the classic atresia, it is just shown here. This is the dilated part and this is the atretic part. So just you'll proceed with the primary anastomosis without need for any ileostomy formation. One of the most important to discuss it with colleagues, I know it is well known, but malrotation and volvulus. And the problem in those, in baby's age group, most of the time it's detected early and no need to worry about it. But once the baby grow up more than a month, it start to be more risky because not to recognize. I'm giving this example because this example for one baby who was born actually in the hospital, he was absolutely fine. Just within 24 hours, he started to have vomiting and immediately taken to the NICU. After 3 hours, they call me, baby not doing well, please do upper contrast. It was obstructed. We took him for OT. This was the result. Even sometimes babies in the hospital, you have to take care. Every minutes and hours on those babies matter. But you have the hour, you have to count the minutes in those babies and how rapid you have to act, because you don't to end with baby with short bowel syndrome that you restrict his whole bowel if this can be detected early. So how we can proceed? Any suspicious bilious vomiting baby, you have to rule out malrotation before proven otherwise. So upper contrast is the key stone here to diagnose. There is a variety of malrotation. You have to think about it. You have to discuss it with the radiology. You have to guide your radiologist how to delineate it. Don't rely only, we will do plain X-ray, because it will not help that much. Actually, this is how the malrotation will look. So complete the volvulus, complete rotation, and the bowel is strangulated. So just you have to untwist anti-clockwise to relieve the obstruction. So management mainly can be by laparoscopic if the boy is bigger than like 3-4 months, but in small neonate, sometimes by laparoscopic with dilated bowel, it is not easy to proceed by laparoscopy. But at least by diagnostic laparoscopy, you can reach the final diagnosis and delineate your plan even with a small incision. One of the interesting case that with diabetic mother baby born, after that he didn't pass stool. Think also about left colon syndrome and meconium plaque. And here the nice of gastrographene contrast, it is the same therapeutic, diagnostic and therapeutic in the same time. This is baby just born with the same presentation, and we did the gastrographene contrast. You see the pellet of a stool here and the hard meconium and meconium plug in the whole the journey. Just few hours after doing the gastrographene, he passed this big meconium plug. This long, it almost was 15 centimeter, and baby improved dramatically. Didn't need any surgery, any further management. Went home after 5 days in a good general condition. But sometimes those things can even done by colleagues, pediatrician, neonatologist, in a good way without any hesitant. So meconium ileus, another severe form of meconium plug. With meconium ileus, I think most of you know you have to rule out cystic fibrosis and other factors, but still the dilemma always when you have issue of dilated small bowel, you have to think about distal obstruction. So just do the lower contrast enema, and you will find the diagnosis. Once you found that it is not simple plug, still the baby obstructive, so you have to take him and evacuate, do manual evacuation. You can see maybe here how the sticky, can you see the pointer there? It is not working. Okay, so this you can see exactly here how the sticky by suction. I am trying to take the meconium out of the bowel, and this is after the end of the wash. You have to do vigorous saline wash to melt the hard meconium. So one of the also interesting and important, and here we'd like also not to make colleagues panic always. Thank you, doctor. Colleagues always panic when you are seeing baby with anorectal malformation, because this is nothing. The baby born now, don't worry. Even he can stay with you for 24 hours until you can transfer him to the pediatric surgery center, because nothing to worry about it. Baby will start to have abdominal distension, but you have to wait at least for 24 hours to confirm the diagnosis before doing any surgical intervention. The boy, most of the time, will have the low type if they have meconium in the rapha and the perineal line. Girls, most of the time, they will have either vestibular anus, okay, or which can be treated conservatively until baby grow up at 6 months to do the definite surgery, because this will not cause obstruction, or it will be a complete or yani a kilwaka. In this cases, they will need another management. So the very important always when you are looking to those babies to wait for 24 hours, as we mentioned, and to do the invertogram. The invertogram now it's done in a nice way, not like the old-fashioned invertogram, but just keep the baby in prone position like for 15 minutes and just take an X-ray so with a coin or any radio oblique material to measure the distance between the end, the anal expected or supposed where to be anal opening and the gas shadow. So this will give you a hint for the surgeon, especially how to going to proceed. If it's low or intermediate, you can proceed directly for anoplasty, posterior sagittal anorectoplasty, or if it's high up, you have to go for colostomy. So this is exactly how to proceed. In this baby, you have to go direct and do anoplasty. This is the end result, and this is the gear. You have to finish it also with the anoplasty, but in case of high anomalies, you have to go for divided pelvic colostomy. Then you will manage accordingly later. Hirschsprung disease, I think this is one of the most common intestinal functional obstruction, but you have always to think about it once the baby failed to pass meconium within 48 hours and he's obstructed. So this is one of the also criteria. Hirschsprung disease, if you are plan to do contrast, please don't wash and do any rectal stimulation, because you will forget or you will miss the transitional zone in this contrast if you start to stimulate the rectal site. The surgery, as you know, you can proceed with the transanal endorectal bullet through, or you can, if it's big, it is huge, you can do either open or lab assisted bullet through. You have the two options. The pneumoperitoneum, one of the also just characteristic and common presentation in preterm babies to have a pneumoperitoneum and what we call it the football sign. So football sign, this means there is gas in the abdomen due to perforation. Very important, you have to differentiate between isolated perforation, which should be managed immediately by surgical intervention, or baby with neck who perforated, and this sometimes if baby too sick, you can just put a drain and wait until baby resuscitated well and recover from this shock state. But this is very important to know about it in case if the baby is now fine, so you have to take him for OT, just resect the necrotic or perforated site and do stoma for him accordingly. Other neonatal age group patient, those baby with biliary atresia who proved by height scan and other studies. So you have to go for major Kasai procedure, or babies who's coming also with strangulated hernia. Strangulated hernia, it should be reduced. Otherwise, you have to take babies for surgery, and you can do it even by laparoscope. This is the strangulation. You can see the bowel inside the internal ring, and this is after closure. And this is the classic bulge, which is cannot be reduced. So I think in those strangulated hernia now, the advantage also with laparoscope that it will give you advantage to look for the other side. So you can also manage this case immediately without any delay. As you see, this is the hernial site, and this is what you are seeing when you are entering the bowel. This is almost what look like hernia, but The other side is the normal hernia. Just I will do quick. This is the just final result after you do the bear string and close the hernia. So you will finish the surgery. In those cases, it is very rapid surgery. It can be finished in 20 to 30 minutes without any delay. So it is also advisable. Sorry for delay, but just to take home message for colleagues, I think it is always teamwork is the vital for our saving and serving our babies, okay, in the NICU or even in the normal pediatric ward. Early diagnosis and detecting of those babies is very crucial to reduce the morbidity and also can lead to later mortality, which can lead also to later mortality. But our teamwork and coordination in those cases, it will give us the great achievement and save our baby and will not lead to a catastrophic end scenarios in those small kids. Thank you for your listening.
Thanks, Dr. Khalid, for a very valuable presentation. Our second speaker, Dr. Muhammad Hassan. Dr. Muhammad Hassan, he's a consultant pediatric surgery at Al Qasmi Hospital, Women and Children, MOH Sharjah, and his talk will be about pediatric emergencies, pediatric surgical emergencies. And so please welcome with me Dr. Muhammad Hassan.
Good afternoon, Assalamu alaikum. I would like to thank you, Dr. Sharif, and the organizing committee for this challenging and amazing start of after COVID scientific meetings, which is of great benefit. It's honor for me to be here between you. Our talk today is non-traumatic pediatric surgical emergencies, which I think it's a very hot topic that we should share together, so we can know when we have to emergency receive our sick patients and non-emergency referrals. The topic, as you will see, that it is divided because of easy memorization to different age groups, and we will discuss in brief each age group. Regarding neonatal age group, Dr. Khalid elaborated on most of them. Diaphragmatic hernia, esophageal atresia, perforated neck, congenital intestinal obstruction, strangulated hernia, testicular torsion, abdominal wall defects, and imperforate hymen. In this slide also, I will mention about the urogenital sinus and cloaca. Urogenital sinus, we have a baby born, looks female, external genitalia, and most of those babies will be either having electrolyte disturbance in the first 24 hours, or they will have a huge lower abdominal central mass, and the baby is not able to pass urine. If we found something like this and we look at the genitalia down and we find in the vestibule only single opening, we don't find a urethra and vagina. So this is 100%, it's a urogenital sinus, and it is acute surgical emergency, because this should be dealt with a pediatric surgeon with the collaboration of endocrinologist, because we have to drain this huge vagina, which is the cause of lower abdominal mass. Second thing, cloaca, we will find a baby born boy, girl, with a single opening down. There is imperforate anus. There is only single opening in the vestibule. So also with the central abdominal, lower abdominal mass. So this is a cloaca, and also it's a surgical emergency because we have to do colostomy for those baby as soon as possible. The other urological pediatric surgical emergency is a posterior urethral valve. Most of these babies now, because we have antenatal scanning, they will be born with the antenatal scan of bilateral hydrourethronephrosis. Some of the good fetal ultrasonographers, they will pick up that the bladder is thickened and they will raise the suspicious of keyhole sign. Otherwise, if the baby is born without a previous antenatal scan, any baby born with bilateral hydrourethronephrosis, you should suspect before discharge posterior urethral valve until proof otherwise, because we are dealing with those babies before discharge, and it's make a lot of progress in their clinical prognosis if they have been treated early on. We are doing all this fulguration, surgically treating them before going home after birth. Early referral is very important also for the salvaging of the kidney status. The third item is the erythroseal. It can happen in boys and girls. Here, erythroseal, we will have a unilateral hydroerythronephrosis, usually with the duplex system by ultrasound. By the duplex system, maybe it's missed by the radiologist. So any massive hydroerythronephrosis unilateral should be also referred to a pediatric surgeon for further workup just after birth to exclude this erythroseal, because it's surgical emergency and we have to drain it before the patient going home. It can happen in boys or girls. The other age group, infantile age group, intussusception, congenital hypertrophic pyloric stenosis, strangulated hernia, and intestinal obstruction. Pediatric age group, testicular torsion, ovarian torsion, peritonitis, intestinal obstruction, and magnet swallow, which we are seeing a lot in these days. Again, I will not go in details for this. It's covered already by Dr. Khaled. As we mentioned, the diagnosis antenatal, mostly it's there. Majority of these infants develop respiratory distress at birth if they are not diagnosed before, and just X-ray, it will delineate that the patient is having diaphragmatic hernia. Critical point is to consider that it is a physiological emergency, not a pediatric surgical emergency. So if the baby born and the pediatrician anywhere in UAE knew that he is having a diaphragmatic hernia, it's a physiological and neonatology emergency, not a surgical emergency. Again, we should not ventilate by ambu bag or mask, and maybe managed with the high frequency or conventional ventilation. And the gentle ventilation with a permissive hypercapnia is very important to reduce the pulmonary pressure. Surgical management, as mentioned, we are doing all these cases in our hospital by thoracoscope. And as you see, the wounds after thoracoscopic intervention is very minimal. Tracheoesophageal fistula, I mentioned as well. We are doing all these cases in our hospital thoracoscopically with a very good results. This is in the left side here. This is a pure esophageal atresia because there is no fistula and gasless abdomen. On the right side, it is esophageal fistula where there is a gas in the abdomen. And again, the management for short gap or tracheoesophageal fistula, mostly we are doing it within 48 hours of birth. And it's very important to do it early, so we will decrease any negative effect on the lung. For long gaps, we are doing gastrostomy, and we are waiting a few months until we will do the definite surgery. And this is the post-operative follow-up of one of our cases. As you see, there is no incision almost. For congenital intestinal obstructions, intestinal atresia, meconium ileus, malrotation, and volvulus Hirschsprung disease in perforated anus. I will go very fast on it because most of these topics have been discussed. Meconium ileus, as we know, mostly it's coming with the cystic fibrosis. And again, there is two types, simple meconium ileus and complicated meconium ileus. And this is, again, it's different in the referral timing. It's important because simple can be managed within 2 to 3 days. Even gastrographin enema, as mentioned before, can be therapeutic in 30% of the cases. But complicated meconium ileus, patient will be born with a very hostile abdomen. Patient will be very sick because most of them, they will have a perforated bowel and pseudo meconium cyst. And sometimes we are a pediatric surgeon confusing them with volvulus neonatorum. For radiological imaging, as we see here, this is a nice X-ray for a patient with meconium ileus. As you see, dilated bowel. The only thing, this is intestinal obstruction, but with discriminated from the normal intestinal obstruction of atresia, that as you see in this erect view, there is no air fluid level. So by this, we know that it is meconium ileus. And when we do lower contrast, as Dr. Khaled mentioned, we don't do upper. Lower contrast, it's therapeutic, and we have to reach to the terminal ileum to dissolute the meconium, and it can be therapeutic once, and we don't have to do surgery. For a simple one, as we mentioned, the patient should be well hydrated because gastrografin, it's too much osmotic and it causes dehydration of the bowel. And if failed gastrografin enema to be therapeutic option, we have to go for surgery to evacuate the distended bowel. For complicated one, it's a surgical emergency. And again, most of them, they will have a meconium pseudocyst. And what we are going to do for surgery, it depends on the findings. Most of the time, we have to do resection anastomosis and something we call chimney ostomy. So we are bringing the distal bowel opening to the proximal and the proximal bowel outside. So we can do wash out every now and then until the patient will have full feed. Then later on, we are closing this. Going to malrotations, which already discussed here, only I will mention the embryological aspect of malrotation. I like to mention this very importantly because me personally, I was not understanding what is malrotation. Malrotation, as you see, the cecum is lying up above the duodenum, not in the right iliac fossa. It is up. And there is a band between the cecum and the duodenum that is obstructing the second part. And in the meantime, the duodenum is not going a C shape to the left of the vertebral column. It is going the duodenojejunal junction down right away. So the arc of the mesentery is very short, and this bowel is very liable for torsion. This is why it may develop volvulus neonatorum. And as we see here, this is the torsion because of the arc of the mesentery is very narrow. And again, what we are doing in surgery, we are dividing this bands, and we are getting the cecum to the left side, so we are widening mesentery. And this is a diagrammatic schematic presentations of the embryological cause. As you see here, the mesentery up is very small, narrow. This is why it's liable for torsion. And down when we are doing our surgical intervention and widening it. And as you see here, the final image, we transferred the cecum to the left side of the abdomen and all the small bowel now on the right side. And all the bands released. Appendix, of course, it's removed also because the cecum is in a different position. And as you see now, the mesentery is widened, so there is no liability for torsion. This is a picture of, on the left side, it is for volvulus. As you see, we call it omega loop. It's very angry abdomen. Those patients should be, as Dr. Khalid mentioned, the minutes count to save the bowel in those babies. So we should have a very high index of suspicion. And this is a normal malrotation without volvulus. There is a paucity of gas down in the lower half of the abdomen, and there is dilated duodenum and the stomach as we see up. And once we see this picture also, we should book the patient in the nearest surgical list to avoid any undesirable complication. Here, the bird's beak, it's a very significant sign for volvulus. And on the other side, it's malrotations without volvulus by upper contrast study. Again, as a surgical key rule, any sudden bilious emesis in a healthy child, it's a very ominous sign that should aware us for volvulus. And this patient should be not left until surgically dealt with. Again, going back to the abdominal wall defect, we have omphalocele and goscaresis. As you see, these babies will be born. The pediatrician in the OR after cesarean section will call us. We have these babies. Here, this one, it's a case of omphalocele major in which the defect is covered with Wharton jelly membrane. And on the other side of the screen up, it is the omphalocele minor, which we take these babies to the theater and we close them right away after birth. Omphalocele major, no. As well as the gastroschisis in the middle, this is a gastroschisis, which is abdominal wall defect to the right side of the umbilicus and not covered with the Wharton jelly. And those two cases, the omphalocele major and the gastroschisis, we are doing it staged as we see down with the silo that we are reducing it to the abdominal cavity gradually until we have all the bowel inside. Then we close the abdomen primarily as we see at the lower down part of the screen. Sorry, the pointer is not working. Again, all these babies should be delivered by cesarean section if it is diagnosed antenatally. And for omphalocele, mostly they have associated congenital heart disease. For gastroschisis, they don't have. Neonatal testicular torsion, this is antenatal torsion happened already, and the baby will be born, and after birth, the pediatrician or the mother will discover that the patient having a very hard mass in the scrotum and will be referred to us. This is, again, it's an emergency in the diagnosis, but again, surgery can be done within few days because already gangrene happened, and usually we are removing this gangrenous testis, and we are fixing the other one. Imperforate hymen, again, another surgical emergency. A baby girl born like this, and after birth, the pediatrician discovered that she is having this swelling in the vestibule. This is imperforate hymen. This picture, we should also differentiate between this and the urethrocoel, because some cases of the urethrocoel, which we mentioned early on, sometimes it can prolapse from the urethra and give the same image. So we should be careful when we take decision to take these babies, those imperforate hymen, we took them to a next list to do crochet incisions, and that's it. But in urethrocoel, we should do catheterization for the urethra to make sure it is not urethrocoel, because it's completely different management. So we as a pediatric surgeon have to be very careful, but both of them are surgical emergency. Again, for infantile age group, intussusception, again, all of us know this. You are diagnosing those cases better than us. A healthy child, 6 to 18-month-old, most of them are having a primary intussusception, which there is no leading cause. Most of these children having a history of gastroenteritis or upper respiratory tract caused enlargement in the mesenteric lymph nodes, especially the terminal ileum lymph nodes, causing as a pseudo leading point. And they will be presented with abdominal crampy pain. This is very significant to have high index of suspicious at this stage. To wait for a current jelly stool and for absolute constipation and vomiting, this is a very late sign. If we see those patients as a pediatric surgeon, usually we are not doing for them a radiological reduction because this patient already having gangrene. We should pick them early on so we can save them without any surgical intervention by doing only radiological reduction. Okay, and this is again enema reduction. It's diagnostic and therapeutic in the same time. Ultrasound is the only 100% diagnostic tool. X-ray, it's 50%. So we should have a very high clinical suspicious always. Again, we don't want to have this picture as a surgical intervention because as you see, the intestine is already melted from the late diagnosis. Congenital hypertrophic pyloric stenosis, again, baby, most of them coming in a boys, 1 week to 2 month age group, progressive projectile vomiting of curdled milk, as well as constipation. Some of them, if they are very late presenters, they will come with a loss of weight as well. Now we are rarely seeing a baby with a congenital hypertrophic pyloric stenosis with a lost weight. Again, feeding test most of the time is very diagnostic, in which we put the baby in the lap of the mother and let the mother feed the baby. And during this, we just palpate the epigastrium and we can feel the olive tumor or the pyloric mass. Again, ultrasound should be 100% diagnostic. We see the length of the pyloric canal. It should be more than 16 millimeter. And the thickness of the pyloric muscle, it should be more than 4 millimeter. If it is like this, we just diagnose him. We are not doing any other contrast study anymore at all. It's not advisable. And again, we should correct the electrolyte imbalance those babies having before surgery. So we are admitting them, correcting the electrolyte imbalance. We have also always to remember that they have a very low caloric intake. So we should give them 10% dextrose with the electrolyte imbalance to prepare them for surgery, and should be slowly corrected. We shouldn't be in a hurry because severe alkalosis and hyponatremia need slow correction to decrease the risk of pontine myelolysis. And again, surgical intervention, it can be done open, but in our hospital, we are doing all these cases surgically, and most of them, they are discharged after 24 hours with a great results. Again, intestinal obstruction, usually in this age group, it's a congenital band or internal hernia or intraluminal lesion. and it can present with any age. This is a case of congenital band that it was causing gangrene of the bowel. For pediatric age group, again, acute scrotum, it's a very common presentations any time of the year. And again, the differential diagnosis, testicular torsion, torsion of the appendix of the testis, appendicitis or orchitis, hematocele, trauma, idiopathic scrotal edema. We have also a golden rule here as a pediatric surgeon. Once we are having a dilemma in the diagnosis of those cases, we are doing surgical exploration, even if it is negative. Because to lose testicular torsion, ultrasound, it's very cheating in this diagnosis. We cannot blame the radiologist that he missed the diagnosis. So always, if we have a clinical suspicious, we should operate on the child. As you see here, a variety of patients we operated upon, and the blue dot sign, it's characteristic for torsion hydatidum morgagni. If you are sure about this clinical diagnosis, we are conserving them. This torsion hydatidum morgagni. Ovarian torsion, again, need high index of suspicious. History is very sudden, and in adulthood, it's usually related to menarche. But again, we have to remember also it can happen any age. In 2-3 years old girl, it can happen. Again, it would be characteristic of sudden colicky, abdominal pain, suprapubic, and associated with a reflux vomiting because not of the GI, because of the severity of the pain. And some of them recurrent. So the mother will tell you 3-4 months she has this severe colicky pain, all of a sudden it goes and she become comfortable. And if we do ultrasound, we will have a pelvic mass. Sometimes also the radiologist will not know that it is ovarian origin. Again, we are doing these cases laparoscopically as it's seen here. It's full blown here torsion ovary, and we did for this case salpingio-oophorectomy. Peritonitis, again, peritonitis in children can be either due to perforated appendix, perforated Michel's diverticulum. But one message also we want to convey that peritonitis, sometimes it present with acute intestinal obstruction because of the late diagnosis. So if we see multiple dilated bowel loops, okay, in a tender abdomen, we have to put suspicious of peritonitis in the first differential diagnosis. And this is examples of patients we had for Michel's. We did it also laparoscopically or perforated appendix. Last slide, magnet swallow. We are facing a lot, and I wish that you will distribute this in the community to warn everybody you know, patient, family, friends, about this magnet, that it should be prohibited totally from our homes, from our schools, from our community. Unfortunately, again, still it is very cheap prices. It can be got through the internet. We are facing every month a disaster from this magnet. As you see, all these magnets was swallowed in a 2-year-old child. The child came in a septic shock. He was about to die because of this toys. Please, any more than single magnet swallowed, it should be referred right away to surgeon, even if the patient is clinically okay. This is the references. Thank you so much for your attention.
Thanks, Dr. Muhammad, for very informative presentation. I think Dr. Nader is here. Still, we are running our scientific day. Our next speaker, our colleague, Dr. Nader Francis. Dr. Nader Francis, consultant pediatric pulmonology, Al-Qasmi Hospital, Women and the Children at MOH Sharjah. And his presentation will be about imaging, bronchoscopy guided diagnosis. It will be like a case scenario. So please welcome with me, Dr. Nader Francis.
Thank you. Thank you for inviting me, and thank you for attendance to wait for afternoon. I will speak about bronchoscopy in pediatric. I'm waiting the... Okay. Okay, this is non-conflict of interest. This is one look, it's worth 1,000 words. It's true. We can, one picture can explain us much better than pages. This is my agenda. I will go fast for the theoric part. I will have to give time for the bronchoscopy cases. This is definition. Bronchoscopy is a way permit us to look, to see, to visualize airway, upper airway and lower airway, and also to get some sample from the bronchos by doing lavage, bronchial lavage, or by doing biopsies, a different kind of biopsy. Now, recently, we can do some intervention by using bronchoscopy. Okay. This is two types of bronchoscopy. One is the flexible one, the other is the rigid one. Now we are preferring to do all major bronchoscopy by using a flexible one, but still this is place for rigid one only for foreign body extraction, to do some laser treatment and to visualize the upper airway, not upper airway, subglottic, and to diagnose, for example, cleft, laryngeal cleft. This is best to use rigid bronchoscopy. This is because this is invasive procedure. We prefer to do under anesthesia, of course. Can be under sedation, deep sedation, or general anesthesia. This is anesthetist to decide which type of anesthesia we're doing. We can proceed with bronchoscopy by face mask. This is the preferred way of pulmonologist, but it is the most challenging way for anesthetists. Anesthetists prefer to do bronchoscopy through the ET tube, but we cannot see, for example, larynx or subglottic, even a big part of trachea. For this reason, in our hospital, we are doing flexible bronchoscopy through LMA. This is complication. This is very complications very rare by using flexible bronchoscopy. The most common is hypoxemia, and this is stridor, laryngospasm, and we can improve it, reduce the complication by using local anesthesia. And this is complication related to bronchoscopist. This is the most common and most dangerous, the vagal stimulation, and can be manifest by bradycardia, severe bradycardia, or even heart arrest and infection. Infection is very rare, but fever not very rare. Common fever after bronchoscopy is common. Around 50% of patients underwent bronchial lavage. They will develop fever within 24 hours related to inflammatory issue, not infectious issue. Pneumothorax and pulmonary hemorrhage, this is more common in interventional bronchoscopy. And this is contraindication. There is very few contraindication. Absolute contraindication, severe hypoxemia, hemodynamic instability, and hemorrhagic issue. And some of this absolute contraindication are indication to do bronchoscopy. For example, patient with acute tracheal obstruction by foreign body, we should do bronchoscopy. And patient with massive hemoptysis, we should do bronchoscopy. Relative one, the preterm or severe preterm. Now with progress of instrument, we can do easily in small preterm. Our youngest baby, it's premature 28 weeker with 800 grams. Indication, there's indication so common, we have a lot of indication. Any chronic symptom, any chronic diagnosis. Chronic cough, chronic pneumonia, chronic atelectasis, recurrent persistent pneumonia, bronchiectasis, uncontrolled asthma, all this those are indication to do bronchoscopy. This is indication to evaluate airway from upper airway nose till the bronchus. And for example, laryngomalacia, vocal cord dysfunction, tracheal compression, wheezing, lateral wheezing, lateral hyperresistant lung. In ICU, duly we are using more and more bronchoscopy in ICU. This is a systemic review done in USA and showing there is in PICU unit the average of bronchoscopy done is around 150 bronchoscopy per year. We have a lot of indication, persistent, difficult to intubation, difficult to intubation, difficult to extubation, difficult to ventilate, different to oxygenate, a lot of indication. Interventional bronchoscopy is new in pediatric. We can do now bronchial lavage for a therapeutic issue. We can do biopsy, transbronchial biopsy, endobronchial biopsy, and now we can do transbronchial needle aspiration guided by ultrasound EBUS. And we can, for removal foreign body, to put stain, to do bronchial dilatation, a lot of indication. One word about bronchial lavage, because it's safe, and we should do bronchial lavage in each bronchoscopy. It is the aim of bronchial lavage valve to get cellular or non-cellular complement from the airway, and this is from especially from alveoli, by injected to let's see, to analyze it and to help us for the diagnosis, especially inflammatory lung disease. How we'll do this is we prepare 3 aliquot of one of free-warmed normal saline. We inject the aliquot in the desired area. We inject it manually as fast as possible, and we withdraw directly. And by this way, we create flow to aspirate this complement. We should, to be correct, we should recover at least 40% of fluid, and the majority of cells should be macrophages. Normally, okay. The sample are sending to bacteriology, virology, and to histocytology, and now with molecular biology, we can do some immunostaining, and we do measure now interleukin, different type of interleukin, CD1, CD1A, and CD4, CD8. Now, before showing the video, this is some anatomic. When are doing bronchoscopy, we should see in the trachea this view. This is carina. We should see in the same time right bronchus and left bronchus. If we cannot see the both together, means there is issue, there is problem. This is compression, there is atresia, there is issue. When we go in the right lung, we should see the upper lobe, lower lobe, and middle lobe. This is 3 view. We go to go inside the upper lobe. We should see this is 3 orifice, like triangle, 1, 2, 3, apical, posterior, and anterior of in the right lung, in the right upper lobe. If we cannot see, this is mean there is issue. In the left lung, this is upper lobe, and this is lower lobe with lingula, and this is right lung. Sorry, this is lower lobe, and this is middle lobe. Middle lobe is slightly smaller than lower lobe, and this is when you go inside the left lung. This is upper lobe, lower lobe with lingula. Now I will present some cases. This is video. We can see this video. This is the dynamic view of what I just told you. This is the carina. We can see now this is the left lung. This is the upper lobe and the upper lobe, and this is lower lobe of the left lung. This is now we are going to the. It's still the left lung, and this is the right lung. This is the upper lobe. This is the lower lobe. This is the middle lobe, and we will do now bronchial lavage. You see, this is the installation of normal saline, warm normal saline. This is the installation. You see, this is here, and this is suction. This is bronchial lavage. This is section, and this is middle lobe, and this is the upper lobe. We see the upper lobe. Hopefully. This is the upper lobe with 3 orifices. 1, 2, 3 orifices. Going. And this is the first case. Our first case. This is 6 years old girl. It's referred for chronic cough and persistent pneumonia in the right lobe, right middle lobe. There's negative history, nothing, no foreign body aspiration, nothing. CT scan showing atelectasis in this area. And this is bronchoscopic, what's showing? We'll see. We will see. This is normal larynx, normal vocal cord. This is inside. Normal view of carina. We can see the both of this. We can go on the right side. What happened? Oh, what happened? Why I cannot choose the video? Okay, sorry. Can be for a body, can be another thing we will see. This is, sorry for repeat. This is the vocal cord, and this is the trachea. This is the carina, orifice for the carina. And this is when we go inside the right lung. This is the upper lobe, and this is the lower lobe. And the middle lobe, what we find about the middle lobe? What do you see? Small middle lobe, around stenosis of around 50% of middle lobe. Reduce the caliber of middle lobe. And this is name of middle lobe syndrome. And middle lobe syndrome, we had a lot of differential diagnoses. The most common asthma, GERD, and compression. Compression by the most common compression due to the tuberculosis. And CT scan normal. This is no adenopathy, no tuberculosis. We did spirometry. It is asthma. We start inhaler corticosteroid, and after inhaler corticosteroid, this is disappear of this. No more persistent pneumonia and curing of persistent pneumonia. This is other case. This is girl. 6-year-old, history, recurrent chest infection since birth, but apparently we cannot precise which side, right, left, up, down, you cannot precise, but did hospitalization a few times. This is in our hospital, this is X-ray, and we do bronchoscopy, what we see. This is vocal cord. You can see this is directly the right lung. This is the lower lobe, and this is middle lobe. And the upper lobe, what we see the upper lobe, we can see only 2 orifices, 1, 2. And this is stenosis atresia of one of the branch of the upper lobe. When this is, as we go here, this is, we can see 3. This is 3 orifices, 1, 2, 3. Sorry. What? There is issue with going picture or slow motion. Okay, here. This is the upper lobe. And this is 2 orifice 1. This is 1 small orifice. And the second one, when we go inside, we can see 3 orifices. 3 orifices. Mean there is normal upper lobe. And the other one, this is add a branch, small branch. And this is a small branch added. And the name of this small one, bad drainage, the name is this known case as congenital tracheobronchial branching anomaly. The most common, this is when the added branch came in the trachea, and the name, this is right tracheal bronchus. And this is a very rare malformation, lung malformation. And this is case number 3. Patient since 4 months, present 4 years old, present with recurrent chest infection, recurrent persistent pneumonia, needed hospitalization 4 times. This is negative history, no shocking, nothing. We do bronchoscopy, we see this is granuloma. We cannot see anything because there is bleeding. We do bronchoscopy lavage, and we can see here something. We go deeper, this is foreign body. This is foreign body was hard pieces, I think was stone. And this is image from our archive. This is foreign body view from the bronchos, and this is foreign body plastic. This is plastic foreign body. This is this is almond, and this is peanut. This is was 10 pieces of peanut in same patient. This is an interesting case. Girl, teacher calling girl with 7 years old, since 1 month, fever, weight loss, lymphadenopathy, hepatosplenomegaly, diagnosed as EBV because the serology of EBV were positive, and treated with antibiotic, not improvement. Mother mentioned once time she got a steroid, and there was dramatic improvement. And refer to our hospital, and we decide surgeon to take biopsy from cervical node. And during preparation, during intubation, I received call, come hurry, because we cannot intubate, we cannot ventilate per patient. This is, and she's in bradycardia. When I do bronchoscopy, this is a picture. This is total obstruction of trachea by pseudomembrane. I try to remove it by forceps, I cannot. I still it Dorenaz alpha with brushing. I remove it. This is a view, destroyed trachea with diffuse small tumor, granuloma. For me, and creamy secretion look like fungal infection of histiocytosis. Culture become positive for candida, and histopathology. This is a lymph node showing macrophage, a lot of macrophage, no malignancy, and we asked the lab to do, the histopathology to do staining for both bronchial lavage and lymph node, and became positive for protein S100, negative for CD1A. And this is typical for Rosai-Dorfman disease. This is for me was new. This is kind of histiocytosis. And we see here, this is diffuse node in the lung and diffuse node in the lung. And this is histiocytosis affect lymph node especially, and very rare can affect the lung. There is a case, premature, 27-week, RDS membrane disease, intubated, received surfactant, but difficult to intubate. This is with multiple, difficult for extubation, with multiple intubation, and develop after few days complete right lung atelectasis. We did bronchoscopy, and we see carina, large carina, very small orifice of right bronchus. I cannot go inside, and there is very small bronchus. The decision was to try to do balloon dilatation, but our neonatologists prefer to give chance to converse treatment, medical treatment, and working, because after 3 weeks, we see here there is improvement of caliber, not normal, but improved comparing by this one. And you see the chest X-ray of patient after that, no more right side atelectasis, and patient discharged after few time without and at home. There is Carmi syndrome. Carmi syndrome, there is Dr. Khaled just spoke about this syndrome. This is epidermolysis bullosa. Normally, you have 4 types of epidermolysis bullosa. One type of junctional, the epidermolysis bullosa, and there is 3 types of junctional, one of pyloric atresia. Pyloric atresia named Carmi syndrome. And Carmi syndrome is very rare disease. This is recessive hereditary, and now complicated with airway obstruction. And normally patient died with due to the airway obstruction. We received one patient of 6 months old with suffering, complaint from stridor, recurrent chest infection, history of prematurity, and pyloric atresia, and with huge family of pyloric atresia with epidermolysis bullosa. We did genetic study, we confirmed the diagnosis of Carmi syndrome. The first bronchoscopy, this is difficult to see, this is vocal cord, and here we cannot see the glot. This is almost complete obstruction, subglottic area, and this patient, by good chance, she's doing well. Stridor reduced spontaneously without only treatment dualization. For this one, we did bronchoscopy at age of 2 years and few months. This is only to diminishes vocal cord due to the reflux if a patient has reflux, and this is no more subglottic stenosis. And here we can see here no more subglottic stenosis. I review all the literature. Nobody prescribed spontaneous resolve of obstruction in Carmi syndrome. Can be the first, I don't know, maybe it's the first case. And this is, if you have time, I can see you a video for tracheomalacia. We can see here, this is patient in ICU with persistent stridor, difficult to feed for feeding. This is trachea. We see trachea is not normal. We can deep. This is trachea here, like go deeply here. Here's the bulging of posterior wall. It is abnormal, and we can see here like fish mouth. This is long segment of tracheal malacia, and normally those patients need put stent at this age. This is so risky. Nobody can put it, and to discharge patient on positive airway CPAP. And this is a few pictures from our archive. This is tough. So this is esophageal atresia, fistula, and this is the carina, and this is we see the fistula bigger than also than carina. Here we can see the carina is at we can see only the right bronchus. We cannot see the left bronchus because this is left compression. This is an inverse. This is right compression. And this case of vascular ring, here cyst on supraglottic. Here this is patient with chronic stridor. And when we do bronchoscopy, this is trachea ring, one kind of information. This is patient premature. This is difficult for extubation. And when we do bronchoscopy, this is stage 3 subglottic stenosis with cyst. I think a take-home message: flexible bronchoscopy is safe. Procedure done routinely in pediatric respiratory medicine, can be done in neonatal population. Now we can do it in small baby. The combination of clinical, radiological, and BAL can permit us to diagnose some rare disease. The interventional bronchoscopy is a promised procedure, still are not taken her place in pediatric pulmonary medicine. Thank you. This is all the reference. And this is, thank you, and I apologize for not spending time.
Thanks, Dr. Nader. I think we need to transfer a lot of patients for bronchoscopy. Thank you, Doctor. Our second speaker, Dr. Sami Weiss. Dr. Sami, consultant radiology at Sharjah University Hospital, and his talk will be about imaging of cardiovascular anomaly. So please welcome with me, Dr. Sami.
Thank you. Good afternoon. Let's start with the X-ray. Which one is abnormal X-ray in your opinion? All, actually it's all. But this fact is, all of this X-ray image are representing an abnormality in the cardiovascular. But the days that the X-ray give a specific diagnosis for the anomalies in the cardiovascular system, it's gone already. Due to the advanced other modalities and the reality that this anomalies usually delay to manifest their signs in the late childhood, and the fact that most of these anomalies are treated surgically and need to follow up so we miss the specific sign for these anomalies. The value, as we said before, the value of the classical finding are decreased to these facts. But still, in my opinion, as a radiologist, that the radiologist could be the first person who suggests that this anomaly could be a cardiovascular anomaly, not due to respiratory distress from the first X-ray image. And still we have some signs, some specific signs which could suggest the cardiovascular anomalies. We can mention to some of these signs. The first sign is eggs on string signs, which could be seen in the transposition of great arteries. This is the normal finding in the chest X-ray, and this X-ray for cyanotic child with grossly enlarged heart shadow and narrowing of upper mediastinum, giving this appearance of egg of strings. The whole heart enlarged due to the convexity of the right atrium and the at both sides, and the narrowing of upper mediastinum due to atrophic change in the thymus due to stress, which give this appearance, which could suggest this malformation of transposition of great arteries. Another example. Okay. Okay. Snowman signs, which represent, probably I can't see from, okay. The total anomaly of the pulmonary venous return. Sorry? Yeah, that's what we talked in the beginning. Okay, but we can go through some specific finding which could become more clear in the late childhood. So this sign, the total anomaly of pulmonary venous system, usually all the drainage become in the single vein, which go through a vertical vein draining into the left brachiocephalic vein, which give this appearance on the X-ray. The paratracheal, right paratracheal, due to prominent superior vena cava, and the left due to the vertical veins, and the rest of the heart, it's giving the body of the snowman, which give this signs of snowman, the head and the body. Okay. Semester anomalies, this bending shadow at the medial portion of the right lung could be due to, anomaly of the vessels draining of the right lung, sometimes draining into the inferior vena cava, and also may drain into the portal vein or hepatic veins. And the size of this sign or the size of this vessels depend on how many portion of the lung it's draining into this vessel. This diagram can explain the draining vessels, which become more enlarged in this case. Actually, this is an angiographic sign. This is a stenosis of outflow tract of the right ventricles, which given the appearance of gooseneck, narrowing of the outflow of the right ventricles, and the convexity of the other portion of the ventricles in this angiographic finding. Okay, this is a very common sign, very famous sign. It's figure of 3 due to the correctation of the aorta, due to dilatation of the aortic arch, the stenosis, and the dilatation of the descending aorta, which giving this appearance of figure of 3. Or in the angiography, we can see the dilatation before and after the stenosis. And in the barium swallow study, we can see this reverse 3 sign, which also represent the indentation of the aortic arch upon the upper portion of the esophagus. Another very famous sign in the tetralogy of Fallot, it's a boot sign, the apex of the heart, it's uplifting up due to hypertrophy at the right ventricles. And there is another anomalies also, stenosis of the pulmonary and the overriding of aorta and the VSD defect. Another example of both. The grossly enlarged heart here due to Stein anomalies, giving the appearance of box, appearance of the heart. Another example of the hypertrophic right ventricle and displacement of the tricapsid valves and the stenosis of pulmonary artery and enlargement of the cardiac shadow. The conventional angiography is less common nowadays because of the advanced modalities, imaging modality, but this modality is still important in the guiding of therapeutic procedure, like in this example in the pulmonary stenosis, while this balloon dilatation of the stenosis through the angiography. Again, the advanced modality define the morphology and the connection and the function of the anomalies become rapidly more useful tools. The echography, which depends on the examiner itself, how much he is expert, which can be done on the antenatal and the neonatal period, can give highly details and anatomic formation of the cardiac anomalies, give a functional information, and the color Doppler can detect the stenosis or regurgitation areas. But this modality is limited in post-surgical cases and also decreased due to in the all children due to decreased acoustic windows. Here is an example for ventricle septal defect. Show the flow between the left and right ventricles. Another example from echocardiogram show dilatation of left ventricles in a child with dilated cardiomyopathy. Here is another advance in the CT angiography, which is more useful in the evaluation of anomalies. It's often give more details about the area which can't reach by echography, give more details about the structure and the connection between the structures, and the relationship between these complex cases. Also, it's very useful on the following of post-operative complications such as stenosis and occlusion and pseudoaneurysm. The benefit of CT scan include the rapid acquisition times, which avoid the need of sedation and could be especially useful in the ill infants, and it can give us a good access for the lung visualization. The disadvantage of CT scan, mainly the radiation for babies, and also it's depend on the IV contrast, and it gives less information about the function of the cardiac function. MRI give more details about the anatomy and functional information. The advantage also include there's no radiation in the MRI and give a many key imaging sequence and different technique like a black blood and cardiac gated spine echo and bright blood cardiac gated spine echo. So it can give us a good idea about the flow abnormality and give us a better contrast between the myocardium and the lumen of the cardiac chamber, and also give us a dynamic information about turbulent flow or stenosis and regurgitation. And the processing data, which can obtain from the cardiac MRI, can give us function information, especially about ventricle ejection fraction. MRI angiography is another technique which use the gadolinium, which can clear the anatomical relationship between the anomalies. You can see some example about how much details we can obtain through this modality. In the CT scan, here we can see ventricle septal defect, two ventricle septal defects. Another example in the MRI, atrial septal defect by MRI between the both atrium, which can guide the procedure for closure. And here is an antenatal ultrasound show clearly this arterial defect in this child. Congenital pulmonary stenosis, very nice image by CT angiography and volume rendering, show the stenosis of pulmonary and post-stenotic dilatation of pulmonary artery. BDA or patent ductus arterius, CT angiography show the connection between pulmonary artery and the aorta, and the volume renal image show clearly the connection between them. Another example for the semester anomaly by CT scan. This reformate image show how long and the size of the draining vessels from the right lung, which draining in the inferior vena cava. And the axial image show this tubular hyperdense structure in the right base. (3D) for coarctation of aorta. More clear details about the hypoplastic distal arch, the stenotic area, and the dilatation of descending aorta, and the collateral vessels between the pre-stenotic and post-stenotic areas. a coronal reformate image show the dilated chartreuse intercostal arteries, and another image show the stenotic area and dilatation before and after. An example also about the total anomaly of pulmonary venous return. All the venous return communicate in single vessels draining in the right atrium, superior vena cava, inferior vena cava, right atrium and right ventricles, and upper and lower pulmonary veins. Another example about the draining venous system in the left and atrial defect on this MRI image. Etiology of fellow, this post-surgical treatment, so the stenosis of the pulmonary stenosis and the graft between the right ventricle outflow tract and post-stenotic area and the native stenosis. Here in the axial and volume rendering. Another example of post-surgery showed the shunt between the right pulmonary artery and right brachiocephalic artery and the stenosis of left pulmonary artery. Another example of atraxia syndrome. Here in this X-ray, we show that the shadow of the liver is in the left side of the abdomen, and the gas bubble of the stomach in the right side. And this MRI reformate image shows that the liver in the right side, the left side, and draining right hepatic vein and the left hepatic vein draining in the right atrium. Another example about anomalies of left coronary arteries, where there is a fistula between the left coronary artery and right atrium and a large coronary artery, and which seen in the angiogram by significant dilatation of the left coronary artery, which filling the right appendage. And then we can review the information. The one we start with it, that the cardiovascular anomalies can't be diagnosed only by X-ray, and the advanced modalities playing more significant roles in the diagnosis and follow-up of these anomalies. Echography in the antenatal and neonatal stage is the main corner of the diagnosis, means diagnosis, to characterize the cardiac anomalies and demonstrate anatomy and function, and could be technically limited in the older children, adults, and in the post-operative patient from the lack of adequate acoustic windows. And CT scan, an excellent method who can explain the anatomic relationship of complex anomalies and structures, and which couldn't seen by echography, especially the pulmonary artery conduit at the aorta, and at the post-operative complications such as stenosis and occlusion and pseudoaneurysm. And CT scan It's favorable due to easily obtained in the critical ill patient because we don't need for sedation. MRI give us more details about the anatomy and functional information, and he have the advantage of he is not, there is no radiation in this study, in this procedure, and give us more details and special relationship between the structure and evidence about the dynamic flow, which could be related to a stenosis or regurgitation, and functional measurements such as ventricle ejection fraction. Thank you.
Thanks, Dr. Sami.
Yeah.
I think we are behind time, so if you have any questions, our colleague is here, our Dr. Khalid, Dr. Muhammad, Dr. Nader, Dr. Sami. Any question? Yes, Doctor.
Just a follow-up, the question would be between Dr. Khalid and Dr. Nader. In the few of Instagram, already most of the mature ventilation and stress, and we are trying to ventilating the baby. We are ventilating the baby, and the air will go from the fistula to the stomach and the intestine, and we have abdominal distension. Whenever we are making, we are making the food down to bypass it, almost the fistula is the end of the carina and going to the esophagus. So what's the solution for it? Really, we are facing problems, and the fact Doctor, we are incubating. Doctor, we are, I will tell you, the problem, it is down. It's down as the carina and going to the esophagus. So whatever air, if you want to bypass, I mean, to make it, we are breaking low ventilation setting, whatever, you found stomach as any solution to make any thing to establish that we will take this move. Very good. You are changing hypoxic, Dr. Dr. Khalid, any solution?
Those cases, our aim is the baby quiet. Problem why the baby starts to have a nutrition because he's crying.
No, it's sedated.
If the baby sedated is breathing normally, very likely that he will start to touch and go the air and go the breathing.
It's not that the patient are giving it go to his stomach and intestine. My question is, anything we can do to put this wall between just to take it so that it will not pass the air?
Just to explain the issue, as you mentioned, most of the problem size is size 3, okay, which is originally area with distance. Those cases, the problem that this is essentially that the air will transfer from bronchial to the stomach and the lung. This is why we want to operate this baby within the 48 hours, okay, to prevent abdominal even for us, and for us, this abdomen is difficult for us to get the procedure for don't only and always to minimize the air transduction from bronchus to the abdomen. This can be done without any intubation, but keep the baby sedated. But the baby, when he is air hunger, but he will start to
excellent presentation. Very happy regarding the interest partner to something with the left microphone, this decision for conservative treatment or the is that very small.
As you mentioned, Doctor, most of those cases is transit cases. So, and what exaggerating the problem, the meconium plug, because it caused mechanical obstruction. My aim as a surgeon to relieve the mechanical obstruction. So by contrast, when I'm giving gastrographene, it will melt the plug and it will come out. Once it's done, even if I have narrow lumen, it will dilate it by the motility within days. So this will be sorted out immediately. But this is fortunate what's happening in meconium plug. Meconium ileus, separate entity. So it is due to cystic fibrosis and other problems. And those long, dry meconium, which is from the terminal ileum until the large bowel, it will not be easily melted by the contrast. But here, sometimes I have to go and interfere surgically. Thank you. Yeah. Yeah.
And there is a variety of preferences between the surgeon. Some surgeons go to 3 years, also 5, 6 years.
Yeah.
So can you tell us how the criteria to do the surgery?
Okay. You are welcome. For the fragmentic hernia, as we mentioned, our aim when we are going for to operate in those babies that their pulmonary blood pressure will be normalized. What meaning of normalized? It's also variable, because for us we are taking 40 millimeter of mercury as normal pressure, or accepted at least pulmonary pressure to go for surgery. Because the problem, you expect most of that pulmonary pressure to increase, but you don't want to exaggerate it by the surgery because it is stress situation. So our aim always to reduce it, because most of the time the pulmonary pressure is reached 80 to 90. In those cases, you have to start the antihypertensive medication for pulmonary hypertension. So once you reach this, baby is stable, a baby not in high frequency ventilation, he's in low parameter ventilation. So this time, telling you the honeymoon time, that now I can go and take the baby. It can differ between 3 days until 10 days, as I mentioned, because some babies straightforward, since birth they are smooth, we didn't escalate the ventilation from low to high frequency. So in those cases, we can take him within 2-3 days from delivery. But rest of babies, sometimes you still nothing controlled regarding blood pressure. And this give you indirect sign that this baby is very sick. And even you can alarm the parent, even with the closure of the defect, this baby may die even on the table when we are taking him. But beyond 10 days, I cannot wait more, even if blood pressure like 60, because I will give him a last chance to be operated. Umbilical hernia, as all pediatric surgeon agreed, will not be operated before age of 2 years, provided at age of 2 years that it is like more than 1 centimeter, and there is other factors that prevent the closure, like babies with nephrotic syndrome or NBD dialysis, or babies who's like Down syndrome, who's having muscle weakness, bone, and you know that this umbilical hernia will not close. Those babies can be operated after 2 years, but before 2 years, nobody will operate an umbilical hernia. And as you know, umbilical hernia, it will not get obstructed like inguinal hernia. But just reassure the parent, and just even first visit by pediatric surgeon can be at age of 1 year, not necessarily to send the baby at age of 1 week for pediatric surgeon with umbilical hernia. Okay, thank you.
Any more questions? Sorry.
Regarding the question for the doctor regarding the ventilation for tracheoesophageal cases, most of these cases in the first 24 hours, they will be on room air. Again, if they are not sick, we leave them on room air, they will not have any problem of leakage. Even if we are obliged during transfer, for example, to a pediatric surgery center to ventilate them, we can do the very gentle ambu bagging, very gentle. It will not leak. The problem that we are a little bit worried, so we are ventilating them with aggressive ventilation, and this make the fistula dilate and leak. But I think most of them, they will be okay with a very gentle ventilation if we have to. This is why, again, we should operate them early on, so we will avoid this. Thank you.
Thank you, Dr. Muhammad. For me, I will take a chance that just give a comment for my colleague. Oh, sorry, Doctor.
I didn't hear, Dr. Anna, sorry, I didn't hear in what disease?
What specific red flag the pediatrician will put in his mind to be having a good surgeon, pediatric surgeon, for the GI emergency congenital
The most important thing is the sudden bilious vomiting, and the other thing that the tender abdomen by examination. This is a very important flags, both bilious vomiting and tender abdomen. Khalid, any other thing you want to add?
And I will not add more. Yeah, as we mentioned, we consider what the most high in the hierarchy, the malrotation. Bilious vomiting, you have to rule out malrotation. The problem that not by small age, not babies, because it is well expected. But when the child is 3 years or above, I was trained in Cologne in Germany. We received one girl, 8 years old. And you imagine the service, medical service in Germany, how far and what the best level they reach. But still, those cases can be missed. And the pediatrician was telling to our colleague, the pediatric surgeon, when a patient was coming to the ER arrested, actually, the pediatrician was telling us the child was vomiting 60 times. Okay. But the problem, they didn't think about malrotation. Baby was resuscitated, sent to the ICU. Second day, they informed us, we told them this is volvulus. So when we went, all the bowel gone, so you have to resect. And the child ended with short bowel syndrome. Within 2 years, she expired complication of the sepsis and also liver cirrhosis. But this scenario, if you saw it once, you will not forget it. The malrotation, volvulus, this is one of the critical things. Patient have bilious vomiting, you cannot sleep, you cannot go and take your break until you are sure this baby have volvulus due to malrotation or not. Thank you.
I think we are out of time, so thanks my colleague, Dr. Muhammad, Dr. Khalid, Dr. Nader, Dr. Sami for really very informative and valuable presentation. I think we have now time for a break, coffee break. 10 minutes, please come at time because we are behind. Thank you so much.
Everyone, please settle down now because we are about to start the fourth session. May I call on Dr. Siguran Shukar for our moderator and Dr. Hala Maruf.
Thank you very much, and thank you to Dr. Sharif and his team for inviting me. And really, it's amazing for Dr. Sharif to carry on this conference. And I was hoping I will see even 5 people coming or 10 people coming after this pandemic and what's going on with us. And it's really very courageous. And I will call it يعني بالعربي, this is مؤتمر التحدي يعني. شكرا دكتور شريف. So I'm going to talk, I have a general talk about Kawasaki, but we can, if we have time, we can go more for acquired congenital heart disease. But usually, so we'll talk about that recognition of scenarios of Kawasaki, mainly, and concentrate on the Kawasaki picture, and of course, so what can we start with acquired heart disease? We start with Kawasaki disease of Kawasaki or the strong scenario is more interesting for us. Human heart disease is not as common as Kawasaki and this kind of thing. Then we have bacteria, the myopathy, and arthritis, and colitis. So we'll start with this scenario. How to feel for boy with people who are we did a example of basis. These are And this is presented all, so we have to analyze the evidence. And then after people making these, we compare 100 photos. We want to
No, it's 5 milligram per liter, this is normal. It's not 5 milligram percent, means 50. Right. Okay, so I really don't know. Have to be honest. So these are the top. Okay, this is what we have. Assuming the number is stable, let's still see how many, and there is about like 10 degrees, something like that. Okay. Alright. So this was the outside validation. So now when I finish with that, when I see this abnormal, I'm still right. I need to be more. Alright, so the first response, the first step is I identify that I'm done. They are high, then I get hard. They are low, normal, then I say where I am. I don't need to do anything else. I can start there and just relax. But keep higher. So when you say there is, you don't have any physical sacrifice inside, that's fine. But if it is near, so I can repeat. I can see the definition. So CC is 20,000, this is 500, you will get 15, and you need 2.5, you need 40, and over. If you know that, I know this is big group. Okay? Which means I want to do 3 times. Okay, one for the liver. So, what usually you see in the UA? Pregnancy, somebody or something like that. As we know, is the number of hundred.
No.
Still how many times?
Still more than 1 hour.
Really?
Yeah.
It should be about 3.5 grams per deciliter. There is attendant inside?
Yeah. We are going by delay.
What about the platelet?
It's high.
Now, remember this one. This is the most important part of my this is the most updated guidelines for and this is the background that you see here. Now, if you are not going to this, you are talking about beautiful people like you cannot see now, if you are talking about anything about money or anything about gold, this is abnormal because this is abnormal. So there is information. The need so I get it. And then now I'm going to do a you can figure it out. If you are the business is more than and then how many and what was so this is a how many you need only okay now
right now, if you have a positive fever, I don't care what is that. I don't need to worry about anything. All right? Okay, so if you have anything to do, if you don't, you stop. You don't need to treat. And if you use this diagram, it has helped me many times to ask a question, which is sometimes really important for the patient, for the parents, for the doctors, to decide which way they're going. If they are, if there is nothing, if it is normal, then we do it fast. So this is what I say. 2 years old, people go to the so we have this. People is a mass. They don't like to say something. Okay? So we will have to get the level of fever. Moderate or high grade fever like more than 38, more than 39, anything like that has been defined. So people for 6 days don't move it and that's it. So we have right? We have now we have This is our plan. We are planning to plan. It is about the it's This one, we can find because this will be a information thing. We do not sensitive. Now we want to say this is outside. Okay, to say this is outside, we do not think of this. These two are there. So we need to think about it. We have to have one equality. We need to have Yes.
AST 150 RB platelets. And I will show you there is a specific name for this finding. What do they call it? Again, another Kobayashi? Kobayashi? You like Kobayashi, right? It's not food. It's related to Kawasaki. Okay? So you get sodium less than 133, you go for AST more than 100, CRB more than 10, and all of these points. You need 4 points to say this is a very high resistant. So 4 points out of this. So if the patient doesn't respond, you have to think about this line and you have to say, okay, what we can do next. Okay. Okay. I think I did not talk about the follow-up because I think my time is done. How many times? This is important, and I think I will stop there. How many times the pediatric cardiology need to see Kawasaki patient? Why don't you come and do the lecture instead of me? Okay, you know, leave something for me, man. I'm working hard here. Dr. Islam, talk to him, please. All right. 4 times, 6 times, once a month, one time if normal DC, and none of the above. Which one you think? So for normal patient, this is the protocol. We do initial baseline, and then 2 weeks later, and then 6 weeks later. So 2 weeks, because that's the time where you're most likely to see the coronary artery finding. 6 weeks to see if you're gonna continue on aspirin treatment for the long term or no. 6 months, we used to discharge them after 6 months, and I'm assuming normal coronaries. Now with the new guidelines that from 2019, you have to follow them every 3 years. And what we found out that this patient with Kawasaki, that they have a high risk for coronary artery disease as an adult. And this is new. We didn't know that before. So this patient, it's true, they got Kawasaki, they didn't get any problem with it, but then later on, they will get coronary artery disease in their 40s and their 50s, okay? Of course, if they have a finding, if they have aneurysm, we are talking about complete different protocol that we're gonna need to treat for this patient. And that including aspirin and other anticoagulation process. So take home message, you don't have to have full 4 criteria to diagnose Kawasaki disease. And in fact, less than 6 months with fever for more than 7 days, consider Kawasaki until proven otherwise, okay? In patient with risk of IVIG treatment failure, start steroid. And this is another thing, a little bit new, that usually when we talk about steroid, we say it's gonna respond or not gonna respond. It maybe increase the inflammation and so on. And I think this is the end of my presentation. We have tomorrow for these people who's interested on webinar. I hate webinars. I promise you this will be my last webinar I'm gonna do. After I saw Dr. Sharif with his courageous to bring us all here, will be my last, but if you are interested, you can register at cme@kidsheart.ae. All right, thank you. Thank you.
Our next speaker is Dr. Azhar, and she's a senior clinical psychologist at the hospital. She's also American board certified. She will take us through the psychological journey of children and family in ICU. Over to you, Dr. Azhar.
Good afternoon. It's nice to be here today. And it's a strange feeling to be live. And I thank Dr. Sharif, of course, Dr. Mamdouh, for, yes, I agree, for being so courageous and resilient. And this is, I think, our first, most of you, their first physical conference, yeah? So it's a beautiful moment to be here with you. So I'm going to talk to you, I'm going to shift you a little bit from Kawasaki and talk about the emotional world. And I don't know how many of you talk to your patients about the emotional relationship between the parent and the child. And this is what, it's a topic that I've been really passionate about over the past few years as I attended my first infant mental health conference and learned about the emotions of babies for a change. So today I'm not only representing Latifa Hospital, I'm representing the Infant Mental Health Committee, which we started under the Emirates Society for Child and Adolescent Mental Health. And it's the first affiliate of the World Association of Infant Mental Health. And UAE is the only Arabic country who's affiliated with them. So we're very proud of this. And if you want to learn more about these initiatives, please let me know afterwards, and I'll be happy to connect you and to refer you to our website. So I'm going to start out. I know we're a small group, and maybe our virtual viewers can join us also. But I'm going to start by just most of you are, how many are fathers here? Parents? Only one? Cannot be. I cannot believe it. I think more. We're a small group, so raise your hands. It's okay. Mothers? Few. Okay, we have a few. So we're daughters and sons also, we're aunts and uncles. So I'm going to ask you to take a minute, and I know you're physicians and nurses, to just think about if your child was here sitting with us today, and I like to start with this exercise, what would they say about you right now? Okay, I always like to look around and see the looks of, and the words that can come up. Anybody is courageous enough to share a word? What would your child say about you right now? Thank you, Doctora, thank you. Great, that's nice. So the first words that come to you are very important as a parent also, because I had different reactions: great, strict, angry, fun. So, and I'm doing this because I think it's important for you as physicians and nurses working with children, young, old, different ages, to have some self-awareness about your own experience as parents. So again, I'm asking you at the end of the day on Thursday evening to shift your mind completely from the medical world to the emotional world, because I think they're so interconnected. How do you want your child to remember you when they get older? Something to think about tonight. And how would you describe yourself as a parent? Okay. And very important question, how do you remember your own parents? So if I ask you now, if you were 5, 10, how do you remember your own parents? What would you say? Mother, father? Dr. Hala, I'm going to pick on you, huh? Busy. Very, very, very important answer. So the way you remember your own parents and the way you're parenting your own children, it's almost like a cyclical transmission, almost as similar to our genetics. So and there was a psychologist recently talking about the pandemic and said, how do you want to be remembered in 2020 also, even by our children? Because there has been so many changes also in our practice in terms of healthcare and in our parenting. So in the words of the famous Winnicott, he's an analyst in psychology, he said, there's no such thing as baby alone. There's baby and there's someone. So why are we talking about infant mental health? Do you believe that infants and babies have emotions? Everybody agrees. And their emotions are not so simple. Their emotions, they have a complicated world of emotions. Now, the research tells us babies who are hospitalized for a long time and separated from their caregivers can suffer the consequences for up to 6 years afterwards, especially if there's no early intervention and there's no referral to mental health early on, psychology, psychiatry. Babies, I get this always misconception when parents come in the room and they tell me, you can talk about anything you want in front of my baby. I said, no, I can't, because babies can pick up on what we're talking about. So please don't keep them in the room and pretend that they're invisible. They're not invisible. So there is research also that babies who are exposed to domestic violence, babies, can suffer also from post-traumatic stress disorder, up to 45% of the sample in the research that I read recently. So 45% of the babies who were exposed to violence can suffer trauma-related symptoms. So you, as healthcare professionals, I look at you as really the first door and the first mental health professional who families come to. So you are the key in terms of picking up on these issues, picking up on these red flags, and referring them appropriately and early on. It's never too early. So I always say from the beginning, if we can refer infants and we can refer toddlers, we can prevent long-term problems from occurring and really continuing until adulthood. I want to make sure I'm on time. Dr. Hala, feel free to tell me when I have 5 minutes, okay? So again, why infant mental health? We know, you know, as physicians and healthcare professionals, the brain develops rapidly during the early stages. Any toxic and negative experience can leave a long-lasting impact, especially, as I said, if there's no early intervention. We know about critical periods and sensitive periods, and that's why we want to promote attachment, healthy attachment, positive attachment early on. And I believe attachment, honestly, if you ask me, I believe attachment starts even from the prenatal stage. When parents are planning or thinking about having a baby, that's an important stage where they think about their own childhoods and how they want to be as parents. And this is where attachment starts. It doesn't even start from pregnancy. If you want to read up on this, Bruce Perry is a great author, so I thought, you know, I'm going to list some of these authors that you might want to check out their websites. We know that children who are exposed to early trauma can also suffer functional and structural changes and alterations to their cortical and subcortical regions of the brain, as you can see. But also the good news about infants and toddlers is we know more about resiliency now, we know more about neuroplasticity as well. We know about the relationship and the parallel between the mother's physiological world and also the baby. So they're both intertwined early on. And I'm talking even about the emotional centers of the brain, such as the amygdala, the hippocampus, and the hypothalamus, and all the other mechanisms that are related to the emotional world. I'm not going to talk about oxytocin, but I'm going to take you through history because I just want you to know that this is not new. What we're talking about today about attachment and bonding is not new. It started out with Darwin. If you're interested in reading, he started following his little young child around and noticing his movements. And then it continued. Everybody knows Freud, right? Right? Sigmund Freud. So Freud said, of course, the first person we fall in love with is our mom. That was his theory, so not to undermine the father, of course. And then it continued. And then there was the famous, has anybody seen this? Harlow's experiment with monkeys? No? So I'll talk about it. I don't want to repeat anything you know, but Harlow said, you know, let's look at the animal kingdom. So he looked at baby monkeys and he deprived them, he separated them from their mothers, and he put the monkeys with two wires, one dressed with cloth and one had milk and food. So then he decided to take the monkeys away from the cloth and keep them with the food. You would think the monkeys will be all right, but this is what happened to the monkeys. They became depressed and isolated because they were withdrawn and deprived of nurture of their mothers. So imagine what would happen to human babies when they're deprived of their parents early on, or they don't get the nurture they need early on. So there comes a guy named Bowlby, and he's fantastic. And he said, we all, as human beings, if we get the love that we need and the nurture early on from birth, we develop something called the internal working models, where we develop how we perceive the world, if we trust others, if we believe in ourselves. So this is why, again, that bond from the beginning is very important in pediatric practice also from the onset. And this is where you can send a message to the parents if you pick up on the red flags that I'm going to talk about. Then came two ladies, and this is important for you to know because they're the ones who classified attachment. And they said we have 4 types of attachment, basically. And the way you would know is by observing. When you have parents and children, of course, coming together to your practices, right? So I'm sure as you're talking to them, you're observing the way they're interacting. So these ladies basically created this lab and brought in the mother and the child, and then they brought in a stranger, and then they told the mother to leave the room for a little bit and see how the child reacts. Will they bond with the stranger? Will they tantrum? Will they get scared? So a normal baby, what would they do if their parent leaves? What would they do? Cry. What would they do when they come back? Feel secure, and they would go and hug them. So they found that the majority of children, luckily, are securely attached to their parents, but we have 3 different types of insecure attachment, unfortunately, that it's important to know about these. We have something called avoidant. This is when, I'm sure you've seen this, when children just don't care. Their parent leaves, their parent comes back, there's no reaction at all. Cool, very cool. So, and they sit there with you, and I usually, in my first initial evaluations of children, I ask the parent to tell their child, I'm leaving for 5 minutes and coming back. I want to see what happens. This is my kind of attachment screening from the beginning. And then you have these children who are just confused. They're called resistant ambivalent. So when the parent leaves, they start reacting, and they start crying, and they start clinging. But when the parent comes back, they give you this confused reaction. They are happy, but then they don't care. So they go back and forth. And then you have something called disorganized. This is the worst kind, actually. They found it in traumatized and neglected children, and I've seen it also myself, is when children freeze. They have these unusual, bizarre mannerisms toward their parents, and then they just freeze. There's no expression in their face. I'm not going to show you the video, but we have other really interesting experiments also. This is Tronic. And he basically, and I'll show you the experiment, but he basically brought a securely attached diet in the beginning, and as you can see, and he told the mother to interact with the child and then just keep a still face. So if to the person next to you, imagine that one of you turns to the person and keeps a still face, no expression, just like that. And you're talking to them and trying to engage them, but there's no reaction. So what happens to children when they are faced with the still face? So I'm going to show you the video. I'm going to click on it to try to see if it works. There's no... Even if you don't hear it, it's okay, because you're going to see just observe the reaction. So this is a securely attached mother-child dyad. So this is the mom is just really normally engaging with her baby. It's pretty slow, I think. I wish we had audio, it would be nicer, but it's okay. Okay, thank you. Thank you, gentlemen.
This baby starts pointing in different places in the world, and the mother's trying to engage in their play. They're working to coordinate their emotions and their intentions when they want to do wrong in the world. And that's really what the baby is used to. And then the baby gets the mother to not respond to the baby. The baby very picks up on this. And then she uses all of her abilities to try and get the mother out. She smiles at the mother. She points because she's used to the mother looking where she points. The baby puts both hands up in front of her and says, "What's happening?" She makes that screechy sound at the mother, like, "Come on, why aren't we doing this?" even in those 2 minutes when they don't get normal reaction, they react with negative emotions, they turn away, they feel the stress of it, they actually lose control of their posture because of the stress.
Okay, you can stop the video. So you can see why this is why I'm showing this, right? Because the implications are very huge. When the mom stopped reacting or responding on being in tune with the child, this caused the child to be dysregulated and in pain. And this was, we're talking about a few seconds, right? So you saw how the child really responded. So this is where we emphasize it's not only about the physiological functioning of the child, but really the emotional functioning of the child is really critical and imperative to development. So imagine in our work over the past many years, we've seen so many children who go through this every day. It's not moments, it's not seconds. This is where maybe some parents are actually really good at meeting the basic needs, feeding the child, bathing the child, schoolwork, but they're not there emotionally. They're not there, they're there physically, but they're not there emotionally. So imagine the horror for this child who's not getting the love, who's not getting reinforced about their sense of self-worth. So the risk factors that I would love for you to pay attention to as you go back to your practices is there are many risk factors, but in the interest of time, I summarize them. And some of the risk factors according to our own clinical experience, but also this is according to empirical evidence. One is premature birth. Premature birth, we have a support group in Latifa Hospital for parents of premature babies. And you would be amazed at how parents express feelings that they're really having trouble bonding with their children because they're premature. They're ashamed, they feel guilty, they feel that they're not sure. 5 minutes? My goodness. They're not sure. Give me another hour. They're not sure about how to deal or how to hold the baby. There are also a lot of antenatal, postnatal stressors. If you're working with parents, have you ever in your history collection asked the parent, was this a planned baby? I didn't ask this question before, honestly, because I was a little bit shy and it's a sensitive question. But really, there were so many answers that I get from parents that are surprising about the story of even conceiving that child. If the child wasn't planned, and how did they feel during the pregnancy, or versus a child also who was conceived when the parents were having a lot of stress or difficulties. A lot of other factors, if the child has a fetal diagnosis also. I mean, I'm sure you deal with this on a daily basis, some of you, are chronic, or they're diagnosed with a chronic illness eventually. All this really impacts attachment and impacts the parent's ability to be in tune with the child. There are a lot of socioeconomic factors also. And I have to mention also COVID, because we don't know now still to what extent is COVID impacting the attachment between parents and children. We know that there are a lot of changes in parenting even. We know there are a lot of changing demands on parents. And there are higher anxiety rates and depression rates around the world in adults. And there are higher rates of domestic violence and child abuse because of isolation, socioeconomic stressors, etc. So research remains in progress, but it's important for us to keep in mind that COVID can have a long-lasting impact on how, in a positive way, and maybe in a way that we need to look at. So I apologize, I have to skip around. I really timed this to be 30 minutes, but so I'll skip around just to highlight now the positive side, and the take-home message is that any kind of rupture or injured relationship between parent and child can be repaired. This is the good news, and this is what we want to convey to parents. So if you're seeing a parent who's really struggling in parenting or connecting with the child because of medical symptoms, because of other issues happening in the family, we can really encourage them and by telling them that there are many ways to promote that kind of attachment. And what we want to promote as mental health professionals is that we want parents who are able to be sensitive to their children, able to be attuned, synchronized, with their children, and able to understand what their children are really feeling and thinking, and why they're behaving. I don't believe that children are problematic. I don't believe there are problem children or bad children. Any child who is acting out from infancy to older, there's a reason for it. and we want to figure out the reason with the family, but it won't happen alone. It has to be an MDT approach where we work closely with the physicians, with the nurses to help these families. So I really encourage you to looking. There are a lot of great resources out there that are really available for you to use and even distribute to your families and patients. UNICEF has great resources, WHO, all of the the large international organizations are promoting infant mental health. World Association of Infant Mental Health, WAIM, has a lot of, right now, free webinars if you are a member, and they're great. So this is where we are right now. Just really quickly. It's not going with me, but anyways, I'll talk about it if you don't, yeah. So this is where we are right now in terms of infant mental health. We know that attachments are passed on from one generation to the next. And in order to stop unhealthy attachments, we have to educate parents about healthier attachments. We know that there are also diagnoses right now, if you're not familiar with them, about attachment. In our diagnostic manuals, there is something called reactive attachment disorder. There's something called disinhibited social engagement disorder. And you are, again, the first ones who will be able to pick up on these. Parents will not come to us in the beginning. They will come to you. So we're looking to you for support and for referral of these families. If you're interested in the neurophysiological synchrony between parent and child, please check Daniel Stern. He's a great writer as well. And this is why we're here and talking about this, because this is attachment. Sorry, it's not reflecting my slide, but attachment really shapes all of this that you're seeing on the slide. It shapes brain development, it shapes physical development, behaviors, and it shapes the child's future. If they don't have a healthy attachment early on, they're likely to have a difficult future. Learning difficulties have been found, lower IQ, difficulties in social functioning, difficulties in marital functioning, if we don't, again, intervene early on. So what works is just, I'll say it in one word, in a couple of words. We need early screening. We need more parent support programs. We need to promote the message about attachment and MDT approaches. This is why we promote in our hospital, of course, practices like kangaroo care and contact and close contact. We need to promote why breastfeeding is important, why touch is important, singing, talking. So we need the parent to really buy in, but they cannot buy in attachment unless you also are buying in the concept of attachment and bonding between parent and child. So in our hospital, just quickly, if in case you don't have these services and you want to promote them, we offer inpatient services, we offer liaison services, we offer, if the parent refuses mental health support or treatment, we offer support for the medical team. We offer outpatient services. I'm a child and family psychologist, but I offer also a support for parents who are dealing with a child who's having a chronic illness or who is discharged after a long time of being hospitalized. And we offer support groups also for our staff who are dealing with difficult situations in the ICU or in ICU. So this is just a glimpse into infant mental health. We would love to see you again for future workshops. We have activities under the Infant Mental Health Committee. If you're interested, please get in touch with me. We have a webinar and a symposium coming up, virtual though. Still, we're not there yet in terms of live, but also we accept pediatricians as members if you're interested. So this is where we are right now. And I think that the ultimate take-home message is that we just really simply want to teach parents to fall in love with their babies. We want to teach them to respect the well-being of babies and their presence. I feel like we learn a lot from, they're the best teachers, honestly. And we want to listen to what our children are telling us. But again, we can't do it alone. And we have to listen closely. Two last pictures I want to share with you. These happened last week and I took permission to use them, but please no pictures of them. I want to show you how complex the child's world is, the mental health world. And the picture on the right, this is a child who was in terrible pain for a long time, but there were no medical factors or organic factors, so it's psychosomatic. So the child, they started therapy, and I asked the child after a while, the pain disappeared. And I asked the child, what happened? How did you get rid of that pain? All that pain that was driving you to a frustration point and driving your parents also, because she's crying every morning and she's a young child. She drew this picture on the right and she said, well, finally, I let out my feelings out. Her feeling, and she opened the circle. So this is amazing. This is for a child to say that Adults don't let out their feelings sometimes. So for a child to say that, it's amazing. The other picture is about a child who's extremely anxious and afraid. So I asked him the other day, please list what's making you afraid, so afraid and anxious. So he listed the following, and I just was really mesmerized by how thoughtful he is. And we don't know that these children think this deeply. He said, I'm afraid of being alone. I'm afraid of hell. I'm afraid of planetary collision. I can't even say it, planetary collision, which I didn't know about. And I'm afraid of the universe ending. And I'm afraid of having people I love dying. Can you imagine a child who is 6 thinking about, Khalas, I'm done. I'm done. This is my last note. So if you're interested in reaching me, please feel free to do so. This is my email. This is my number. And thank you so much for listening. And thank you for the invitation. Thank you, Dr. Hala, for the invitation.
Thank you, Dr. Everyone knows Dr. Hamza. I don't have to introduce him.
Assalamu alaikum. You know, I think I was almost sleeping, you know, late afternoon, but I think the interesting talk of Dr. Muhammad and Dr. Azhar woke me up. I changed my mind at the last moment, and I do this all the time, okay? And today we're going to talk about something new. I'm going to talk about the latest article we have published, and hopefully after this very difficult year, this is السنة العجفاء, we will have inshallah some hope. Is Dr. Khalid here? Okay, then the session will be long, too many questions. Second, who believes that autism can be cured? Who believes that autism can be cured? And when we say cure, the patient is normal and he takes home 5-year bumper-to-bumper warranty. Khalid, believe. Good. Wallahi, you are very optimistic. Okay, what I will do today, you know, as everybody knows, and I have been, when I moved from the state here, I was the furthest from autism. But when I came here to Dubai, UAE, I was flushed with autism. Can you imagine when I was in the state practicing, I don't even see autism. I used to send them to the child psychiatrist right away, off the bat. When I came here and I moved to Al Mafraq Hospital, then I went to Dubai, I started seeing a huge number of autism. And to be honest with you, the first patient we were able to cure them. I cured them without realizing they were that I cured them, Adam and Rakan, because it takes so long time. Then we came up with our first testimony, second testimony, fifth testimony. Then by the end of the day, you're always going to have somebody say, well, there's a question mark. These most likely were not autistic. Most likely they were misdiagnosed. Most likely they are commercially being used, you know. Unfortunately, and you know, this has never hurted us. We are human, and everybody knows how things, you know, works. So we decided at the end, then we'll have to go ahead and collect our patient and submit them for publication. Okay? Surprisingly, it was so amazing and so depressing that to find out that in 2002, there's an article published saying using the approach we are using now have led to significant improvement in all signs and symptoms of autism. Over the last 20 years, when I wrote my article, you cannot imagine it. There is almost no new articles or treatment on how to treat autism. Okay, so finally we published our article. We published 18 cases, and I will tell you, I'll talk to you about them. So this is a YouTube. I don't know if it's going to work or not. Can you turn on the volume, please? If it does not, it's fine. So this might summarize our study. No volume. Not sharing. Okay, then we'll skip it. Skip this one. So this is, we will talk about the study quickly. I will be swift. I will not take too long of your time. We will go for the money. You know what I mean? So we published this article in the Neuropsychiatric Disease and Treatment. Okay, and this is 2.6 Impact Factor Journal. It's a peer-reviewed, open access, PubMed Index, PubMed Central Index. And I insisted, Yahala, I insisted to publish it in international peer-reviewed study. You know what? Because first, I want to know what can I do better. Second, in order not to have big question marks. You know what I mean? Because when you take your article and publish it in peer-reviewed journal, they will go ahead and dissect it step by step, piece by piece. It took me 8 months to publish this article, and instead of 2 reviews, 8 reviewers reviewed my article, which is 8 reviewers. What's 8 reviewers? It is for the phase 2 study that FDA used. You know how much? Because it's too good to be true. So this is about the article, about the misery I have gone through. So this is the retrospective case series of 18 patients. And these patients that we collected, they are the patients who were treated with from 2017 to 2020. And this patient has to be diagnosed with autism. How? Clinical diagnosis, clinical psychologist, CARS S2, DSM-5 criteria. So there's no doubt these are autistic, okay? Second, they have to have comorbid behavioral disorder, and also they have to have normal EEG to rule out epileptic aphasia, normal ABR to rule out hearing problem, and at the same time, no genetic disorder, no global developmental delay. So we dissected the pure autistic cases, okay? And this is everything is explained in the article. Then, once we did the diagnosis, we added CGI, Clinical Global Severity Scale, and CARS-2 at the baseline. Why? Because when I submitted my 3 cases, they told me, yes, we trust you. They were autistic. Their signs and symptoms resolved completely, but prove it. I still remember the things. So that's why we have to do it at the beginning, at the end, to do the CARS, clinical tool to diagnose autism, plus DSM-5 criteria, and after resolution of the symptoms, and CGI scale, clinical global assessment scale, the severity and improvement, okay? Then this is the clinical global assessment severity scale. The kid has to be 4 and above. Why? Because if you are autistic and you are having no problem with the surrounding, most likely, you are not the case we want to treat you. So we decided to take 4 and above, the real heavy duty autism cases. And this is the global assessment. They were done at the baseline, okay? And after we treat them, we have to go back and do it again. Then we treated them. This is our protocol. We took the sign and symptoms, okay? We made sure we diagnosed them right, and then we started them either on risperidone or aripiprazole, which is the 2 antipsychotic medication that FDA approved to treat comorbid behavior in kids who are 4 years and above or 5 years and above. And this is the biggest disaster ever happened to autism, because every time you're going to put a patient in medication, the family will come back to you, tell you, but this is not approved except in 5 years and 4 years and above, and 20 years later, still we have the same darn indication. I put them in 2 years and above, but we have to take the patient who are less than 4 years out because the journal got panic, and we are publishing them inshallah soon as a second pack. Then we start going according to our protocol, start low and go slow. If the patient improve according to signs and symptoms or risperidone, we keep going up until we hit 3 ml. So dosing, very important, is the most important thing. If the patient does not tolerate risperidone, we switch him out to aripiprazole, crossover. We go start low and go slow, 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 slow until we hit 10 ml or 15 ml or maximum tolerated doses. This is all explained here and in the article. Now, a lot of the time you would see the patient, attention, understanding, social communication, receptive language, expressive language, repetitive behavior, sleep, emotion, everything, every single sign and symptom to improve, but they plateau. Patient, all of a sudden he moves from completely disconnected, as if you are talking to a Chinese person, call him disconnected, Chinese. He connect with you. And I see this every single clinic because they have heavy autistic patients. But they stop. You reach the maximum dose, then they stop. Then what should I do? Hala, what should I do? The patient went, improved, connected, but they plateaued at what? At 60%. What I do, as a simple country epileptologist and child neurologist, I add ADHD medication. Because when you look at the patient heavily and when you observe him, you realize that his biggest problem now is not connection, like autistic. You call him 100 times and he doesn't answer. The biggest problem is attention. So we add Ritalin or Concerta or Strattera. And we start with Ritalin, start low, go slow. No improvement. Side effect, we pull out the Ritalin. We add Strattera. 2 years and above. All these are indicated 6 years and above. I do this every single day. We go up, up, up. No improvement in Strattera. We pull out Strattera. It's not working, then we add clonidine. Here, we only use Risperidone, aripiprazole, and Ritalin, Concerta, and Strattera. These are the only 5. But I have a huge number of patients that I use a lot other medication. Okay, what happened? In total, we have 18 cases. 14 females, 4 females. The age was 4 and above. I treat 2 years and above, and I have been doing this last 8 years. Okay, and all the testimony you have seen on the video, Malak was the first one, and now she is completely normal, and she has a special skills where she hears the rhythm or the notes for music, and she can do it right away. Absolutely normal, 100%, bumper to bumper warranty. Sorry for the mechanical language. Okay, 8 patients were started on Risperidone, 56 were started on aripiprazole. Okay, and as I said, we based efficacy based on CARS-2 plus CGI, Clinical Global Impression Severity Scale and Improvement Scale. Okay, me and the clinical psychologist. Okay, so 10 patients attained CGI scale of 1, which means completely normal, by my judgment and by the patient judgment. Okay, once we reach this point, we repeat the CARS-2. Why? To make the reviewer very happy, because all what they care about, did you add CARS, ADOS or not? And when we repeat the CARS, they were in the normal range. Of course, the most important is your clinical judgment, okay? In addition to our clinical judgment. And we added in the article also the presenting signs and symptoms and the signs and symptoms when they finish the treatment. And the most important thing, these patients who attain complete resolution of signs and symptoms, they are normal in the school without support or shadow teacher. You cannot get better than this one, okay? Now, we run a statistical, statistical analysis. Why? Because they want statistical analysis and it was very significant, the idea. We don't need statistical analysis. If you are autistic and you become normal, would you do statistical analysis, Dr. Khalid? Of course not. Okay, but they want it, so we have to do it. Right. So 12 patients, we supplemented them with Risperidone, and Ritalin, aripiprazole, or Strattera. Okay, we did the cardiac evaluation, no problem whatsoever. 8 years, I have never seen a problem. We do cardiac evaluation baseline and serial. We did blood test, everything is normal. Okay, right. Why I am presenting this study? It's a retrospective case series, okay? And everybody is excited about double-blinded placebo-controlled study, because this study is the first study ever reported in the medical literature to show autism patient can be cured. These are the first 18 cases in the medical literature. You go to PubMed, PsycInfo, Bobas, Midline, you would not find a single patient cured. There's only one patient, they put him on phosphonatoin. He was 19 years old. He's like, 5 years younger than me now, okay? And his silent symptom improved. This is 18 cases, 10 of them complete resolution. And now, of course, after 1 year, almost all the other patients are on the track. And that is the importance of this study, okay? That autism can be cured. And the protocol is reproducible. Now, currently, after this, I published this one because I was older than 40 years and less than 2 years. So I said, let's go ahead and publish the less than 4 years. Because the journals get very, very nervous. FDA, CDC, Georgian Society, Madaba Society, medical tell you autism cannot be cured. And all of a sudden you hit them with, and Egyptian Society will tell you also we agree. And all of a sudden you hit them with 18 cases because they get panic. Now we are preparing another 10 cases to be published soon, inshallah. But these are, I have 5 minutes, right? 5:40, I'm looking here. And you know what? When I was going through my data, I collected 70 patients currently with me. But I would never them. Nobody would accept them for publication. So we're going to go with another 10 cases soon, starting with 2 years and above. Why? Now the question I had, once we published this one, I found some Twitter from my friend. I was not necessarily impressed by, their criticism, not negatively, because their criticism was very superficial. You know what I mean? They were questioning the diagnosis. They were questioning the medication. It's a retrospective study. Or we only depend on double-blind placebo-controlled study. Great. How would you double-blind a medication without having information telling you this medication might work? Right? Do you agree with me? Strattera, atomoxetine. How did they find out it is? How did they do double-blind placebo-controlled study on Strattera? They invented as like Nexium, medication for ulcer. Then they put double-blind placebo-controlled study for ulcer, non-beneficial. But they noticed it helps the attention. Then they did double-blind placebo study to show the attention. That is the main goal of this study, to show people, for God's sake, look here, انظر هنا. ضع الدائرة. You have to look here. This is the way we have been doing this. Okay? And please take this piece of information, then do double-blind placebo study. You know what? Do prospective study on it. Okay? That's why we were successful in curing autism, while everybody were not. Because this is, everything comes from God. One. Second, it's a real practice. I have been working with patients for 8 years. We start with as FDA, then with daily practice, all my colleagues will realize there's medicine and there's the art of medicine. If I have noticed that when I put them on aripiprazole, not only the anger and the difficult behavior get better, they become more focused. They start listening to their name. Then we start pushing up the medication, of course, reviewing the literature. Then you notice that the last problem left with me is attention problem. Then you add attention medication. It's simple. Then we realized Rakan and Adam, well, all of a sudden they were back to normal, right? And then we start doing the same protocol again and again and again and again. So early administration of medication, proper dosing based on individualized treatment approach. If Muhammad does not respond to risperidone, I switch him to aripiprazole. If aripiprazole pushed him to 50%, I add attention medication. If one attention medication does not work, you never quit. I switch to other medications. Like blood pressure, ya akhi. We have 30 blood pressure medication, and you don't have to necessarily respond to the first medication. You might switch You might shift, you might combine, do the same thing. That is the key. Chronic administration. All the recent studies, and it's all explained in the article, showed chronic administration of antipsychotic resolve core sign and symptom. And there is a recent study called BART, clearly showed that. It's in the PubMed. Combining antipsychotic with ADHD medication and combining it with supportive therapy, and the key point, you never quit. In my simple, humble experience, 70% of the cases, patient who comes to me, if I try them with, according to my protocol, simple protocol, we secure 70%. You know what's my biggest problem? To convince the family to go on medication. What is my next second problem? To continue the medication. Because 6 months, the patient disappeared. Yesterday, patient, he did fantastic in aripiprazole, 2 of them, and then they disappeared. One year later came to me, oh, we stopped the medication. I told him, great, you need to find another doctor. 3 weeks ago, the same thing. I told her, you need to find another doctor because these need to be taken for 1 or 2 years, okay? Now, do you think is our information, is our study, even though it's a retrospective, simple, retrospective case study, do you think it is helping us, or is people paying attention to that? Okay, let me tell you something about statics. Altmetric is for 3 seconds. Altmetric is the company that track every single article. And at the time when I was looking at my article, they tracked almost 16 million. And you can see it, guys, on this link, 16 million. And our article is on the 97 percentile impact factor of medication ever, or article ever tracked. Why? Because it is not a repetition about probiotic, omega-3, oxygen chamber, all of the above or none of the above. I will not let you say it, and I'm done. Thank you very much.
Thank you.
You should. Thank you.
May I call Dr. Azhar Abdi to come on stage, please, to receive your plaque of appreciation.
Okay. First of all, I want to thank all of you who are staying till the late time till now. There is a very interesting lecture now from Dr. Iman Iskandar. She's a professor of neonatology in Abu Rish, Cairo University. And you will enjoy definitely this lecture, the modes of ventilation. And all of you are invited in gala dinner after 2 hours in around swimming pool. But we have to appreciate Dr. Azhar because she have some commitment. And thank you very much, Dr. Azhar, for coming and for very interesting lecture and appreciated. And Dr. Azhar, she is one of the team of the Pedia Dubai now. Every year we are enjoying a lecture from Dr. Azhar. She's interactive and very good lecture. So thanks a lot again and appreciation. Thank you.
Thank you so much.
Thank you very much. So we will call Dr. Abdullah to chair this session. And before we are starting this session, we apologize for Dr. Iman for late. I know that she is very busy, and I am really waiting the lecture for Dr. Iman to teach from her. And really, I enjoy to hear from her. Dr. Iman, she is very known professor, and she is one of the best in maybe not in the Middle East, in the world in the neonatology. And really, for myself, I feel this is the fruits of the conference. So thank you, Dr. Iman, and again, we apologize for the late, and we will enjoy. So Dr. Abdullah, she will introduce you. Thank you very much.
Professor Iman Laskanda is a professor of neonatology and pediatrics in Cairo University, member of Society of Pediatric Research Group, member of American Society of Pediatric Research Group, and member of the High Scientific Council of the Egyptian Board of Neonatology. So welcome, Professor Iman.
Can you hear me? I'm very honored to be with you this afternoon. I would have really loved to join physically, but it was impossible because of all what is happening around the world these days. But I really congratulate Dr. Sharif and Dr. Muhammad Ali and Dr. Al-Banna for organizing such a prestigious conference and encouraging everybody to attend. I hope next year I can join you physically. My talk today is going to be about ventilation modes in the newborn. I hope that we will be able to cover the different ventilation modes in the newborn baby, whether the control modes, the synchronized modes, or the dual modes. In a very short time, I hope I will be simple enough and get the message clear. For anyone working with tiny premature babies as we do, I always like to remind us all, including myself, that our oath means to do no harm, which means knowing very well how to handle our machines and to understand the disease pathology before deciding who we are going to treat with what. So let's start with the definition of a ventilator mode. And we talk about that, we mean the operating characteristics by which the ventilator will control how it will trigger inspiration and cycle into exhalation, whether to produce a mandatory breath, to support a spontaneous breath, or both. And this is different from dividing ventilation into invasive and non-invasive, because when you talk about invasive and non-invasive, it just means the way you are connecting the artificial airway to the natural airway. But you can, whilst doing invasive or non-invasive, have different modes of ventilation. A small introduction, as you all know, in neonatal medicine, we tend to use time-cycled pressure-limited ventilators. And the concept of that is to create a positive pressure at the airway that is higher than the pressure that is present in the alveoli. And so you get a pressure gradient, and as a result, air will flow from the high pressure to the low pressure point. This is done by having a constant gas flow and closing the expiration valve in the ventilator circuit so that the pressure rises up. At the end of a certain time, the expirator valve will open and the pressure outside will be much lower than the pressure inside, and gas flow will move out. And when there is a big pressure gradient, the gas flow is fast, and as the pressure gradient decreases, the gas flow will slow down. And this is a very important point to remember. Why did we choose or prefer pressure limited ventilation to volume ventilation in the tiny newborn because it helps us cope with problems with air leaks because we use uncuffed endotracheal tubes and because of the big volume that is present in the patient circuit that can oppose the action that we are trying to achieve. The big problem that faces us when we only use pressure limited ventilation is that once the compliance improves, if we are not very aware to lower the pressure quickly, the volume that we will push in with this pressure will be very high, increasing the risk of bronchopulmonary dysplasia. This diagram only shows that once you have a pressure gradient, high pressure outside, low pressure inside, there will be flow, and the flow will introduce volume inside and the alveoli will open. So what are the different ventilation modes? As we discussed, how are we going to start the inspiration? Either it will be by the ventilator on its own, and this is what we call a control mode. The ventilator just triggers the breath, and it's as if there is no baby there. If it's a doll, it will be the same way. Or the ventilator realizes that the baby is breathing and will provide partial support to this baby. Or the patient will be totally in control, ordering the ventilator to help him when he wants. This depends on what will trigger the ventilator. So if the ventilator is in the control mode or in one or two of the other modes, the main trigger for the start of a breath is time. So we say we're going to have 30 breaths per minute, which means that we're going to trigger a new breath every 2 seconds. But if the ventilator is responding to the patient breath, it has to receive a signal from the baby that tells the ventilator that the baby is about to breathe, and then it will respond to that breath by triggering that spontaneous breath by triggering a machine breath. As you can see in this picture, this is a ventilator breath that is decided by the ventilator. The time comes, and then you have a PIP for a certain time, and the pressure is pushed in until the end of the inspiratory time, and then the exhalation valve opens, the pressure comes down, and the volume within the lung goes out. And this is different from this breath. If you see, the difference is in this little thing. This is the spontaneous breath of the baby. The baby sucks the air in, so the movement is in the opposite direction, but this little suck triggers the ventilator to produce a same power of breath as the one here, but it is induced by the patient breath, therefore it is an assist breath. And this is different from the spontaneous breathing of the baby. And look here, the spontaneous breath triggered the breath and the breath started, but then at the time of exhalation of the baby, the ventilator also felt the exhalation and synchronized with the start of the breath and with the end of the breath. And we will go more into detail. So the control mode is a mode whereby the ventilator is acting as a pump of air at a preset setting by the operator. So the operator will set the maximum pressure, which is the peak inspiratory pressure. It will set the PEEP, which is the end expiratory pressure. It will set how many breaths per minute, which is the rate. It will set the inspiratory time and the amount of oxygen that's required. The flow in between the breaths is interrupted, and this is reserved only to babies who cannot or do not have any form of respiratory drive, whether they are apneic or whether they are on skeletal muscle relaxants. And this is not at all a mode that we normally use under any condition except if there is complete loss of respiratory drive. Because there was completely no respect for the patient's breath, and a better mode was introduced in the 60s, which was called intermittent mandatory ventilation. And this mode means that the ventilator realizes that the patient might need to take some breaths between the mandatory breaths that the ventilator is giving. And therefore, the big point of difference was that the gas flow is continuous. So if the baby takes a spontaneous breath between the ventilator breaths, he finds clean, fresh air that is well oxygenated. At the same time, the operator will set a predetermined number of breaths. The operator will set the pressure, the higher pressure and the lower pressure, and will set the FiO2 and will set the inspiratory time. Why is this a better mode than the control mode? Because it is respecting the spontaneous breathing of the baby. Therefore, it is maintaining the strength of the respiratory muscles and allowing better distribution of gas. But what if the baby is exhaling at the time that the ventilator is giving an inspiration? This will lead to asynchrony, and this asynchrony will lead to air trapping and increase the risk of pneumothoraces, and will lead to an ineffective breath, because the ventilator, when it's pushing the breath in, the baby is pushing the air out, so the breath will be ineffective, and this will lead to variable tidal volume. One time good tidal volume reaching the baby, the other less tidal volume, asynchrony, and very high risk of either ineffective ventilation or ventilation-induced lung injury. And this diagram shows the machine breath. I set the ventilator to 30 breaths. So every 2 seconds, a new breath starts, the same inspiratory time in all the breaths, and the same interval between the breaths. But look at this, the baby is breathing, and his breath is not related at all to the breathing of the ventilator. So yes, the ventilator is helping in some breaths, but there is asynchrony and sometimes ineffective breaths, and sometimes a severe augmentation that might lead to high pressures and ventilation-induced lung injury. So the idea came to synchronize. Why don't I have an intelligent machine that will feel the baby when the baby is about to breathe and will coordinate with the spontaneous breath of the baby? So this needed to the need to detect the baby's breath, which is to find a mean by which the baby can trigger the ventilator. And once this trigger happened, to make the ventilator very responsive so that in milliseconds it would respond by giving a mechanical breath. And how can the machine trigger? There are several ways. At first they said, okay, you can put a sensor on the abdomen. And this, whenever the baby takes a breath, the abdominal wall will move and it will trigger a breath. This was sensitive to breathing, but it was not specific. If the baby got a hiccup, it was going to trigger a breath. So it was not very, very specific. And so they said the most specific thing is either the airway pressure or the airway flow. And the one that is the mode of triggering that is preferred by most neonatologists is to put a flow sensor at the end of the endotracheal tube, so that when the baby starts to suck some air in, the flow of air moving in will move against the sensor that is placed at the end of the endotracheal tube, and there are various forms of sensors. How does the trigger act? The trigger has a trigger sensitivity, and the trigger sensitivity is graded. The higher the sensitivity means to do a tiny breath, and this will trigger the ventilator. So if the baby needs to do a small effort, it means that the trigger is very sensitive. So if you want a high sensitivity of your trigger, set it on the low point. If the grading is from 1 to 9, go down to 2 or even 1 if you need to, although we don't prefer 1 because it makes it liable to auto-triggering. If it is in liters, choose the small amount, 0.3, 0.4 liters. Don't choose 2 liters and ask a baby to trigger a machine. So the higher the number you choose, the blunting you make for the trigger, the less breaths this machine will be able to help the baby. Now, what's the trigger window? The trigger window means that the ventilator will wait for the stimulus given by the spontaneous breath of the baby, provided you set your trigger correctly, until a certain point. What is this certain point? This certain point is if it will interfere with the preset breath that you have put. Let us take an example. If you are going to use a synchronized mode of ventilation, let's say synchronized intermittent mandatory ventilation. So you will set 30 breaths per minute. And you will set your trigger sensitivity to 0.3. So what you are telling the machine is, if I ask you to deliver 30 breaths per minute, you can only wait 2 seconds and have the breath, or else you will not give the rate that I asked you for. And therefore, the machine will wait for the baby to trigger, for the baby to trigger. If the baby triggers after 1.5 seconds, then the machine will get the breath synchronized with the baby's breath. But if the machine approaches the 2 seconds and the baby has not taken the breath, then the machine cannot wait any longer, and it will trigger a breath to maintain the rate that you as an operator set on the synchronized intermittent mandatory ventilation mode. When you have a new baby admitted to your intensive care, premature, 1,200 grams, distressed, and needs a mechanical ventilator, is this the mode that you should choose? For me, I don't understand when people choose this as an initial mode in a very sick baby. Why do I want to help him with some breaths and not help him with the other breaths? Why don't I help him as much as I can until he shows me that he is ready to start weaning? And therefore, at that point, I prefer to choose another mode. And this is the assist control mode, which on some ventilators is called patient-triggered ventilation, and on other ventilators is called synchronized intermittent positive pressure ventilation. And this is a huge problem with ventilation modes. You find different names for the same thing in different machines, and that is why it is very important for you to study your machine well and understand which mode means what. So in assist control mode, you set as an operator everything except the rate of breathing. What decides the rate of breathing or the respiratory rate on the ventilator? The baby decides the respiratory rate. But take care, if you set your trigger not to be sensitive to that baby, you will be suffocating that baby, because the baby will not be able to trigger except a small number of breaths because you have a wrong setting on your trigger. So if you want the assist control mode to work, and this is a very good initial mode to support your premature baby, and we can add something to it when we discuss the dual modes, you have to set your inspiratory time, which is the pressure, which is the PIP, set the peak, set a backup rate in case your baby becomes apneic, but very, very important to set the trigger sensitivity according to your baby. If your baby is a tiny preterm, please set your trigger sensitivity to 0.3 or 0.4. Don't set it to higher numbers that will make the baby not be well supported. But in assist control mode, you also set the inspiratory time. So the baby is deciding the respiratory rate, but you are deciding the inspiratory time because you need the alveoli of this baby to open up. So if you look at this diaphragm, you can see in synchronized intermittent mandatory ventilation, the ventilator is waiting for the baby to take a spontaneous breath as long as the baby takes it in the time window allowed for the ventilator to maintain the rate that you set. If the ventilator waits and waits and waits, but the baby does not take the spontaneous breath, then the ventilator will trigger in order to maintain the 30 breaths per minute that you set. What happens in assist control? In assist control, you set your trigger sensitivity to be sensitive to most of the baby's breath, and so the baby will trigger the ventilator soon enough. When will this happen in assist control? If the baby becomes apneic. The ventilator will wait and wait and wait, but for a long time, which is the time of the apnea rate that you set. For example, 30 breaths per minute. So if it's 30 breaths per minute, or 20 breaths per minute, or 25 breaths per minute, the ventilator will wait for that time. If the baby doesn't take a spontaneous breath, the ventilator will trigger. How is that different from another mode, which is called the pressure support mode? In pressure support mode, the operator sets the pressures, but the baby is in control of everything that is related to the timing. The baby is in control of the number of breaths per minute, which is the respiratory rate, and you help him with that by setting the correct trigger sensitivity. But the other thing is that the baby will also decide his inspiratory time, meaning that you will not set a certain time for the inspiration. The baby will define his own inspiratory time by another thing that is set, which is called the flow cycling criteria. And what I mean by that is the baby can detect or give a signal to the ventilator when he wants to start the breath, and the ventilator will follow, and when he wants to end the breath, and the ventilator will follow. And if we look here, this is the start of the breath by the baby, the spontaneous breath. So the ventilator triggers to the preset pressure that I put. And then once the baby starts to end the breath, as you see here, the ventilator will sense and will end the breath at the same time. So one time you will have a longer inspiratory time because the baby took a longer time, and one time you will have a shorter inspiratory time because the baby took a shorter time. So if we compare the pressure-triggered ventilation, the patient-triggered ventilation, or the assist control with the pressure support ventilation, this is an initial mode, this is a weaning mode. Here, the patient initiates the breath and decides the respiratory rate according to the trigger sensitivity. But the ventilator is the one who will decide the duration of inspiration according to a preset inspiratory time. So there is synchronization in the beginning of inspiration, but there might not be synchronization at the end of inspiration. As opposed to the pressure support, the patient decides when to start the breath according to trigger sensitivity and when to end the breath according to flow termination criteria, which we will discuss very soon. So the baby decides the respiratory rate, but if the baby is apneic, the operator sets a backup rate. Here also, the baby decides the respiratory rate. The machine limits the pressures. I put the set PIP and the set PEEP. Here, the machine has to be set to provide enough inspiratory time, because since the baby is going to decide the inspiratory time, when his compliance improves, his inspiratory time will become longer. So if you give him a very short inspiratory time, you are cutting the inspiratory time earlier than the baby needs. So in pressure support ventilation, you set a max inspiratory time. You don't set an actual inspiratory time because this is what the baby decides for himself. So how does the baby end the inspiration in pressure support ventilation? This is the difference. In the normal breath, like in synchronized intermittent mandatory ventilation or in patient-triggered ventilation or assist control, you set an inspiratory time. So once the breath is triggered and the patient is pushed with pressure to your set PIP, the pressure lasts for the duration of the inspiration. And then when the exhalation valve opens after the set time, because it's time cycled, then the pressure will end and exhalation will start. What happens to the flow in time cycled ventilation? When the pressure gradient is very high between outside and inside, the flow will be very rapid to fill the alveoli. As the alveoli fill up, the pressure gradient will decrease, because as the alveoli fill up, the pressure is rising inside, so the difference between inside and outside is diminishing, so the flow will decrease and decrease and decrease. And look here, it's a period of no flow, no gas exchange, despite that the inspiration has not ended. Whereas in flow termination criteria, the baby tells the ventilator, and the ventilator knows that the baby is ending his breath because the operator sets a point, a percentage from the maximum flow. يعني أنا بقول, I tell the ventilator, if the maximum flow is 10, for example, when the maximum flow goes down to 0.5 or to 5% of the maximum flow, please ventilator realize that the baby is ending his breath, because we said as the pressure gradient decreases, the flow decreases. طب I tell the ventilator, when the flow decreases to 5% of the maximum flow, end the breath. And look here, when the flow decreased, the ventilator shut off the PIP, the exhalation valve opened, and the inspiration ended. And this is how you set flow termination criteria. You tell the ventilator, once the flow goes down to 5% or 10% of the maximum flow, this is the flow termination criteria that you will feed to your ventilator. This is the point at which the ventilator will open the exhalation valve and start the inspiration. So what happens if you have a leak? If it's a small leak, you have to set your flow termination criteria above that point, or else the ventilator will not realize that the breath is ending. So if we look here, this is the IMV mode, which is not synchronized and does not realize the patient effort. This is the SIMV. I'm synchronizing the beginning of the breath, but I'm giving a set number of breaths per minute that I decide. I have set the rate. If the baby meets with me, fine. If the baby lingers, I am going to give a breath because I have to respect the rate that I set on the ventilator. In assist control, the baby decides the rate. But once the baby starts, I give a set inspiratory time that I determine. So the number of breaths is determined by the baby. But look here, the baby ended the inspiration while the inspiration of the machine has not ended. Whereas in pressure support, I am trusting the baby more. The baby is doing well. I want to follow him more. The baby decides the rate, and the baby decides the inspiratory time by the flow termination criteria. Look here, the short inspiratory time, the ventilator followed. Longer inspiratory time, the ventilator followed. This is pressure support ventilation. It is a weaning mode. If we revise what we said, in SIMV, preset rate, and the baby takes spontaneous breaths in between. In assist control, if you have a good trigger sensitivity that feels the baby, you help the baby with every breath, but with the same inspiratory time. In pressure support ventilation, the baby decides the rate and the baby decides the inspiratory time. So to move on, the recent mode, which is not only depending on the pressure, because now we realize that pressure is that the ventilator-induced lung injury depends on volume more than pressure. I am giving a certain pressure. This pressure is good if the lung is stiff, but once the lung compliance improves, this pressure will push 20 milliliter instead of 10, and I will cause barotrauma and voliotrauma, and I will cause ventilator-induced lung injury. So someone said, let us combine a mode that will allow us to use a certain tidal volume to guide our pressure. Since we are using a flow sensor and we can measure the amount of volume going into inhalation and coming out of exhalation. So the volume guarantee acts in this way. I, as an operator, set a certain tidal volume. I say, okay, my baby is 1 kilo. I want to give him 5 milli per kg. And I set a certain pressure. I say, I'm going to put a PIP of 18. So the baby starts to take breaths. The 18 pushes in 5 milliliter of air. So this is the set tidal volume. Both of us are satisfied. Then the baby improves, the compliance improves. So the 18 that I pushed in pushes 7 milliliters of air instead of 5 milliliters. This is a bigger volume. And what happens at that point? A trigger from the baby to the ventilator tells the ventilator, because the tidal volume is measured, that this is too much of a tidal volume. So automatically the ventilator will change and will lower the pressure provided in the next breath. So let's see what happens. The ventilator aims to deliver a preset tidal volume. and you set a maximum PIP, not a specific number, because you want to give the ventilator space to move up and down in order to achieve the volume that you set. So if the volume delivered is correct, no change in the pressure that you set will happen. But if the baby receives less volume, the ventilator will increase the PIP in the next breath, but within the limit that you put for this baby. It will not exceed the limit, because if the baby bends his neck, it will not deliver the amount. And if he straightens again and you will have taken an action and the ventilator will have raised the pressure, it will cause a problem. So always you set the pressure that the baby is going to be using, and you set a maximum pressure that is 2 or 3 centimeters water above that, so that the ventilator can move within that range to improve the tidal volume achieved. In pressure limited ventilation, if the compliance improve, you have a risk of barotrauma. But if you use a volume guarantee, you will adjust this pressure and you will prevent the volutrauma and the barotrauma. And this is the concept. You select a certain PIP and PEEP and a maximum limit for your pressure. The ventilator will deliver the breath. If it is the same, no change. But if it is not the same, the ventilator will adjust higher, but within the limit that you set, not superseding, and lower. And since it adjusts lower, then it is a mean of weaning the ventilator automatically according to the improvement of the baby. The important thing in guaranteeing a tidal volume is that in the initial phase, when the baby is still very sick, if you gave surfactant and the compliance improved, and after a few minutes the compliance decreased again, if you are using pressure ventilation, the result will be the baby will receive ineffective ventilation because smaller tidal volume will enter. But if you are using a volume guaranteed ventilation, it will adjust the pressure. It will increase the pressure to deliver the same tidal volume, provided you do not exceed the limit. The recent Cochrane review about the use of targeting a certain volume in addition to your pressure controlled mode has proven to reduce the rate of death, the number of pneumothoraces, has reduced the duration of ventilation, and is predicted to reduce bronchopulmonary dysplasia. So it is actually the first thing in a long time that is helping us reduce the risk of bronchopulmonary dysplasia. Does it have limitations? Yes, it does. If you have a big leak, you cannot depend on volume, because you are going to mix the ventilator up and you will get either very high or very low setting. If you set your PIP too low, if I want to deliver 5, and I set my PIP at 14 and my limit at 17, and this baby needs 19 or 20, and you don't follow your alarms, this baby will get ineffective ventilation because he will not be able to achieve the set tidal volume that you want to guarantee. So make sure your settings are correct. Just to highlight a new mode, this mode is the NAVA, which is the neurally adjusted ventilatory assist. Because even in volume targeted ventilation, the support you give to the baby is reduced when the baby makes an effort. Because when the baby makes an effort, the ventilator realizes that he does not need to make the same effort. And so if your settings are not correct, you can exhaust your baby. In this new mode, it provides a proportional assist. What does that mean? You have electrodes that are introduced at the end of a nasogastric tube that realize the minute the diaphragm starts to contract to start the breath, so they synchronize very well, and they realize the extent to which the contraction happens, so they can provide assistance that is equivalent to the amount that the baby truly needs. So it is a momentary adjustment. So this signal will represent the central respiratory drive, and the signal will provide the time at when we are going to start the breath. And then we will know when to cycle off the ventilator, and it is supposed to provide very, very good ventilator synchrony and help as much as you can according to the baby's needs. But till now, we don't have sufficient evidence to show that it actually reduces bronchopulmonary dysplasia, but the predictors are that it will be okay. So I will terminate. Ventilation modes comprise only.
2 more minutes.
Yes, I'm finishing now. This is the last slide. Ventilation modes comprise only a small part of operating a ventilator. To achieve the best possible outcome for your patient, you have to remember all the details and not only focus on buying ventilators with new modes. You have to be a good clinician, you have to have good nursing, you have to understand your patient, his pulmonary function and pathology, and you have to understand all the concepts of the mechanics of ventilation and choose the correct mode. And my take-home message is you have to understand the mode of the ventilation, of the ventilator that you are using, and you have to understand which mode to use when. And assist control is an excellent initial mode for ventilating the preterm. And when you use volume targeting, it will make your service more superior and will reduce the risk of ventilation-induced lung injury. Please keep updating yourself and keep learning and keep understanding your machines to be better operators. And I hope you all come to visit us at our hospital, Abu Rish Hospital, which is the oldest pediatric hospital in the Middle East. Thank you very, very much.
My friends, they are trying to do something in something only virtual as everybody, but I don't want to be like everybody. I want to be some problem from all the something of important now we are talking from virtual. So this is last night I saw him when we are playing the Jumu'ah, in the conference here in intensive care. So just about to start for a long time, we are not, now he's promoted as associate dean, so he cannot, thanks to him, he's really programs coming, everybody we are appreciating present, especially also to Nasser, they are coming from Omdar, and I think it will take 4 messages for swaps, so this is all. So here we have from the clinical to have special occasion for 1 month. So God bless her. And we are looking for something more after that. So today we will make so in this rappel, we get the rings for the people we are sitting down, and we will make rappels. Everybody will win. One will big size, one is medium size. So this is just a souvenir. I know that you can buy all this, but this is souvenir from the. So we will make rappels now. And we will start by this winner by Pedia Dubai. So we will invite Dr. Abir to come to be here. So this first winner, he will win an latest level. دكتور عزت. Thank you. A lot of people invited after the 1.5 or 1 hour.